Assalamu alaikum, ladies and gentlemen. I am Dr. Noor Mariam and I am honored to serve as co-moderator of Rheumacon Pakistan 2026 along with Dr. Zainab Malik and Dr. Maham Dilshad. It gives us great pleasure to welcome you all to 7th Annual International Rheumatology Conference, where we are joined by an esteemed panel of speakers and experts. Rheumacon Pakistan is a premier annual international conference dedicated to advancing the field of rheumatology and clinical immunology, organized under the auspices of the Department of Rheumatology and Immunology, which was established 27 years ago. The initiative reflects a long-standing commitment to academic excellence, clinical innovation, and community service. Since its inception, the department has been actively serving the masses and has played a pivotal role in training numerous rheumatologists who are now practicing across the country, contributing significantly to the management of autoimmune and musculoskeletal diseases. Continuing this proud legacy, Rheumacon Pakistan marks the 7th International Rheumatology Conference, bringing together distinguished national and international experts, clinicians, and researchers. The conference serves as a dynamic platform for sharing cutting-edge research, discussing evolving international guidelines, and addressing region-specific challenges in rheumatology. With a strong focus on emerging therapies, evidence-based practices, and multidisciplinary collaboration, Rheumacon Pakistan aims to enhance clinical expertise and improve patient care standards. Join us in this journey of learning, innovation, and excellence as we work together to improve patient care standards. The conference today will comprise 3 scientific sessions featuring a total of 10 talks and 2 panel discussions. The first session will include 3 talks, followed by the inaugural ceremony. The second session will consist of a panel discussion along with 3 talks. The third and the final session will include 4 talks, a panel discussion, and the closing ceremony. Each session will conclude with an interactive question and answer segment. We sincerely thank you for being a part of this event and hope that you find the conference both insightful and rewarding. Moving on to the first talk of the day. Musculoskeletal injuries involving the lower limb represent a significant and often underappreciated contributor to morbidity, particularly among physically active individuals and the aging population. In context of rheumatology, differentiating sports-related injuries from inflammatory or degenerative conditions is essential to avoid misdiagnosis and ensure appropriate management. Early recognition, accurate assessment, and targeted rehabilitation strategies are therefore crucial in restoring function, preventing chronic disability, and optimizing patient outcomes. It is a privilege to introduce Dr. Misam Afzal, a distinguished rheumatologist with extensive international training and expertise. He holds MRCP and FRCP, master's degree in rheumatology, and specialty certification from Royal College of Physicians, UK. As the head of the Department of Rheumatology at Al Aleem Medical College and Gulab Devi Hospital, Lahore, Dr. Afzal has been instrumental in advancing rheumatologic care and education. We look forward to his valuable insight on this important topic. Please warmly welcome Dr. Misam Afzal on the stage.
Assalamu alaikum. Okay. So thank you very much for giving me the opportunity to discuss this interesting topic, lower limb sports injury. I have no conflict of interest. So when I was given this topic, I was slightly surprised at why a rheumatologist should be speaking about the sports injuries. But then I realized that actually we see many of these patients in our clinic, in our daily practice. And the real challenge is not actually a sports injury, it's the overlap between the mechanical and inflammatory conditions, which makes the assessment far more important than it appears. We all know that about 60 to 80% of sports injuries are the lower limb injuries, and out of those, ankle injuries are the commonest. So sports injuries, they are not like a single event, it's a cumulative event. Repeated microtraumas, uh, delayed repair, or delayed, because of the delayed repair, its degeneration gets worse, especially in hypovascular sites like the ankle. These injuries are quite cause the problem. So among the ankle injuries, the commonest is the lateral ankle sprain. And it happens, you see these type of injuries normally in the sports like a football, when a sportsman awkwardly land on another sportsman's foot or on an uneven surface, causing the hyperflexion and inversion of the foot. It affects on the ligament like anterior talofibular ligaments. Okay, now at the knee, again mechanism guides the diagnosis. An ACL injury is typically non-contact and pivoting injury. So you see these type of injuries normally in the sports like football, basketball, and skiing and in tennis. In contrast, MCL injuries normally due to the valgus stress from the contact, such as tackling from the side. So commonly we see these types of sports injuries like rugby, wrestling, and hockey. Okay, let's start with the case presentation. This is a 25-year-old football player presents with an inversion ankle injury during the play, and he immediate lateral ankle pain, but was still able to bear the weight. On examination, there was a localized tenderness at the lateral side of the ankle and on the ATFL side, and positive drawer test. And X-rays are normal and the range of movements are normal as well. So diagnosis will be the lateral ankle sprain. Up till this point, the diagnosis is quite clear. And what do you think, how will we make the diagnosis? Do we use any sort of imaging or anything to diagnose the ankle sprain? Do we? No. The ankle sprain is normally a clinical diagnosis on the basis of the mechanism and also the drawer test, instability test, and obviously in this case, patient has a range of movement of the foot is fine. We don't need any sort of imaging at this point. However, not all ankle sprains are simple, so sometimes situation changes. This case is actually taken from the BMJ publication. Uh, so this patient's symptoms gone worse quite rapidly, pain worsened, and then swelling worsens as well, and pain was out of proportions, and neurological signs appeared, and a compartment syndrome was suspected at that time. A compartmental pressure was checked, which was very high, and this patient required a urgent fasciotomy. Now, after a period of recovery, patient went home, and after a few months, patient presented again with the worsening of the symptoms without any clear history of trauma. Now the symptomatology changed. Early morning stiffness, more than 30 minutes, ankle pain, bilateral heel pain, improves with physical activity, and was a gradual onset. What do you think that what's going on now? The symptomatology changed. On examination, Achilles tendon was tender at the site of anthesis, and also the plantar fascia, CRPSR was raised, HLA-B27 positive, R effector anti-CCP was negative. So obviously all started from the mechanical injury, and now things gone to the inflammatory. So the diagnosis of spondyloarthritis was made. Now here, what begins with a straightforward mechanical injury may later reveal an underlying inflammatory process. No, the thing is that we don't know that whether this patient had this underlying inflammatory process while he had this mechanical injury, or it was triggered because of the trauma or surgery, or it may have developed later on. But from patient's perspective, all started from the injury. So that's how the patient presents to a rheumatologist. They always come, they will tell you that we had an injury and that's why we have this problem. Yeah? HLA-B27 positivity doesn't mean always that patient got ankylosing spondylitis. It can be negative it can be positive in normal population, about 5% of the patients. Okay. So when it is not a sports injury, when the symptoms are persistent, when the pattern is atypical, and when the recovery is not as expected, then it's not a bad luck. That is the diagnosis trying to tell you something. So always, when you see something going on the wrong direction, we always need to rethink the diagnosis. And why the spondyloarthritis or any inflammatory condition will mimic the sports injury? Because it's the same anatomical position like heel, ankle, knee, and often there is no clear history of trauma. And normally in the early stage, the disease is more localized rather than systemic. And patients are normally young and active. So when we suspect any inflammatory arthritis like spondyloarthritis, we need to actively look for these clinical patterns like enthesitis, inflammatory back pain, asymmetrical oligoarthritis, dactylitis, and associated diseases like psoriasis and inflammatory bowel disease, and extra-articular manifestation like uveitis. So spondyloarthritis are subdivided into axial spondyloarthritis and peripheral spondyloarthritis, and there's quite a lot of overlap among them. And that's why they mimic the sports injury. So the core lesion in spondyloarthritis is enthesitis. And from the rheumatology perspective, enthesitis at the site of Achilles tendon and plantar fascia, they are the most important. And if you see any patient with the persistent heel pain and not improving, then we don't only label this patient as an overuse injury, we should think about enthesitis. And enthesitis is not only a feature, it's a hallmark of spondyloarthritis. Okay, so these are the common site of enthesis. But from the rheumatologist's perspective, the most important are Achilles, plantar fascia, patellar tendon, quadriceps tendon, and iliac crest. So now, when our clinical bit is a little confusing, we take a help with the modalities like ultrasound. So here you can see normal tendon, which is showing the fine fibrillar pattern, sharp edges inserting into the bone. And there are no Doppler activities. In comparison to that, this is the mechanical tendinopathy, and you can see the tendon is quite thickened and has quite a lot of hypoechogenicity, loss of fibrillar patterns. And this one is a normal tendon, which is normally in an oval shape with a good fibrillar pattern. And here, this is a tendinopathy, thickened tendon with a loss of fibrillar pattern. Now, this is again like a degenerative tendon, and we all know that most of the degenerative tendons, they don't show Doppler activity. However, because of the chronic disease, there can be a new vascularization, and Doppler signal can present because of the new vascularization, and it is not actually a true inflammation. In comparison to that, this is spondyloarthritis-related enthesitis, and here you can see this big enthesophyte. This is a result of chronic inflammation because of the spondyloarthritis. And on the bottom slide, you can see enthesitis with a Doppler activity at the site of insertion. So this is the typical ultrasound of the spondyloarthritis. But keeping in mind that this, like enthesophyte, is not only specific for spondyloarthritis, can happen into the aging process or with the overuse injury or degenerative process. When we diagnose this spondyloarthritis, we don't only see the Doppler activity. This is a combination of the symptoms, isn't it? So Doppler activity, enthesitis, enthesophytes, or erosion formation, and we also see this clinical sign and symptoms. So this is a summary of this, that mechanical tendinopathy primarily affects the tendon substance with degeneration, loss of fibrillar pattern, and sometimes Doppler within the tendon due to new vascularization. In contrast to that, spondyloarthritis, it is normally enthesitis and Doppler signal on the insertion site with the enthesophyte formation and also the erosion formations. So when I see such patient, how I approach, I take a history to see if this patient has a history of trauma, or it is an insidious onset, or the pattern was localized, or it is multi-system, or symptoms are activity related or versus inflammatory. So all that we have to see during examination. The pain is in the tendon and in the enthesis. Obviously, image guides the diagnosis, but it is the clinical bit is the most important. So when plantar fasciitis isn't a plantar fasciitis, this is a story published in this newspaper, which is known as creaky joints. This is a story about a patient who initially presented with a bilateral heel pain. And it took her like 18 months before she saw like 9 different doctors. before the diagnosis of psoriatic arthritis was made. And it was made only at the end when one of the doctor thought that this is out of the proportion symptoms. So he investigated, took a further history and found this patient got psoriasis. And this patient now advocates that not all foot pain is mechanical. Patients with psoriasis should be aware of the psoriatic arthritis. And persistent symptoms, if there are persistent symptoms not improving, you should question it about the diagnosis. Now this is case number 3. This is about 49 years old male who, while playing, had a Achilles tendon rupture, and then he had a surgical repair, and he presented with the worsening of the pain, warmth, and discharge from the incision side. He had a couple of incision drainage done, and the repeated course of antibiotic. All the time the cultures were negative. However, his ESR, CRP is raised. Now, what do you think? If multiple cultures are negative, repeated courses of antibiotic, can it be an infection? So we already need to revisit the diagnosis all the time. So persistent sterile infection, atypical post-operative course, and no organism identified. A further history was taken, and we found that it is actually another published case. It shows that patient has a history of high protein diet, alcohol use, and renal stones. And what do you think now where it's going? Gout. Yeah, that's correct. So this is the picture taken from the same journal. You can see another incision drainage done, and you can see this chalky material coming out from here. This patient has a dual energy CT scan done, and it's showing this color coding, which is a urate crystal in the Achilles tendon. And the histopathology confirmed these are the tophies you can see on the histopathologies. So the patient was treated as gout. He was referred to the rheumatologist. So you can see how the picture can change. Start from the like a sprain, and then suddenly things can change, and we have to revisit the diagnosis. That's a complication of that's how there is a lot of overlap between the sports injury and the inflammatory problems. So the key learning point here is that inflammatory condition like gout can mimic the infection, and if the cultures are repeatedly coming back negative, we always rethink the diagnosis. And Achilles tendon is a common site of the diagnostic confusion. Now this is case number 4. That's a 42 years old recreational football player, acute inversion ankle injury, and he get the pain in the lateral ankle site. Initially improved within 3 to 4 weeks, and then he came back to activity without any rehabilitation. So what happens when patient not get the rehabilitation on time and not give the sufficient recovery time to repair? Things can go in the wrong direction. So his pain worsened with the activity, sense of giving way, instability, difficulty on uneven surfaces, and there were no inflammatory symptoms at this time. There was localized lateral ankle tenderness, positive interior draw test, positive Taylor tail test, and MRI showed ATL, FL, and CFL rupture. So this is the case of chronic lateral ankle instability. And secondary to repeated trauma, inadequate rehabilitation, and mechanical structure failure. So this is the 4th case. You have seen already 3 cases, and this one is the 4th case. And while I was preparing this presentation, I received a text message from my neighbors. One of the son-in-law, he had an injury 10 years ago, and he sent me a video, and I have taken the consent from them. And now I'll show you this video very according to the topic.
मेरा ना आज से 10-12 साल पहले यूनिवर्सिटी में फुटबॉल खेलते हुए ये यहाँ पे फ्रैक्चर हो गया था, और उसके बाद प्लास्टर भी लगा था एंकल पे। तो फिर बाद में ये होता है कि थोड़ी सी नाहमवार सतह आती है ना, तो ये पाउंड ट्विस्ट हो जाता है इधर से, और फिर वो जगह सूज जाती है। पहले तो ये कभी कभार हो रहा था, लेकिन पिछले 3-4 माह में 3 से 4 दफ़ा ना इधर से ये पाँव ट्विस्ट हो गया है कि सड़क थोड़ी सी ऊपर नीचे होती है तो ये पाँव इम्बैलेंस हो जाता है और पाँव मुड़ जाता है, जिसकी वजह से ये पूरी जगह सूज जाती है और काफ़ी दिनों तक ना मैं गर्म पट्टी बांध के बैठा रहता हूँ।
तो इसमें ये कह रहा है कि जब मैं चलता हूँ तो बार बार मेरा पाँव मुड़ जाता है, तो दिस इज़ अ क्रॉनिक इंस्टेबिलिटी। सो उसका फ्रैक्चर जो है वो 10 साल पहले हुआ था और उसके बाद मेरा ख्याल है वही जो रिहेबिलिटेशन प्रॉपर तरीके से नहीं हुई, तो अब इंस्टेबिलिटी ऑफ द टेंडन्स है जिसकी वजह से सारा कुछ हो रहा है। So in conclusion, most lower limb sports injury are mechanical, but not always. Always reassess symptoms if it like persists beyond the expected healing time. The expected healing time जो है वो 4 से 6 हफ्ते या मैक्सिमम 3 months है। अगर उससे ज़्यादा ना हो तो हमेशा revisit करें डायग्नोसिस को। और we always need to understand what is the mechanical symptom, what are the inflammatory symptoms, and if a sports injury is not improving, it's not a bad luck. It's a signal to reassess the diagnosis. Thank you.
Moving on to our next talk, the management of rheumatoid arthritis has evolved remarkably, with disease-modifying anti-rheumatic drugs enabling sustained remission in many patients. However, the question of when and how to safely taper therapy remains a critical clinical challenge. Balancing the risks of disease flare against medication-related adverse effects and healthcare costs requires careful, evidence-based decision-making. Optimizing tapering strategies is therefore pivotal in achieving long-term disease control while minimizing patient burden. We are honored to welcome Professor Dr. Babar Salim, an eminent figure in rheumatology with distinguished academic and clinical career. Dr. Babar holds FCPS qualification in both medicine and rheumatology and a master's degree in pain management. He is also a fellow of American College of Rheumatology. Currently serving at Fuji Foundation Hospital, Rawalpindi, Professor Salim is widely respected for his contributions to rheumatology practice and education. We eagerly anticipate his expert perspective on this subject. Please welcome Professor Dr. Babar Salim.
Assalamu alaikum ji. I hope you can hear me loud. Thank you, Dr. Noor, for such a lovely introduction. You reminded me of my mother-in-law. She used to praise me like this. Thank you so much. Ladies and gentlemen, thank you so much for the invitation. I would like to thank Dr. Aflag, Dr. Faisal for inviting me. Indeed, it's a privilege, honor to be here and standing in front of you guys. And the topic I'm going to be, I've got no disclosures and this is the place where I work, it's Fuji Foundation Hospital, Rawalpindi. And the topic I'm going to be talking about is that how to taper or stop disease-modifying drugs in rheumatoid arthritis. And well, before I move on to my objectives, the point here is that we will not be talking about the patients who have an active disease. So I think that most of us know how to treat an active disease or a moderate disease or a low disease active. But I'll be talking about those fraction of patients who are in complete remission, who are completely fine, and they have a question, for how long do we have to take the medicines? So this presentation is basically, so keep this in mind, we are talking about only those patients who are in sustained remission. So these are going to be my 4 objectives. I'm going to talk about what is a sustained remission. We know that what is remission, but what is sustained remission, I'm going to talk about that. Tapering, how to be done, why it is important, and post-tapering relapse, is there any entity which is known as post-tapering relapse? Yes or no, we're going to discuss about that. And at the end of the day, we're going to conclude my all these objectives. So, by definition, by the ACR and EULAR, the remission is defined by at least for 6 months or more. So you need to know whatever the tool you are using. You're using CDAI score, DAS28, Boolean score, whatever the tool you are using, but the patient has to be for at least more than 6 months, and the steroids must be stopped at that particular time. So that's the most important point, because sometimes the patients say that patient is in sustained remission and the patient is taking steroids. So we won't be calling that a sustained remission. So by definition, sustained remission is any patient who is not taking steroids for at least 6 months, not requiring any painkillers, there is no evidence of synovitis, and he is in sustained remission for at least 6 months or more. So if we talk about the evolution of these criteria, they started back in 1995, starting from DAS28, RAPID-3. Now we have a very recent one, which is known as the Boolean 2 criteria. If you see the Boolean 2 criteria is a less stringent criteria as compared to Boolean 1 criteria, because they have increased the patient's global assessment from 1 to 2 without compromising on the radiographic progression or on the health assessment questionnaire. The point here is that why they have done this. The reason is that they wanted to include more patients into the umbrella of sustained remission. So when they did this, they increased the figures from 14% to 20%. So without compromising on the health assessment questionnaire or on the radiographic progression. So now we need to know how much percentage of patients are in sustained remission. So, well, it partly depends upon which particular tool you are using. For example, if you are using a DAS28 to check for a sustained remission, which is not a very good tool to assess sustained remission, around 30% of the patients are going to be in sustained remission after a period of 6 months. But if you're using a Boolean criteria, which is around 20% of the patient would be in sustained remission. So the cutoff story is around 20 to 30% of the patients are in sustained remission. So this presentation is going to be about that number, that 20 to 30% of the patients who are in complete remission. We are going to be talking about those groups. We are not talking about the rest of the patients who have an active disease. We all know that we have to treat an active disease. So this presentation is basically targeting that cohort, that small number, around 20 to 30, who are in sustained remission, who keep on asking you that, Dr. Saab, I come to you, you don't do anything, you check my test and you take a fees. You don't do anything. So, nor you're reducing my dose, nor you're increasing my dose. So this presentation is basically for those patients. So the next question is DMARD-free remission possible? How many of you think that if we stop the medicine, the disease is not going to come back? Okay, how many of you think that disease is going to come back? Yes, you're right. Well, we'll discuss about it. You need to know the definition of DMARD-free remission. So what happens is, first of all, the patient comes to us on the green part, you treat rheumatoid arthritis. And with the passage of time, you target and the patient becomes into remission, for example. And then you plan, let's stop it. You don't do it in general, but for example, if you stop the DMARDs, and after stopping the DMARDs, patients remain in remission for at least 1 year. So patients without on DMARDs for at least 1 year and still remaining in remission, that is known as DMARD-free remission. I want you to know this definition because we are going to be talking about this definition in the next couple of slides. So DMARD-free remission is no DMARDs in an RA patient and the patient is perfectly fine. So is it possible or not? Well, let's see. Well, this is the data from the two very, very important cohorts. One is the Leiden Early Arthritis Clinic, and the other one is the T-REACH cohort. And when we talk about rheumatoid arthritis, we always give a lot of respect to these cohorts because they have got a very stringent criteria to include in their patients. So those patients, they say that any patient who requires biologics ever in their life, ever in their life, DMARD-free remission is not possible. They could not find a single patient who ever required a biologic in their life, and when they stopped the medicine, it had a relapse. So that is the point number one. However, the patients who do not require biologics or targeted synthetic DMARDs, probably the DMARD-free remission may be possible. And how much it is possible, we're going to discuss about that. Well, this is the retro trial based on sustained remission by the end of 12 months, what they did was they divided into 3 groups. In one group, they continued the DMARD, and by the end of 1 year, they saw that around 80% of the patients remained in remission. And in the second group, they start doing the tapering, and half of the patients still remained in remission. And if you see the third part, that one, they stopped the DMARD, and after 1 year, around 40% of the patients remained in DMARD-free remission. They had nothing. So these figures are very astonishing, because we used to think that, like all of you raised your hands, that we know that the disease is going to come back. So this is a new data, and they say that probably if you select the patient very rightly, the new figures are quite high, as shown by EULAR and ACR. They are very stringent. They say that every patient is going to come back. But the new data is coming up. This is evolving. They have not added this in the recommendations, but this is a new data that probably the figures need to be studied more. Okay, so question to this is that, is DMARD-free remission possible? Probably, yes, it is possible. So what were the predictors of sustained remission? Who were these patients in which the disease didn't come back? Well, this is the data over a period of 17 years. They tried to see the data, the predictors. They collected data of 18 predictors. They included RA factor, anti-CCP antibodies, acute phase reactants, smokers, comorbidities, so many things. But what they found, these were the 5 main predictors, which they found that in these were the patients in which the disease did not come back even after 1 year. They were younger patients. They had a shorter duration of disease. At the time of the diagnosis, they had a good quality of life. They were non-smokers, and they did not have any erosions on the X-rays or ultrasound. So the next objective is, why do we want tapering? Why not just continue on the treatment, go on and on and on? Tapering, why it is important, how to be done, which drug to taper first. Well, nobody wants to take the medicines for the rest of their life, even us, and long-term side effects, cost issues, patient preferences, compliance issues, so many things. So this is going to be you can see the below, that is the tapering, why it is important. Well, let's see the data from the EULAR 2023. EULAR straight away says dose reduction can be considered, but discontinuation is not advisable. And if you see the data from the ACR, there is a double take for continuation. They prefer that don't go for tapering, just go on and on and on. However, if somebody wants to reduce the dose, you may reduce the dose, but discontinuation is still not recommended. And despite of that retro trial, the guidelines say do not stop the medication. And the rationale behind this is that we have seen that retro trial has shown that around 40% of the patients, they will remain DMARD free. But still, the data rationale by the ACR and EULAR is that the relapse is still very high after 1 year, which is around 56 to 87%. So that's the rationale. They avoid discontinuation. So next is, if we plan to taper the medications, which we should, so what should be done? So this is the cartoon which I have made, is that if your patient is taking a monotherapy, first of all, identification of the patient is the most important thing. Identify the patients who are in sustained remission. If you're selecting the patients who have a low disease activity, patient is definitely going to relapse early. Apply stringent criteria, apply like Boolean 2 criteria rather than DAS28. Then it has to be a shared decision. Take a consent from the patient that we are going to be doing this, but if there is a relapse, please inform us at the earliest. So the third point is gradual dose reduction is recommended and avoid discontinuation. So these are the 4 parameters. And if your patient is taking a combination therapy, for example, with methotrexate, the patient is taking sulfasalazine or maybe triple therapy. So first, again, the first 2 steps are the same. Identify the patients, have a shared decision, and followed by, if the patient is taking dual therapy, just reduce the dose to monotherapy. If the patient is taking a triple therapy, reduce the therapy to dual therapy, and then gradually monotherapy. And if your patient is taking injectables, there are 2 ways. Either you can go for dose reduction or dose spacing. Both these methods are recommended. Let's see what EULAR has to say about this. Well, EULAR has no problem. You can do whatever you want to do. Dose reduction or interval spacing, both are right. Just do it. Now the point is, the which agent to taper first? Should we taper? How many of you would, for example, if your patient is on methotrexate along with JAK inhibitor, so how many of you would stop or taper methotrexate first? Please raise your hands. Okay. And how many of you would prefer to taper the JAK inhibitors or the biologics first? Okay. Now let's see what does the data says. Well, if you see the ACR, as per the 2021 guidelines, they say that they favor conventional synthetic DMARDs over biologics or targeted synthetic DMARDs. We'll discuss about the rationale behind that. And if you talk about EULAR, they have no preferred tapering sequence. So both the societies have a little bit difference in between, but let's see the data. Well, these are the landmark trials. I would like you to remember these are very, very important trials because they are working so much that we have to reduce the medicine. Everybody wants to get rid of the biologics or conventional synthetic DMARDs. Either it's a tapering, either it's a discontinuation. So I'll start with the very first and the old conventional trial, that is the TARA trial. This was published back in 2020 and in the Annals of Rheumatic Diseases. And what they did was, in half of the patient, they tapered conventional synthetic DMARDs first. Like a few of your people wanted to do the same. And half of the people, what they did was they tapered the biologics first. And what they found was, they found that the order of tapering did not affect the flares. So as this is just like the data which was being published by the EULAR as well. That was again taken from this TARA trial. So you can do whatever you want to do, but this was an old study. This was followed by a SEAM trial published in 2023. And well, what they did was, this is a little bit different from the TARA trial. What they did was, they divided into 3 groups. In the first group, they continued the treatment. And they found that around more than half of the patients were in remission. And the second group, they stopped methotrexate. You can see that only 49% of the patients were in remission. But in the third group, when they stopped biologics first, very few patients were in remission. So conclusion from this data was that disease relapse was more in those who stopped biologics first compared to those who stopped conventional synthetic DMARDs. So this goes in favor of ACR rather than EULAR. And if you see the more recent data, again published in 2023, published in Rheumatology Journal, I would like you to focus on the middle 2 circles, and one in which the conventional synthetic DMARDs were tapered, they found that the relapse was only 9%. And in those patients in which the biologics or the targeted synthetic DMARDs were tapered, the relapse was 44%. Again, the conclusion is patients who tapered biologics or targeted synthetic DMARDs prior to conventional synthetic DMARDs were more likely to experience a flare after 2 years. So again, this study goes in favor of ACR 2021. So no one is right, no one is wrong, but keep your eyes open. Which one do you want to do it? So the next point is there any entity risk of relapse post-tapering? Yes, we have a relapse. Again, this is the data which shows that if you taper biologics first, there is a very, very high risk of relapse. In case of TNF, around 75%. In case of tocilizumab, it is around 84%, even more higher. So the rationale is that if your patient is in sustained remission, the maximum relapse is if you taper biologics first, followed by JAK inhibitors, followed by conventional synthetic DMARDs. So it is wise to taper conventional synthetic DMARDs first rather than tapering the JAK or biologics. So this is going to be my last slide, and my first conclusion is that, is tapering possible? The answer is yes, definitely, but choose the patients wisely and have a shared decision before you try this kind of thing. And identification of the patient is the most important key thing. You need to remember that. And avoid discontinuation. It is wise to go tapering, gradually slow in decreasing the doses, then number of medications, rather than abrupt discontinuation. And the last, I feel that this is my anecdotal experience as well, based on these trials, that taper conventional synthetic DMARDs first, followed by JAK inhibitors, and followed by the biologics. Thank you very much.
Moving on to the last talk of this session, The growing prevalence of multimorbidity has transformed the landscape of rheumatologic care. Patients increasingly present with complex interactions between autoimmune diseases and coexisting conditions such as cardiovascular diseases, diabetes, and chronic infections. This complexity challenges conventional disease-centered approaches and calls for a more holistic, patient-centered model of care. Understanding these interactions is therefore essential for optimizing therapeutic decisions and improving overall patient outcomes. We are honored to introduce Dr. Hafiz Muhammad Mahmood Riaz, Associate Professor of Medicine at Aga Khan University Hospital, Karachi. He serves as a Senior Consultant Rheumatologist in the Department of Medicine and has previously led as Section Head of Internal Medicine. Dr. Riaz has an extensive academic and clinical portfolio with nearly 30 peer-reviewed publications spanning key areas of rheumatology and internal medicine. His work has particularly contributed to advancing understanding of inflammatory arthritis, connective tissue diseases, especially SLE, and osteoporosis, with strong emphasis on patient-centered outcomes such as health-related quality of life in rheumatoid arthritis and SLE. Dr. Riaz is widely recognized for his contributions to both clinical care and research, integrating evidence-based practice with real-world patient management in complex rheumatic diseases. Today, he will be sharing his insight on multimorbidity in inflammatory rheumatic diseases, an area of growing importance in rheumatology. Please put your hands together for Dr. Hafiz Muhammad Mahmood Riaz.
Thank you very much for the kind introduction. Assalamu alaikum, ladies and gentlemen, and very good morning. First of all, I would like to thank the organizers. First of all, thank you very much to the organizers of the Rheumacon 2026 for inviting me as guest speaker. And ladies and gentlemen, very good morning. And today we will be discussing the multimorbidity in rheumatology and how it fundamentally changes the way we understand and manage diseases like rheumatoid arthritis and SLE. Here is my disclosure. The sub-themes of my talk includes a little bit about the background of multimorbidity, followed by concepts of comorbidity and multimorbidity. Then we will review the prevalence of multimorbidity in the clinical context and potential impacts on medical care and research. Lastly, we will discuss the challenges addressing multimorbidity and management of RA in rheumatoid arthritis. These are my references. The additional references are also given in the respective slides. So, as you know that the multimorbidity is a growing global challenge with the substantial impact on the individuals, carers, and the society. In the recent years, multimorbidity in rheumatic diseases has gained increasing attention, particularly in the resource-poor countries. The concept is still poorly understood and not well integrated into medical care and research. Currently, it is one of the most acute and least studied problem in rheumatology. The increasing incidence of multimorbidity is probably due to the higher life expectancy, lower threshold for diagnoses, advances in medical care, and possibly due to a true increase in the prevalence of chronic diseases. Certainly, the focus of modern medicine on the provision of highly specialized care can be significantly improve the effectiveness of treatment of patients with a single chronic disease, but the specialists often ignore beyond the scope of their specialty. Let's define multimorbidity. Multimorbidity can be defined as coexistence of two or more chronic diseases in the same individual, irrespective of whether the disease started before or after the onset of the index disease. It is different from comorbidity and represents systemic disease burden. Comorbidity is the presence or occurrence of any distinct additional condition during the clinical course of a patient who already has the index disease under study, and it centers on the index disease, and 3C's classification can divide it into causality, complications, and coincidences. For the morbidity, the RA is the index disease, and all other diseases are mainly regarded consequential. When pathophysiologically linked conditions like cardiovascular disease follows a primary inflammatory disorder like RA, this is referred as causality. Complications are the comorbidities that arise as a direct consequence of the disease itself or its treatment, while the coincidence means that the comorbidities occur independently and are unrelated to the index disease. For example, RA and appendicitis or rheumatoid arthritis or atrial fibrillation. The concepts of comorbidity and multimorbidity are not mutually exclusive or contradictory, but consider a patient with more than one disease at the same time from different perspectives. Multimorbidity has no index disease. In multimorbidity, no index disease is defined, and all morbidities are regarded are of equal importance. Multimorbidity constitutes a more generic, patient-centered concept and therefore takes into account all aspects of the disease condition, including potential disease interactions and potential pathophysiological links. And let's see the comorbidity and the concept of treatment. In the comorbidity concept, the treatment is primarily focused on the index disease like rheumatoid arthritis, and the effect is quantified by evaluating the rheumatoid disease activity, considering that any rheumatic treatment will positively affect the accompanying non-rheumatic conditions. While in the concept of multimorbidity, the treatment focuses on the patient and not the disease. It aims to reach or sustain a patient independence and autonomy and to improve the general medical function, and not the specific focus on how to reduce the activity of a given rheumatic disease. Treatment effectiveness is quantified in overall indicators such as quality of life and physical function. What is the relevance of multimorbidity in rheumatology? It is clear that the problems of the coexistence of rheumatic disease with other diseases is associated with higher socioeconomic status, including more hospitalizations, longer length of stay, perioperative complications and recovery or mortality, repeat visits to the specialist, and an increase in indirect and direct cost of medical care. Treat to target strategy, for example, in the treatment of rheumatoid arthritis and spondyloarthritis, is significantly hampered, and it is assumed the aims of therapy is impossible to achieve with the coexistence of multimorbidity. Multimorbidity is a significant predictor of worse quality of life and functional status independent of the disease activity. More than half of the studies in a systemic review demonstrated an increased mortality rate among patients with rheumatoid arthritis and multimorbidity. 10 out of 19 studies from the same systematic review identified an increased risk of an impaired function status in rheumatoid arthritis, and 3 more studies observed additional effects on quality of life and mental health. Clinicians and policymakers often use evidence-based clinical practice guidelines to improve quality of treatment and allocate resources appropriately. However, patients with multimorbidity are often excluded from the clinical trials and efficacy studies. Therefore, applicability of current guidelines to these patients is questionable and should be interpreted with caution. As rheumatology patients typically have more than one disease, therefore multimorbidity is of particular importance while deciding diagnostic and therapeutic strategies for these patients. Why multimorbidity is clinically relevant? It should also be noted that the multimorbidity can cause a significant distortion of the results of inflammatory disease activity assessment, as we know that the disease activity score combines multiple domains, including objective clinical findings, laboratory measures, patient-reported outcomes, like global patient assessment, and the presence of these patient-reported outcomes, the mortality can have a great influence on the value of the parameters determined by the patient. In a linear increase of global patient assessment is observed in disease that has been with an increase of the number of morbidity patients. Multimorbidity carries a significant economic implications, with more than 70% of healthcare expenditure in the US directed towards the chronic conditions. Individuals suffering with 4 or more chronic conditions receive 80% Medicare expenditure. Similar trends have been observed in the European nations. According to a German study, individuals with 3 or more chronic disorders attend double the number of physical appointments than individuals without comorbidities. So let's review the challenges that we face in addressing multimorbidity in autoimmune rheumatic diseases. It is still unknown that how common multimorbidity is in autoimmune rheumatic conditions and how often it occurs. For an individual chronic disease, abundant epidemiological data are available, enabling clinicians to consider risk factors and prognosis. There are no generally accepted ways to assess multimorbidity currently. So we do not know how to measure multimorbidity in clinical assessment and patient follow-up. So far, there is no universal tool that would allow you correctly evaluate all the parameters of interest. The question of determining the severity of comorbidities is also of great importance. More or less severe variants can change the status of the patient to different categories. We also don't know how the outcomes and consequences are evaluated in multimorbidity. For comorbidity, the effectiveness of treatment is assessed by evaluating the activity of the index disease, such as the swollen and tender joint count in patients with rheumatoid arthritis, the effect of multifaceted treatment on a patient with multimorbidity and a combination of rheumatoid arthritis, diabetes mellitus, and heart failure cannot be quantified by unidimensional standardized tools like joint counts. This disease complexity calls for a change in the standardized clinical assessment, including quality of life, overall function, and health and patient preferences. So let's review the literature. What is the prevalence of multimorbidity in rheumatology? The incidence and the prevalence of Thank you. The incidence and prevalence of multimorbidities are not clear and varying widely due to the heterogeneity of methods used to assess multimorbidity. According to the published literature, the prevalence in the general population is about 25%. It's much more common in the practice of rheumatology. It's detected in about 60% of RA patients, and until now, for other rheumatic diseases, no information is available. Studies have shown significantly higher burden of multimorbidity in rheumatoid arthritis. US commercial claims database revealed 52% of RA patients are multimorbid versus 33% in the matched controls over a period of 2 years observation. Another study revealed 62% prevalence, and a population cohort found that 86% of patients of rheumatoid had multimorbidity. The prevalence increases with longer period of observation. This tells us that multimorbidity is not incidental, it is inherent and evolving feature of rheumatoid arthritis. There are multiple ways to measure multimorbidity, from simple counts to weighted indices. However, these approaches fail to capture how disease interact. Quantitative measures such as multimorbidity index measures severity, while the advanced methods like pattern analysis and network models capture interconnectedness, which reflects real-world disease behavior. ULR recommends that the comorbidity screening should be systematic, repeated over time, and focused on the key domains of cardiovascular disease, infection, malignancy, and osteoporosis. Importantly, this is a shared responsibility across all healthcare workers and patients. Now review the concept of multimorbidity web. Traditionally, we measure multimorbidity by counting diseases or using scores, and therefore fail to capture the complexity of the disease interactions. In rheumatic diseases, comorbidities often share underlying pathophysiological mechanisms like systemic inflammation, immune dysregulation, and metabolic alterations, leading to non-randomized clustering. Multimorbidity web constitutes these relationships as an interconnected network where both disease and disease-host interactions collectively determine clinical outcome. Building on the typical multimorbidity model of rheumatoid arthritis, we can add connections between rheumatoid arthritis and comorbidities like lung diseases and cardiovascular disease. Furthermore, on the other morbidities are also interconnected like diabetes and cardiovascular disease, so these connections can also be added. The result is the multimorbidity web constructed from interconnected morbidities. So what are the implications of multimorbidity in rheumatology? This study was published in 2022 in Arthritis Care Research and focused on the identification of multimorbidity patterns in rheumatoid arthritis through machine learning. So measuring the multimorbidity web, one approach is to measure the multimorbidity web is to use analytical data approaches that capture connections between numerous variables. Using large data set, over 300,000 patients, researchers applied unsupervised machine learning to identify how comorbidities cluster together. What emerges were the three consistent patterns, and these are cardiovascular, cardiometabolic, mental health, and chronic pain syndrome. These clusters are represented interconnected subnetworks within the multimorbidity web. These patterns were reproducible across populations, suggesting that multimorbidity is structured and predictable. This is another population-based observational study conducted in Wales, United Kingdom, using longitudinal electronic health record. It addresses the growing recognition that multimorbidity is a defining feature of rheumatic diseases. There were two objectives of this study: to characterize 10-year multimorbidity trajectories and clusters in patients with rheumatic musculoskeletal disorders and non-rheumatic musculoskeletal controls. The second objective was to understand its pattern, mechanisms, and clinical implications, and to explore how network medicine can provide a systems-level explanation. So the major results are the patients with rheumatic diseases had higher baseline and progressive accumulation of multimorbidity over 10 years compared to the controls. Distinct multimorbidity clusters were identified, as we have seen in previous slides. Rheumatic diseases patients show earlier onset and faster progression of comorbidity clusters. Strong association with cardiovascular and metabolic diseases was found, highlighting the systemic effect of multimorbidity. Multimorbidity burden increased over time in both groups but remained consistently high in rheumatic disease patients. While the traditional multimorbidity indices are used in outcome research, they are very useful for confounding adjustment. On the other hand, the multimorbidity patterns identified the shared pathophysiological pathways explaining disease clustering in rheumatoid arthritis, and this enables us to identify therapeutic strategies and selecting more precise therapies. Pattern recognition provide more informative representation of multimorbidity, reflect interconnectedness among diseases biology, and it captures the multi-system involvement in different domains of the disease burden. So what is the clinical relevance of pattern-based assessment? From a clinical perspective, pattern-based thinking aligns more closely with real-world practice, particularly with the increasing integration of electronic health record databases. And the take-home from this is the multimorbidity patterns move us from measuring disease burdens to understanding disease biology, enabling more meaningful and clinical research applications of this knowledge. Multimorbidity has a profound impact on patient outcomes in RA. It is consistently associated with the reduced quality of life and impaired physical function, with strong effect seen in the physical domains, along with mental health is also affected when psychological comorbidities are present. Importantly, these effects are independent of disease activity, suggesting that chronic controlling inflammation alone is not sufficient in these patients. Multimorbidity also contributes to Faletti, further worsening the functional status. RA-related outcomes and multimorbidity. Multimorbidity also affects how we assess disease activity, like patient-reported outcomes. Global assessment of the patients are heavily influenced by conditions like depression and chronic pain, potentially leading to the overestimation of disease activity. This has even led to modification in the remission criteria in certain cases. Safety, if you look at the safety outcomes of multimorbidity, it is an independent risk factor for serious infections, and it also needs to interpret the disease activity cautiously. It balances the efficacy and safety. The BRAS study investigated the relationship between morbidity and physical function. It was a prospective observational cohort of more than 200 patients with longitudinal follow-up. The target was low disease activity, and the results found that a decrease in physical function with increasing number of morbidities. population-based studies have demonstrated that the burden of multimorbidity has a negative impact on outcomes such as health-related quality of life and physical function, which is independent of the disease activity. Multimorbidity influences every step of treatment. In the management of rheumatoid arthritis, observational studies suggest that the patients with multimorbidity are less likely to receive advanced therapies like biological therapies. However, in patients with active arthritis requiring escalation multimorbidity and do not reduce disease modifications, treatment decisions may be influenced by morbidity burden, physician concerns about safety, and patient complexity. Patients with higher morbidity burden have significantly lower odds ratios of achieving low disease activity, and mental and chronic pain cluster patients predict poor biological response. So moving on, the last portion of my talk is the multimorbidity screening in inflammatory rheumatic diseases. This paper actually looked into the systematic screening for multimorbidities in patients with inflammatory rheumatic diseases, enhanced preventive medicine use, and reduced hospitalizations. This study evaluates whether the systematic multimorbidity screening improves care and outcomes in patients with inflammatory rheumatic disease and successfully addresses the uptake of preventive interventions impact on hospitalizations. The results showed there is 50 to 60% higher likelihood of receiving preventive medicines by using this model. There was significant increase was observed in vaccinations, lower lipid-lowering therapies, and anti-osteoporosis treatment. No significant change was observed in antiplatelet drug use, and there was better adherence to ULR recommendations were also observed. 60% reduction in emergency hospitalizations was observed. There was a reduction in infection-related hospitalizations and trends towards reduction in fractures and cardiovascular events. So the clinical implication supports the routine implementation of structured multimorbidity screening program, justifies resources allocation in rheumatology practice by preventing hospitalizations and improving care. Multimorbidity assessment and management strategies involves the initial step is assessing for the presence of multimorbidity and determining if they are being appropriately managed. There are at least 4 strategies that are involved in the assessment and management strategies, and we will discuss them one by one. Multimorbidity is often under-recognized and suboptimally managed, and the evidence comes from the Comora study, which showed the suboptimal monitoring of cardiovascular risk, infection, cancer, and osteoporosis. Recommended approaches are formal screening strategies and to follow the URL principle recommendations. There are studies which have shown structural interventions in the form of a nurse-led assessment and action plan, and Comitra studies actually showed that the increased management actions were observed in a nurse-led assessment. Multimorbidity clinics are the other strategies to address the challenges of multimorbidity, and they can detect underdiagnosed conditions, and the challenge of multimorbidity clinic is poor long-term follow-up, patients and caregiver burden, which can be addressed by telehealth consultations and ongoing monitoring remotely. Multimorbidity and RA management, because treatment response may be attenuated and treatment risk heightened by multimorbidity, it is possible that RA needs to be managed differently in multimorbidity persons, which means that we need to adapt to the target of remission rather than aiming for complete remission. Low disease activity would be more appropriate in patients with multimorbidity and rheumatic diseases. And there are several landmark trials that actually showed the efficacy of certain and that can help us to understand the balance between the safety and the adverse effects of more advanced treatment like biologics and JAK2 inhibitors. Network medicine represents a shift from reductional thinking to a system-level understanding of the disease. It focuses on the interactions between biological elements such as genes, proteins, and multibiomes, allowing us to understand disease as a complex network rather than a single pathway. This is particularly relevant in rheumatology, where diseases like RA and SLE are highly heterogeneous and interconnected. As far as the future directions are concerned, multimorbidity and the social determinants of health are the active topics of investigations. In the healthcare, due to their prevalence and because they add considerable burden to the patient and the healthcare system. Future research on multimorbidity and social determinants in RA could benefit from further examining their association with disease activity, addressing via healthcare integrative strategies or health equity directed interventions to mitigate their associations with negative outcomes. So my conclusion is the rheumatic diseases are network-driven disorders that lead to predictable multimorbidity trajectories. Multimorbidity is common, progressive, and impactful in autoimmune rheumatic diseases. What we see clinically is actually an expression of a disrupted biological network, and this requires a shift from disease-centered care to integrated, patient-centered management. Early screening for comorbidities and multidisciplinary approach is recommended, moving towards precision trajectory-based rather than an episodic treatment. Thank you so much for your kind attention.
I'd like to invite our Honorable Head of the Department of Rheumatology and Immunology at Shaikh Zayed Hospital, Lahore, Dr. Aflaq Rashid. Please join us in warmly welcoming Dr. Aflaq on the stage.
Bismillahirrahmanirrahim and Assalamu alaikum everybody. Thank you very much for being here, being part of Rheumacon. And I think and I hope that the first three talks today were enlightening for the rheumatology people as well as the physicians, as well as the surgeons, especially orthopedic surgeons. So with that, we are going to start our inaugural session, and the format is that I will ask our stardust of our profession to come and sit on the chairs before inauguration. And first of all, I will invite Professor Aisha Mayo, who is the Chairman and Dean and Principal of Shaikh Zayed Medical Complex and Sheikh Khalifa bin Zayed Medical and Dental College, Lahore, to come and take the chair. I will request Professor Sajid Maqbool Sahab to, sir, please come to the stage. He is teachers of the teachers and has always been an inspiration and an icon of our profession. Professor Khalid Masood Gondal Sahab, who is the current President, Chairman, as well as Vice Chancellor of Fatima Jinnah Medical University. He has been very kind enough to take time and to be part of our Rheumacon. I will request Professor Sardar Fakhri Imam Sahab, Professor of Medicine, again teachers of teachers, to please come to the stage. Dr. Fayaz Raja Sahab, an eminent personality and previous DG Health, as well as a medical superintendent, Mayo Hospital, Lahore. I will request Professor Dr. Tafazul Haq Mahmood, my professor, my mentor, to come to the Dr. Tariq Mia, who is Physicians Academy chairperson, to please, sir, come to the stage. Professor Mona Aziz, who is the executive director of our institution. Perhaps she is not here. So, starting from that, I would like to introduce the Department of Rheumatology and Immunology, Shaikh Zayed Hospital, which was being initiated in 1999 when Professor Tafazzul Haq Mahmood joined it. And with all that persistent commitment and envisionary thoughts, he took that department, started from one-day OPD and some few beds in the medical ward in 2009, with all the facilitation of the new council at that time. Again, that was President of CPSP, Professor Khalid Masood Saab. His efforts for promoting rheumatology, he accredited our unit along with rest of across the country. Rheumatology was recognized and rheumatology departments were also accredited. So after that, again a long journey till 2018 when MD in rheumatology at UHS was recognized. Before that, it was affiliated with Punjab University. So from one day outdoor to a 6-day outdoor, from no ward to a ward at the time of 2017 when Professor Zafrullah Chaudhary, then the president of CPSP, inaugurated the unit. And we come along to a time in 2020 when we thought we should now outsource and outcatch and started this Rheumacon. This is, alhamdulillah, our 7th year of continuing this conference, and we hope to get along in future as well. So with that, I will request Professor Tafazzul to come to the stage and say a few words and take up further.
Thank you so much, Dr. Flak. I'm really grateful to all of you for coming today and gracing the event and taking time out of all your busy schedules. I'm particularly thankful to all my teachers who are here and all my colleagues who have spent years with me and now they are here today. And I'm particularly grateful to Professor Khalid Masood Gondal for taking time out of his busy schedule today when actually CPSP election is being held and he's still here. So I'm really grateful, sir. Rheumatology, as you know, is a broad subject and it is still under-recognized. As I was seeing the questions arising from the previous talks, so the understanding of the subject is still deficient, and that is not because we don't have enough knowledge. That is because the awareness is less, and secondly, the people who are trained in rheumatology are still less and are still more and more required. And I'm very grateful to Professor Ranja Saab that he is probably going to start with Professor Khalid Masood Gondal some community rheumatology program. I don't know whether it will be an MCPS or what, but Dr. Nigat Mir is also on board with that. So that will inshallah happen soon. So community rheumatology means that you will be able to see rheumatologists even in the small areas of Pakistan, and that will be a great service. So that will increase the awareness. Rheumatology as a subject, if I see from 1999 when I landed here, it has actually evolved as a subject, and we started from methotrexate and now we are in an array of biologics and other whatnot, JAK inhibitors and others, specialized targeted therapies, which we are still trying to understand. We still don't know much about those. Not even West knows much about those. So we are all in the process of learning, because rheumatology is a complex disease. It is at the cellular level. What happens leads to a chronic disease that manifests itself into a debilitating problem, not only for the patient but for the whole family. So as more and more rheumatologists are being produced with the help of Khalid Masood Gonzab and his predecessors' vision of recognizing rheumatology as a need and starting it as a specialty to promote the post-graduation in the subject at the platform of College of Physicians and Surgeons of Pakistan. So more and more rheumatologists are being produced, and Pakistan Society of Rheumatology takes a lot of credit for that. Some of the representatives of the societies are also sitting here, and I'm really grateful to them for taking on the task and taking it head on, actually. So thanks again. So I give the mic again to Professor Aflaq. Thank you so much.
Now I will request Professor Aisha Humayun, the Chairman and Dean of Shaikh Zayed Medical Institute, to come to the dais and say a few words.
Assalamu alaikum. So it's a profound honor for me to stand here in this prestigious platform in the Rheumacon 2026. Because Shaikh Zayed Postgraduate Medical Institute is also hosting, and it's the main organizing this conference. So I'm part of the hosting team. So I would like to congratulate the entire organizing committee, the Rheumatology Society, for organizing such a well-organized and well-attended conference. So I hope this conference will be an inspiring activity, inspiring event for every one of you. And here, because the autoimmune health and musculoskeletal issues, they are rising like a pandemic. If you look at the global trends, in developing countries, we are also facing the same rise in incidence and prevalence of musculoskeletal issues and autoimmune diseases. So for this, being a public health professional, I would like to appreciate this initiative that the community rheumatology is to be launched, and we can have access to rheumatologists at community level. Because our general population coming from low socioeconomic status, they don't have access to expensive medicines and to rheumatologists, because we have very few rheumatologists, just like psychiatrists. So for early screening, early diagnosis, and then prompt treatment, this is the key to success. And because if you look at the world, we are moving towards posture medicine, and we are moving towards new innovative disciplines in which we can engage specifically for the geriatric population, for elderly population, how we can keep them healthy, how we can improve their quality of life by and preventing rheumatological diseases. So for that purpose, rheumatologists, public health professionals, and definitely they can work together and they can make a change. So once again, congratulations and thank you for inviting me. Thank you.
Thank you, madam. Thank you very much for your coming to the session and being part of inauguration. I will now request Professor Khalid Masood Gondal Sahab, who has came from his commitments, took out a lot of time, and we are very much thankful.
बिस्मिल्लाहिर्रहमानिर्रहीम नहमदुहु व नसल्ली अला रसूलिल करीम। आज एक ऐसी इंगेजमेंट थी कि दरमियान में मसरूफ़ियत, लेकिन अफलाक साहब का जिस मोहब्बत से बुलाना और फिर आपकी एक स्पेशलिटी, ऑल्दो कॉलेज के इस वक्त 90 फेलोशिप प्रोग्राम हैं, 50,000 फेलोज़ हैं, 40,000 ट्रेनी हैं और 325+ इंस्टीट्यूशन हैं, लेकिन आपकी स्पेशलिटी इज़ वन ऑफ द मोस्ट इम्पॉर्टेंट स्पेशलिटी इन द वे। मेरे इस वक्त के जो बड़े भाई बैठे हैं, हाफिज़ एजाज साहब, मैं फ़र्स्ट ईयर में था तो उस वक्त हाउस साहब कर रहे थे, डॉक्टर फ़याज़ राना साहब उस वक्त मेडिकल अफसर थे, साजिद मकबूल साहब हमारे उस्ताद एसोसिएट प्रोफेसर थे, तफज़ल मेरे से 1 साल जूनियर थे। तो वो कहते हैं ना, हाँ तसव्वुर में दिखा दे, फिर वो सुबह शाम तो दौड़ पीछे की तरफ है गर्दिश अयाम। तो उस ज़माने में रूमेटोलॉजी एज ए स्पेशलिटी नहीं पता था किसी को। ईस्ट मेडिकल में गैस्ट्रो का नाम था, लेकिन गैस्ट्रो वाज नॉट ए सेपरेट यूनिट। तो कहते हैं ना कि मैं अकेले ही चला था जानबे मंजिल, लोग मिलते गए कारवां बनता गया। अब ये सारा कारवां है। अब जब मैं देखता हूँ कि शेख ज़ैद, ऑब्वियसली प्रोफेसर आयशा बैठी है यहाँ पे, इज़ द पॉनियर ऑफ द रूमेटोलॉजी, और इसमें तफज़ल हक महमूद को बहुत बड़ा क्रेडिट जाता है, निगत मीर को क्रेडिट जाता है। लेकिन अब आप में से बैठे हुए कम से कम मैं 10 लोगों को यहाँ जानता हूँ हु आर हेडिंग अ सेपरेट डिपार्टमेंट ऑफ द रूमेटोलॉजी। म्यो का नाम लें, यासर मुझे नज़र आया, इसी तरीके से बिलाल गंगाराम में मौजूद है, फैज़ान उसको रिप्रेजेंट कर रहे हैं, ये अली रुख पीरज़ादा। आप साउथ में चले जाएँ तो वहाँ, यानी नाउ यू हैव गॉट द डिपार्टमेंट ऑफ रूमेटोलॉजी एट एवरी टर्शी केयर सेंटर, और ये बहुत बड़ा सदका जारी है। वो कहते हैं ना कि दुनिया में रुपया पैसा जिस्म रूह का ताल्लुक़ ख़त्म किसी का हो गया, अजीज़ो अकरबा रिश्तेदार चंद साल के बाद भूल जाएंगे। जो चीज़ साथ जाएगी वो सदका जारिया होगा, मरीज़ों की दुआएं होंगी, और ये एजुकेशनल सिस्टम के आपने बच्चों को जो ट्रेन किया होगा ये आपके साथ जाएगा। और कहते हैं एक इंसान की जान बची आपके हाथों से, तो ऐसे जैसे सारी इंसानियत की जान बची। और फयाज़ रांझा साहब अक्सर इसको पढ़ते हैं कि खैरुन्नास मन यनफ़उन्नास, कि इंसानों में बेहतरीन वो जो इंसानियत की नफ़ा रिसानी के लिए काम करे। तो मैं ये समझता हूँ अफलाक साहब, प्रोफेसर तफज़ल, और हमारे ये सारे सीनियर बैठे हुए, फ़खर इमाम साहब मौजूद हैं, उस्ताद मेरे मौजूद हैं, तारिक महमूद मियाँ जिस अंदाज में फैमिली फिजिशियन की खिदमत कर रहे हैं, आज का ये हाल, आज की ये कॉन्फ्रेंस, ये खैरुन्नास मन यनफ़उन्नास की एक अमली मिसाल है। और जब मैं आई गो वे बैक कि 2007 में जब हमने देखा कि 7,000 के करीब ट्रेनिंग, अब 40,000 90 स्पेशलिटी, तो मैंने सुबह स्टेटिस्टिक मंगाया, मैंने कहा व्हाट अबाउट रूमेटोलॉजी, नई स्पेशलिटी। लेकिन इस नई स्पेशलिटी में माशाल्लाह हर शोबे में स्पेशलिस्ट, हर टर्शी केयर सेंटर में डिपार्टमेंट मौजूद है। और इस वक्त बाय द ग्रेस ऑफ अल्लाह अलमाइटी 20 ऐसे इंस्टीट्यूशन हैं जो ट्रेनिंग दे रहे हैं इस वक्त स्पेशलिटी ऑफ रूमेटोलॉजी, रिकग्नाइज 20 इंस्टीट्यूशन इन पाकिस्तान, जिसमें प्राइवेट सेक्टर में 7 हैं, आर्म फोर्सेस में 2 हैं, पब्लिक में 11 हैं। और इस वक्त इस हाल में मुझे इल्म नहीं है कि कितने ट्रेनर मौजूद हैं, लेकिन पूरे पाकिस्तान में आज से 30-40 साल पहले कोई 1 कोई 2 पूरा पाकिस्तान, लेकिन अब 30 से ज़्यादा ट्रेनर मौजूद हैं, और आपके 60 से ज़्यादा रूमेटोलॉजिस्ट ऐड होने जा रहे हैं अगले साल। सो दैट इज़ द कंट्रीब्यूशन जो किसी टीचर की किसी मेंटर की उस अंदाज में होनी चाहिए। तो मैं बहुत मुबारकबाद देता हूँ इस कॉन्फ्रेंस के इनकाद पे, और ऑब्वियसली जो लोग यहाँ बैठे हैं इनसे बहुत पुराना ताल्लुक़। जब मैं साजिद मकबूल साहब को जब भी देखता हूँ सर, तो मुझे अपना हाउस जॉब याद आ जाता है। आई डिड माई हाउस जॉब इन पीडियाट्रिक्स टू। इतनी हम्बल शख्सियत, इतने बेहतरीन उस्ताद, इतनी अच्छी कंट्रीब्यूशन। आप चिल्ड्रन हॉस्पिटल में चले जाएं, म्यो में चले जाएं, साजिद मकबूल साहब की उसी अंदाज में कंट्रीब्यूशन। और इसी तरीके से अपने फ़खर इमाम साहब का वाइस चांसलर बनना, फातिमा जना में और किंग एडवर्ड में कंट्रीब्यूशन, तारिक महमूद मियाँ इनके साथी मौजूद हैं, फैमिली फिजिशियन को इन्होंने बहुत स्ट्रेंथन किया। आयशा हमायूं माशाल्लाह, शेख ज़ैद में इनकी लीडरशिप, हाफिज़ एजाज साहब का स्टूडेंट लाइफ से। लेकिन डॉक्टर फयाज़ अहमद रांझा साहब यूनिक इन द वे हैं कि लोग बिलीव नहीं करते, लेकिन चूँकि मैं खुद म्यो में प्रोफेसर था 2006 और 7 में, और 1860 के करीब हमारा किंग एडवर्ड बना और फिर म्यो बना, और बड़े एमएसएस आए। फैक्ट ये है कि रांझा साहब के 4 सालों में, आप साहब मैं रिपीट कर रहा हूँ, एंड आई एम ऑन ए रिस्पॉन्सिबल पोस्ट, यू नो आई बिन हेडिंग 3 इंस्टीट्यूशन और एक कॉलेज को भी कर रहा हूँ। उन 4 सालों का मैं गवाह हूँ कि म्यो हॉस्पिटल में 1 पैसे की भी दवाई मरीज़ बाहर से नहीं लाता था। स्टेप्टोकाइनेज वाज अवेलेबल, फॉरगॉटिक कैथेटर वाज अवेलेबल, एंड डिस्पोजेबल इक्विपमेंट फॉर लेप्रोस्कोपी वाज अवेलेबल। ये राजा साहब का सदका जारी है, इन्हें खुद भी नहीं पता कि अल्लाह ताला ने इनसे क्या काम ले लिया। अब कम्युनिटी रूमेटोलॉजिस्ट के तौर पे ये क्या करेंगे ये इन्हीं को पता है। लेकिन बहरहाल म्यो हॉस्पिटल में डॉक्टर फयाज़ अहमद रांझा की खिदमात दे रिमेन अनप्रेसिडेंटेड। एमएस और भी कई आए हैं, मैं भी वाइस चांसलर रहा हूँ, मैंने 7 अस्पतालों को देखा, अब भी 3 अस्पतालों को देख रहा हूँ। कोशिश के बावजूद भी हम उस अंदाज में सर्विस डिलीवरी फ्री ऑफ कास्ट नहीं करवा सके जिस अंदाज में डॉक्टर फयाज़ अहमद रांझा ने करवाई। सर आपका बहुत शुक्रिया और बहुत दुआएं। जब भी नज़र आते हैं मुझे बातें याद आ जाती हैं। लोग कहते हैं कि शायद आप एग्जेजरेट कर जाते हैं, तो मैंने कहता हूँ यार मुनाजरा कर लो मेरे साथ, क्योंकि मैं तो 4 साल प्रोफेसर रहा। बहरहाल तफज़्ज़ल हक महमूद साहब, अफलाक साहब, आपकी इस बेहतरीन कॉन्फ्रेंस और ये सदका दारिया, यहाँ ट्रेनी बैठे हैं, ट्रेनर बैठे हैं, और मैं ये समझता हूँ कि 20 इंस्टीट्यूशन नहीं है, अगर इसका 320 भी है तो एक वक्त आएगा आपकी इन एक्टिविटीज़ की वजह से कि हर डिपार्टमेंट में डिपार्टमेंट को हेड करेगा और सर्टिफाइड रूमेटोलॉजिस्ट। एक वक्त आएगा डिस्ट्रिक्ट लेवल पे सेपरेट डिपार्टमेंट ऑफ रूमेटोलॉजी होगा, वहाँ रूमेटोलॉजिस्ट हेड कर रहा होगा, और अल्टीमेटली तहसील लेवल तक आपने इस सर्विसेज को पहुँचाना है, और ये होगी एक्चुअल अमली मिसाल। खैरुन्नास मन यनफउन्नास। थैंक यू एंड थैंक यू वेरी मच। बहुत शुक्रिया।
Professor Khalid, thank you very much. Now, please, Wasif, I will request Professor Dr. Fayaz Ranja Sahab to say a few words, and then Sajid Makhoon.
बिस्मिल्लाहिर्रहमानिर्रहीम। खालिद गोंदल साहब ने जिस अंदाज से पूरे के पूरे हेल्थ डिपार्टमेंट का रिव्यू पेश किया है, एक बात मैं भी कहना चाहूँगा, वो ये है कि एक वक्त था कि पूरे लाहौर में चंद डॉक्टर थे और लेडी डॉक्टर कोई भी नहीं थी। फिर एक वक्त आया कि एक फातिमा जना मेडिकल कॉलेज बन गया तो ख़वातीन भी डॉक्टर बनना शुरू हो गई। वो वक्त था कि जिस वक्त में हमारी ख़वातीन को मजबूरन अपने तमाम मसाइल के लिए नॉन फीमेल के साथ रब्ता करना पड़ता था। अब बात आगे चली गई है और माशाल्लाह यूनिवर्सिटियाँ बन गई, और इस वक्त में मेरे दाएं भी वाइस चांसलर, बाएं भी वाइस चांसलर, और वो भी वाइस चांसलर। मैं ये अर्ज़ करता हूँ कि जब अल्लाह ने मुझे डीजी हेल्थ पाकिस्तान बनाया तो वहाँ मेरे सामने जो आदाद शुमार लाए गए और जो मेरे इल्म में बातें आई, उनमें से एक बात ये थी कि 2030 में जो मस्कुलोस्केलेटल डिसऑर्डर्स हैं, जिसमें सबसे बड़ा कंपोनेंट र्यूमेटोलॉजी का है, वो नंबर 1 डिजीज़ होगी। पूरी दुनिया का सबसे बड़ा हेल्थ का इशू वो होगा। तो खालिद गोंदल साहब ने बता दिया कि इंशाअल्लाह जिस तेज़ी से CPSP ट्रेनिंग कर रहा है और नेक लोग हाफिज एजाज साहब जैसे जो है दुआएं कर रहे हैं, तो ये 2030 में इस वक्त में कार्डियोवैस्कुलर डिजीज़ नंबर 1 पे है पूरी दुनिया में इंसिडेंस के हिसाब से। तो लिहाजा खैरुन्नास का तकाजा ये है कि सबसे ज़्यादा तवज्जो इस पर दी जाए कि ये जो मस्कुलोस्केलेटल डिसऑर्डर्स हैं उसकी वजह से मॉर्बिडिटी, कोमॉर्बिडिटी और मोर्टेलिटी कम से कम हो। तो लिहाजा ये जो र्यूमाकॉन है, ये अपना तफज़्ज़ल साहब जो फादर ऑफ र्यूमेटोलॉजी हैं, 2 ही हम नाम सुनते थे जब स्टूडेंट थे आप साहब, एक तफज़्ज़ल हक साहब थे और एक मैडम मीर थी, बस। अल्लाह अल्लाह खैर सल्लाह, कोई र्यूमेटोलॉजी का नाम नहीं होता था। अब अल्लाह का फजल है कि इन दोनों ने मेहनत करके अफलाक साहब जैसे नौजवान हैं मुतहर्रिक पैदा कर दिए। एक वो हमारे ब्रिगेडियर साहब का बेटा जिसने सबसे पहले पढ़ा है पिंडी वाले
बाबर सलीम
जी,
बाबर सलीम
जी हाँ, वो फौजी फाउंडेशन में है। तो मेरी दरख्वास्त ये है, क्योंकि मैंने सारी उम्र कम्युनिटी मेडिसिन में गुजारी है, तो मेरी जो मोहब्बत है वो कम्युनिटी से है, तो कम्युनिटी के मसाइल के हल के लिए र्यूमेटोलॉजिस्ट कम्युनिटी र्यूमेटोलॉजी को फ़रोग दें, क्योंकि ये बरस इस तेज़ी से बढ़ रही है कि आपके बस में नहीं रहेगा। अगर गोंदल साहब की बात पूरी भी हो गई कि तहसीलों तक र्यूमेटोलॉजिस्ट चले गए तो र्यूमेटोलॉजी तो ख़त्म नहीं होगी, मरीज़ बढ़ते चले जाएंगे, तो उसको मसले का हल नहीं। मसले का हल वही है जो आज महमूद ने, जो कराची से आए हैं, जिन्होंने पढ़ा है कि कोमॉर्बिडिटी अब 62% लोगों को बचाया जा सकता है अगर थोड़ी सी आप ट्रेनिंग दे दें कि गुर्दे को देखना है, जिगर को देखना है, मैदे को देखना है, दवाइयाँ देते हुए साथ। तो हम अब इलाज के साथ मरीजों को मरीज ना बनाएं, उसके लिए ज़रूरी है कम्युनिटी र्यूमेटोलॉजी। थैंक यू वेरी मच।
थैंक यू वेरी मच सर। अच्छा, साजिद मकबूल सर।
बिस्मिल्लाहिर्रहमानिर्रहीम। जनाब तफज़्ज़ुल साहब, अफलाक साहब, वाइस चांसलर्स, हमारे फ़ख्र इमाम साहब बैठे हुए हैं, पुराने दोस्त हमारे हैं खालिद रांझा साहब और तारिक महमूद साहब, प्रोफेसर आयशा, एंड आई होप आई एम नॉट मिसिंग एनीबडी, ऑफ कोर्स खालिद मसूद गुंदल साहब हमारे पुराने साथी हैं। इतनी अच्छी अच्छी तकारीर हुई हैं और अच्छी अच्छी बातें आपने सुनी हैं, और बहुत मुश्किल हो जाता है इतने अच्छे लोगों की मौजूदगी में कोई काम की बात करना। मगर मैं ये आपको बताना चाहता हूँ कि 1 मिनट के लिए रूमेटोलॉजी को भी छोड़ दें और ये भी छोड़ दें, और मेरा ख्याल है राजा साहब इससे इत्तेफाक करेंगे। आप अगर पाकिस्तान में किसी खातून को पूछें कि उसकी तबीयत कैसी है, तो जवाब आम तौर पे ये आएगा, सब कुछ ठीक है, मेरे गोडों में दर्द होता है और मेरी कमर रह गई है। ये ठीक कह रहा हूँ? अब मुझे ये मालूम नहीं कि ये इसका ताल्लुक रूमेटोलॉजी से है या माँ होने के नाते है या खून की कमी से है या काम की ज़्यादती से है वगैरह वगैरह। मगर हमेशा जो जोड़ हैं उनकी तकलीफ़ बहुत आम तौर पे देखी गई है। तो this particular specialty of rheumatology is actually very special. And the reason for that is that this is one specialty where now you can make very, very accurate diagnosis, pinpoint the diagnosis based on very good scientific investigations, which are actually state of the art, and they're also available in Pakistan. And not only that, gone is the time when you would just not know how to treat rheumatological conditions. Now you have excellent modalities of treatments, not only diagnosis. You know, you were talking about ultrasound of the soft tissues around the joints and whatnot, which is also one of the latest modalities. But now you have not only diagnostic capabilities, but based on that, specific treatments, which actually help the patient quite a bit. So those who are sitting here trying to learn, I think it's a remarkable opportunity and they should make the most of it. And I wish that they would listen very carefully and participate. And I wish that they become very good rheumatologists and that we have rheumatologists all over the province, all over the country, and that it creates a big pool of very specialized rheumatologists all around. Because this is a condition which a lot of people do not understand. So I wish the organizers a lot of success.
Thank you.
And I do thank the organizers for this privilege of inviting me here and coming to speak to you. Thank you very, very much.
Thank you so much, sir. Thank you. Professor Sardar Fakhri Imam, sir. Sir.
In the name of Allah, the Beneficent, the Merciful, distinguished guests on the stage, distinguished participants in the hall, I was given this allowance and permission to talk while sitting there, but I think as a part of our culture, as a part of our training, and to pay respect and to recognize those people who've done great jobs in the past, who are still doing great jobs, it was difficult for me to sit down and then talk to you. I think when I come here, it's not just to straighten up my legs or my back, but it's actually to pay my respects to all of you, including the organizers, those who are actually doing this great job to hold this conference on an annual basis. I'm also sensitized to one fact that as we tend to grow old, we tend to accumulate lots of stories, lots of incidences and other things, and we tend to talk more, and we tend to talk fluently and without any break or so. So whereas we've got lots of things, and people of our ages and my seniors in particular will tell you how is it that this field has come up in Pakistan. How did it start? How were people ridiculed when they talked about joints and diseases related to joints? But today it is a pleasure to see that this clan of medicine is growing, is expanding, and will, inshallah, it will continue to do so under the able leadership and guidance of all of you. Thank you once again for having invited me, and I wish all of you best of luck in propagating this field and developing this specialty. Thank you very much.
Thank you very much, sir. I welcome Professor Ahmed Saeed, who is currently heading the Central Park Medical Teaching Hospital Rheumatology Department, and at present he is President Society of Rheumatology. Sir, I welcome you. Okay. Dr. Tariq, please say a few words, and then lastly, Dr. Ahmed Saeed sir.
Bismillah ar-Rahman ar-Rahim. Aflaq sahab, बहुत शुक्रिया for involving family physicians. मैं एक दो पॉइंट हाईलाइट करूंगा कि हमारी प्रैक्टिस में अगर 40-50 साल पीछे चले जाएं तो देयर वर मोर दिस इन्फेक्शियस डिजीज़, बट नाउ डेज जो नॉन कम्युनिकेबल डिजीज़ हैं, नॉन इन्फेक्शियस डिजीज़ हैं, दे आर ऑन द सर्च. रीज़न बीइंग कि हमारा जो लाइफस्टाइल है वो बहुत ज़्यादा चेंज हो गया. हमारे जो यंगस्टर हैं फास्ट फूड के अलावा कुछ नहीं लेते, रिफाइंड कार्ब्स लेते हैं. और एक बहुत बड़ा पॉइंट ये है कि हमारे यहाँ जो सी सेक्शन का रेट है वो बहुत ज़्यादा बढ़ गया है. जो नॉर्मल वेजाइनल डिलीवरी थी, जिससे गट जो माइक्रोबायोटा है ट्रांसफ़र होने थे और उससे नॉर्मल जो आपका इकोसिस्टम है वो रहना था, वो ख़राब हुआ. सेकेंडली क्या है कि हमने तकरीबन 95% फार्मूला मिल्क के ऊपर हो गए लोग. तो उससे क्या हुआ कि आपकी जो ऑटो इम्यूनिटी और इन्फ्लेमेटरी जो डिजीज़ हैं वो बढ़ गई. तो मैं ये चाहूँगा कि आपके जितने रोमेटोलॉजिस्ट हैं, मेरा ख्याल है कि वो इससे डबल भी, जैसे गोंदल साहब कह रहे थे, डबल भी हो जाएं तो पूरी 25 करोड़ को वो नहीं कैटर कर सकते. तो लाइजन बिटवीन फैमिली फिजिशियन एंड रोमेटोलॉजिस्ट इज़ मस्ट. रीज़न बीइंग कि आपकी टाइमली रेफरल इज़ वेरी इंपॉर्टेंट. So I think Academy of Family Physician will work with you people and will enhance the capacity of the family physician so they can early recognize and early refer. Thank you.
Thank you, sir. Thank you, sir.
I would also like to come there, Dr. Flak, if you allow me.
Sure, Doctor.
आप प्रोफेसर फ़खर इमाम, आपने बिल्कुल सही कहा कि मेरे उस्तादों के होते हुए कि जो सब स्टेज पे बैठे हैं, बहुत बुरा लगेगा कि अगर मैं बैठ के बात करूं. प्रोफेसर खालिद मसूद गोंदल, respected so my all colleagues who are sitting here, I'm really honored to be standing here on behalf of the PSR community. We are very in touch. It's really heartwarming that Shaikh Zayed Hospital does this effort every year. Honestly, I can tell that how difficult it is to organize a meeting and do it on annual basis. So my all congratulations to the whole team, Professor Tafazzul and Dr. Aflaq, and I'm really excited to be here and part of this meeting. Thank you, everyone.
Thank you very much, and I would like now to invite Professor Aisha Mayu to come and distribute shields to the guest of honors, please. Madam, please. Madam Aisha.
Professor Dr. Aisha Humayun Sheikh to receive a souvenir. Professor Dr. Sajid Maqbool. Sir, please receive your souvenir. Professor Dr. Khalid Masood Gondal. Professor Dr. Sardar Fakhr Imam. Dr. Fayaz Ranja. Dr. Tariq Mahmood Mia. Miss Farida Nas. Our Chief Nursing Supervisor.
Thank you very much. And lastly, I will request Professor Khalid Masood Gondal Sahab to come to the stage and conclude the inauguration, please. Nice.
Assalamu alaikum. I'm Dr. Maham Dilshad, and I welcome you back as we begin the second session of today's conference. It's a pleasure to introduce Dr. Sayyid Ali Rukh Pirzada, who is currently serving as Assistant Professor at Bahawalpur Victoria Hospital. Dr. Pirzada holds FCPS qualifications in both medicine and rheumatology, reflecting his strong academic foundation and specialized expertise in the field. He has played a pivotal role in establishing a rheumatology unit at his institution, which is a significant contribution towards improving access to specialized care in the region. In addition to his clinical services, he is actively involved in teaching and mentoring, contributing to the training of future healthcare professionals. His commitment to patient care and academic excellence continues to make a meaningful impact on the management of rheumatic diseases and the advancement of rheumatology services. We're honored to have Dr. Pirzada with us today to serve as moderator for the panel discussion on the role of glucocorticoids in autoimmune nephritis. Please welcome Dr. Pirzada to the stage.
Thank you very much for this kind introduction. Thank you. Good morning, everyone, and Assalamu alaikum. Welcome to this focused panel discussion on a topic that continues to challenge both evidence and practice. The role of glucocorticoids versus reduced or no glucocorticoids in autoimmune vasculitis, particularly ANCA-associated and lupus vasculitis with kidney involvement. As you know, over the past few years, all the guidelines, international guidelines, including ULAR, ACR, BSR, and KDIGO, they are progressively moving towards the lowest possible dose of the glucocorticoids in treatment of the renal involvement especially. This was driven by the landmark study PEXI-VAS and low-VAS trial. But the question we face today is, can we truly implement these recommendations in real-world settings like Pakistan, where infection burden is quite high? Access to biologics is inconsistent, and cost constraints influence the decision making. Monitoring facilities are also very scanty. So today's discussion is not just about what the guidelines say, but what is practical, safe, and feasible in our context. To explore this, we have an excellent panel of nephrologists, rheumatologists, who bring both evidence and experience to the table. So allow me to introduce and call our panelists to the stage for this exciting session, inshallah. It is a great honor for me to introduce the distinguished rheumatologist, academician, researcher of international repute. He is serving as the head of the Department of Rheumatology at Institute of the Rheumatic Diseases, Central Park Medical College, Lahore, and is currently president of Pakistan Society for Rheumatology. His extensive qualification and vast experience reflect his deep commitment to excellence in both clinical practice and academics. He has represented Pakistan on numerous national and international platforms and has been esteemed speaker at leading conferences like APLAR and ULAR, contributing significantly to the global rheumatology community. With great respect and admiration, I invite Professor Dr. Mohammad Ahmed Saeed Saab to come on the stage and take his seat. Thank you, sir. Our first panelist from the nephrology is Professor Dr. Hafiz Ijaz Ahmed. He is a distinguished nephrologist and educator, currently working as head of the nephrology at Aleem Medical and Gulab Devi Hospital, Lahore. Professor Dr. Hafiz Saab is the founder of the Department of Nephrology at Allama Iqbal Medical College, where his contributions have played a pivotal role in establishing and advancing the specialty. He has also served as the Dean of Nephrology at PKLI, demonstrating exemplary leadership and commitment to excellence. With his valuable clinical and academic experience across renowned institutions of the United Kingdom and US, he brings a wealth of international exposure and expertise to his work. His dedication to patient care, teaching, and the development of nephrology services have earned him great respect among colleagues and students. With great respect and admiration, I invite Professor Dr. Hafiz Ijaz to kindly come to the stage. Our second panelist from the Rheumatology Board is Professor Dr. Sumaira Farman. It is a great honor for me to introduce her. She is a highly esteemed and accomplished figure in the field of rheumatology. She is widely recognized for her remarkable expertise, particularly in pediatric rheumatology, where her contributions have been truly impactful. As the head of the Department of National Hospital and Medical Center, Lahore, she has demonstrated exceptional leadership, clinical excellence, and dedication to advancing the field. With great respect and admiration, please come to the stage. Thank you, ma'am. Our second panelist from the nephrology board is Professor Dr. Ibadur Rahman. It is a great honor for me, again, to invite Professor Dr. Ibadur Rahman. He is a distinguished name in the field of nephrology and a respected academic leader. He is currently serving as the head of the department at Alimuddin Medical College and PGMI Lahore. With his vast clinical experience, dedication to teaching and contribution to patient care, Dr. Ibadur Rahman contributes to inspire both the colleagues and students. Please, sir, Dr. Ibadur Rahman, come to the stage and take your seat. Oh, thank you. Sir, Dr. Tafazzul, it is a great honor for me. Yes, sir. It is a great honor for me to invite our esteemed supervisor, Professor Dr. Tafazzul Mahmood, a renowned figure in the field of rheumatology in Pakistan. He is widely respected for his exceptional clinical expertise, academic excellence, and remarkable contribution to the training of the future rheumatologist. Throughout his distinguished career, he has mentored and inspired numerous students and professionals shaping the future of rheumatology in our country. With great respect and admiration, I invite Professor Dr. Tafazzul to please come to the stage, please. And our last panelist from the nephrology board, Dr. Professor Mateen Sahab. Professor Dr. Mateen Ahmed is heading the unit of nephrology at Shaikh Zayed Hospital, Lahore. His extensive qualification and vast experience reflect his deep commitment to the excellence, both clinical practice and academics. Sir, I request you to please join us on the stage as nephrology panelist. Sir, before I start, there are some ground rules for the panel. Before we begin, a few quick ground rules. I will direct each question alternately to a nephrologist or a rheumatologist to ensure balanced perspective. Each person's response should be around 2 to 3 minutes, so we can cover multiple aspects of the topic. Panelists are encouraged to challenge each other respectfully, especially where specialties differ. Wherever possible, please anchor the responses in international guidelines and personal clinical experiences in Pakistan. Audience questions will be taken toward the end of the session, if time permits. So let's start. Please share my slides. First of all, I will share with you a clinical scenario of 40-year-old male, previously healthy, presented with 6 months history of the long-standing nasal obstruction. Sir, this is a clinical scenario. 40-year-old male, previously healthy, presented to 6 months of the history, long-standing history of the nasal obstruction, recurrent nasal thrusting, blood discharge from the nose, and sinus pain. He was initially treated as chronic sinusitis with multiple courses of the antibiotics and nasal steroids, with only partial relief. 2 months later, he developed new symptoms like fatigue, low-grade fever, arthralgias, and significant weight loss of 5 kg. His examination revealed high blood pressure of 159 by 105 millimeter of mercury. Previously, he was not a known case of the hypertension. And there was pedal edema and periorbital puffiness with a saddle nose deformity as well. A few investigations were carried out, and urine report showed us +2 proteinuria, numerous RBCs, and 20 WBCs per high power field. Serum creatinine was raised, it was 2.8. And C-ANCA test was 97 against the normal of the 2. So this is a clinical scenario of 40 years, male who was having the chronic rhinosinusitis. And later on, involvement of the rising trend of the creatinine with the history of the periorbital puffiness and pedal edema, rising blood pressure as well. So this is a case scenario. So my first question will be with Dr. Hafiz Ijaz Ahmed Saab. Please, sir, this is a question to you. In this patient who is presenting to us with sino-nasal symptoms and rapidly rising creatinine, which is suggestive of ANCA-associated vasculitis, what is the recommended diagnostic approach, including the role of C-ANCA testing and later on renal biopsy?
Bismillahirrahmanirrahim. This patient with these symptoms which he has presented going on for a few months, and now laboratory investigations indicate significant renal dysfunction, proteinuria and microhematuria, is highly indicative of ANCA-associated vasculitis, presenting with upper respiratory tract as well as kidney dysfunction. So from renal point of view, this is a patient who is having an organ at threat ANCA vasculitis, and we should proceed because all the necessary investigations are already available, and we should plan a renal biopsy that is indicative of which will show us the severity of the disease, chronicity, and how we are doing. But we will not wait for the kidney biopsy results to start the medicines. With this background of advancing renal dysfunction, symptomatology for more than 6 months, having hypertension, we should go according to the guidelines and start him on treatment.
Okay, sir, what is the role of the MPO and PR3 ANCA test in this particular patient?
Both these tests are very pivotal in deciding our patient whether he has got an ANCA-associated vasculitis or not, because these are the two tests which will confirm the association of vasculitis. So as we already have results with us, we will proceed for it.
Okay, sir. Thank you so much, sir. Sir, I pass this question to Professor Dr. Tafazzul Saab. Sir, kindly share your views point. So it's not. No, sir.
Yeah.
Mike.
Thank you so much. First of all, I would like to tell the audience that what is PR3 and what is MPO and what happens when we do suspect ANCA-associated vasculitis and what is actually going on. Because without that background, one cannot develop a treatment management approach. Both proteinase 3 and myeloperoxygenase are, as you know, cytoplasmic antigens which are present inside the neutrophils. And these, because of the chronic inflammation, as in this patient, there is something called MALT, which is mucosal associated lymphoid tissue. So from there, and some genetic factors which are also there, some environmental factors also there. So all of this leads to the activation of interferon alpha, and they prime these antigens, and they come to the surface of from the cytoplasm, they come to the cell. And then there is a term which is called extracellular trapping. So they come out on the surface, and these primed PR3 and MPO are then attacked by the complement 5A activated ANCA antibodies, which are produced by the B cell primed plasma cells, and it leads to the inflammation as well as the widespread nature of the disease that AAV patients suffer from. So with this background of knowledge, it is now easier for us to find these antibodies testing important, but this antibody testing alone is not important. The history which is presented in front of you before that, which is the sinonasal disease involvement, as well as the, urine complete, as Hafiz Sahib has said, the urine complete examination, which is a very simple test with RBCs in it or RBC casts, and rapidly rising creatinine, as it has already been mentioned, blood pressure, and so on and so forth. Now, there is very little doubt that the disease is advancing rapidly and is probably associated with PR3, because this antigen, this ANCA, PR3 ANCA is mostly associated with a rapidly progressive disease. So, but that ANCA alone is not important. KDIGO and all other guidelines, they strongly recommend that the renal biopsy should be performed. But as Hafiz Sahib said, the nature of the disease does not allow us to perform, sometimes not wait for the results, and sometimes the patient does not agree to the biopsy at all. So we will start the treatment.
Okay, sir. Thank you, sir. We have taken your perspective. Sir, my next question is about renal biopsy. What is the role of the biopsy? Should treatment ever be delayed, as sir has told us? Already guidelines say you should treat the patient, not waiting for the biopsy. But sir, I want to know what is the perspective of the nephrologist. Do you start the treatment without the biopsy, or you wait for the biopsy?
Bismillahirrahmanirrahim. Thank you, Dr. Ali. It's a very, very interesting question. We face day to day such kind of scenarios in the management of vasculitis, ANCA associated. As you have mentioned in your clinical scenario, patient not only have the upper respiratory tract in symptom, as well as he has involved the kidneys in the form of pyuria, RBC cast, and deranged renal function with the low GFR and very high ANCA levels. So, because we have to start, because it has involved the multiple systems, not only the respiratory tract, along with that the kidneys. Definitely, to save the system, we should have started the treatment, definitive treatment in the form of immunosuppression, glucocorticoid, and the other steroid-sparing drugs. Along with that, we should proceed for the renal biopsy, because that is very important for the activity and chronicity indices and the long-term management of the disease. And definitely, and because according to the KDOKI guidelines, they have, if we go for the renal biopsies, there are certain 3 or 4 type of class. Focal class, in which focal glomeruli are involved. There is crescentic class, and there is a mixed class as well. And so, if we go for the renal biopsy and we have the crescentic glomerular nephritis that have involved more than 50% glomeruli, we have to do and initiate the immunosuppression in the form of steroids and rituximab or cyclophosphamide, along with sometimes plasma exchanges as well. So to looking forward the chronicity, that can we in the future, if we treat the patient, we have remission, partial remission, or the complete remission. So we should proceed with the renal biopsy and start the initiation of the immunosuppression for the diagnosis and the management along with that.
So sir, your point is we should not wait for the biopsy, right? We should start the treatment, and arrangement should be done for the renal biopsy.
Because patients not only have the active cause in the form of pyuria, WBCs, he has deranged renal function.
Yes.
The GFR is less than 45 ml, because it is recommended according to the guidelines if the serum creatinine is more than 3 or 3.5.
Sir, we just want to know what is your practice and how do you deal with such kind of the patients while you are doing the round in the wards or
where I am working in my department, we have rituximab freely available. So I start with the immunosuppression with the methylprednisolone and start the rituximab. Sometime if it is not available or any other thing, if he has any active viral hepatitis, any other contraindication, then I can switch over on the cyclophosphamide. And sometimes I have to restart even if there are so many high titers of these ANCA and the resistant GFR, it's not improving. Sometimes I started the plasma exchanges as well for in such cases, but not for all, in some cases, in my practice as well. And the same in the KDICO recent guidelines, they also have recommended. One thing I will just want to highlight it, we have to go for the serum IgG levels, because if currently I have one patient with ANCA vasculitis. He had two cycles of remissions and relapses. Now I did 2 times renal biopsies and he responded to that, but he presented after second course of rituximab with he has Acinobacters. So because we have this, it affects the immunomodulator system, and we should have the IgG levels that should be in the baseline before the treatment, especially if we start the rituximab.
Okay, sir.
Thank you.
Thank you very much, sir. Sir, one question from
Can I respond
Madam,
to
please.
this?
Please, you want to add?
So basically, take home message एक तो ये है कि ज़रूरी नहीं होता कि आपके ANCA antibodies positive हो. So you have ANCA negative ANCA vasculitis also. You do not depend on that just for diagnosis. If there is enough clinical suspicion, of course, if patient comes in this situation, you do not wait. You have to make sure you do the workup, rule out any other infection that may be present, because unfortunately, आपको पता है कि they are more prone to infections as well. If there is no infection, this patient has to be pulsed with IV methylprednisolone, monitoring the blood pressure and blood glucose. If possible, biopsy as soon as possible. और renal biopsy की ज़रूरत आपको बहुत 2-3 चीज़ों के लिए चाहिए. Of course, what is the activity of disease? What is the type of disease? Is it something that is necrotizing GN जिसके अंदर आपको शायद ज़्यादा और ज़्यादा you may need to be more aggressive, and though there is still a place there where you think about whether you want to do plasmapheresis. These patients may be at increased risk of pulmonary hemorrhages as well. Biopsy करके फिर choices क्या हैं? अगर बहुत patient sick है, there's no infection, so sodium withdrawal के साथ cyclophosphamide is still a very, very valid option in Pakistan. Of course, you have to, counsel fertility and infection ना हो, लेकिन it is cost effective, it is very, it acts quickly, you're able to, wean off the steroids quicker, and of course work up if possible for rituximab. You can even combine the two together. I just want to add कि बच्चों में इतना common नहीं होता ANCA associated vasculitis, but होता भी है, और उनके अंदर भी पहले probably first line is again doing all of these, ruling out infections, pulsing. Cyclophosphamide has a real role in children because the disease is very, very active. और हमारे यहाँ तो आपको पता है affordability बहुत कम है. जहाँ पे हो तो mycophenolate और of course rituximab तो is an approved indication.
Thank you very much, madam. Well taken point. The compatible clinical picture is if it is there, positive PR3 is there or MPO ANCA is positive, then you should not wait for the biopsy. You should go for the treatment right from the beginning. And these cases should be managed at the experience centers. These are the guidelines which say, and our panelists also agree on that point. So we should not wait for the biopsy. We should start the treatment as early as possible. This is my question to Professor Dr. M. Zayed Saab for the remission reduction in organ-threatening ANCA-associated vasculitis. All the international guidelines, including EULARS, ACR, KDICO, and BSR, recommend glucocorticoids combined with either rituximab or cyclophosphamide. When would you prefer rituximab over cyclophosphamide or vice versa? And can we combine rituximab or cyclophosphamide too? So this is a question, sir.
Uh, Thank you for asking me to be part of this panel. I think there is a great discussion going on around the case. Let's put in this case in the context. I would like in this 40-year gentleman, methylprednisone, as Professor Sumaira has mentioned, anywhere between 500 to 1 gram per day for 3 days, along with cyclophosphamide, because the mechanism of action of cyclophosphamide is like that it's going to be effective within 7 days, 7 to 10 days, and will like to get all the workup done for rituximab. There has been instances, especially when we extrapolate our experience from lupus nephritis, that you can combine both things together, rituximab and cyclophosphamide, especially in a setting of a very life-threatening and organ-threatening disease like our patient has, because he already has lost more than 50% of his renal functions, and he has a saddle nose, which means that he has organ-threatening disease going on for quite some time now. So this patient would require a rituximab, and rituximab workup requires some prerequisites as well, and there is issues of access. I'm glad to hear that it's available at few centers in the government hospital. This I have learned lately, that LGH is one center, but it's not widely available, and it is cost. Its cost actually is a main factor. So cyclophosphamide should remain the first mainstay, IV cyclophosphamide along with methylprednisone. And if possible, add rituximab, withdraw cyclophosphamide. You don't need to give another cycle of cyclophosphamide or just one more cycle with the second dose of rituximab. Just stop cyclophosphamide, go ahead with rituximab, 375 milligram per meter square every week for 4 weeks, or you can use the other, which is not like the clinical trial dose, which is the RA dose of 1 gram, like 2 weekly, and then 500 milligram of maintenance from onwards for controlling the disease.
Thank you. Point has been well taken. So glucocorticoids and rituximab or cyclophosphamide, new onset ANCA-associated vasculitis, these are the guidelines with the consensus, all the 4 guidelines. Rituximab should be preferred in relapsing PR3 disease, fertility concerns, elderly and frail patients. Cyclophosphamide is still valuable when rituximab is unavailable or in very severe renal cases. Rituximab with cyclophosphamide combination for severe glomerulonephritis when serum creatinine is greater than 4 milligram per deciliter or patient requires the hemodialysis. These are the indications for the combination. So my question about the glucocorticoids, which is the main question over here, and we have to discuss it a little bit more. International guidelines now advocate a rapid glucocorticoid taper and consider Avacopan as a glucocorticoid sparing agent, especially in patients at high risk of the steroid toxicity or with severe renal involvement. What is your preferred glucocorticoid dosing and tapering strategy, and what is the role of the Avacopan? Sir, I pass this question to Dr. Mateen sir.
Assalamu alaikum. Thank you, Dr. Ali. Actually, the international guidelines, especially in the KDIGO guidelines, for the induction of this ANCA-associated vasculitis, you have to give the pulse therapy of the solamidol for 3 to 5 grams. That is for the 3 or 4 days. But the international guidelines also favor that the rapid tapering of the glucocorticoids because of having some side effects of the glucocorticoids. And in the trials where it was studied and you will rapid these glucocorticoids up to that of when initially you started with the 1 milligram per kg per day for the initially 2 to 3 months and the rapid tapering, and you have to make this glucocorticoids up to 5 milligram per day up to that of the 6 months.
Sir, what is your practice? These are the guidelines which are saying we should reduce the dose. What is being practiced over here? Because we don't have the Avacopan right now.
Yes, we don't have the Avacopan. So for that of the glucocorticoid sparing, this is all actually depend upon the response of the your induction therapy of the either you will induct with the rituximab or the cyclophosphamide, and you will get the initial remission as early, so you can taper the steroids as early as possible. So after that you have to continue with your maintenance phase of this treatment of this ANCA-associated vasculitis with rituximab or the cyclophosphamide along with the low dose of the steroid as well. As we don't have any avacopan here, in the trials which is studied that the avacopan is more useful in the induction as well as the maintenance therapy for the glucocorticoid sparing agent. Thank you.
Thank you, sir. Sir, what is your take on that, sir? Dr. Ahmed.
Yeah, I believe, yes, the steroids, we all know that these are double-edged swords, and the lesser, the better it is. We do not want at the same time to undertreat our patients and do not like them to develop complications of long-term steroids. But in this setting, when you are dealing with an organ-threatening and life-threatening disease, yes, I agree that 1 milligram per kg is generally the rule, the standard of care. But once you have pulsed, you can rapidly taper. There is a trial which is a plexivas trial, so which has now given us enough evidence that we can have a rather rapid taper even without avacopan. So it's plexivas is not talking about avacopan. It is basically the trial which was looking at the role of plasma exchange and the rapid taper, prednisone versus the slow taper. So the slow taper arm, they were at the 6 months, they were still on 20 milligram of prednisone, starting with 1 milligram per kilogram. And in the other arm, so they were on 20 milligram by like 8 weeks, and by 3 months they were on 10 milligram. This is what we have been practicing at our center. We generally start with either 0.75 milligram to 1 milligram per kilogram in patients who have life-threatening disease. We try to taper them by like 8 weeks to around 10 milligram. This is what we are doing, and this is what I would advocate.
Okay, you bring
but at the same time, we are using either cyclophosphamide or rituximab for induction. Without that, it's not going to happen. This disease is very remitting relapsing disease. If you would not institute steroid-sparing drugs, forget about avacopan, which is not available here. I'm talking about the two options we have. So, and then you can think of tapering depending upon the patient's response. One thing again, the role of a biopsy is really very pivotal because it's going to give you prognostic value. Your patient who has already extensive disease, which is chronic and a lot of fibrosis, sclerosis already has happened. This patient is not going to respond. That patient is going to head towards end-stage renal disease, and you do not want to escalate treatment in that situation. So biopsy has a role.
Thank you. Ma'am, what will be the effect of this treatment on the sinonasal presentation or the part of the clinical presentation?
मैं sorry वापस पुराने सवाल पे जा रही हूँ. So just want to talk about in children what is recommended. So the latest guidelines जो lupus nephritis के लिए आई हैं वही, और उससे पहले जो एक induction therapy आई थी, I'm just applying it to ANCA vasculitis also because we don't have enough trials in children and बहुत ज़्यादा adult data ही हमने उसके ऊपर apply किया. So the induction therapy actually changed how fast we can taper steroids in children, and that was that you start pulsing them at 30 milligram per kg per day from 3 to 5 days, and for the first 6 months this pulse can be repeated weekly, say 2 weekly or monthly depending on the status of the child, while decreasing the daily dose right from the get-go to 20 milligrams a day. तो वो जो चीज़ थी कि 1 मिलीग्राम पर केजी के ऊपर, क्योंकि बच्चों के बहुत और इश्यूज होते हैं, ग्रोथ एंड कुशिंगॉइड एंड रिस्क ऑफ इन्फेक्शन, AVNs, सारा कुछ. That really changed how well these children responded, and this was combined either with induction with cyclophosphamide, और उन्होंने NIH प्रोटोकॉल यूज़ किया था. उसमें जो 1 ग्राम मीटर स्क्वायर मंथली आप देते हो, लेकिन आप उसमें यूरोलूपस ऐड कर सकते हो जो हम करते हैं फिर 500 मिलीग्राम एवरी 2 weeks, and you can give that generally जैसे 3 महीने दिया, but you can extend it to 6 months depending on, of course fertility is a question and a big question, लेकिन बच्चे की जान बचेगी तो वहाँ तक पहुँचेंगे. And हमारे we know that our children behave more like Hispanics and Afro-Americans. They are very, very aggressive diseases in these children. And आपकी cyclophosphamide cost effective है and compliance ensure हो जाती है. अगर आप उनको mycophenolate पे डालते हैं, बहुत ज़्यादा experience है कि they will not either stop taking it because it's not gut is not tolerating or they cannot afford it. So you have to talk to the parents, but you need to ensure that the child. So this is a great way to do it, and iske alawa just, you can look up, but there are now shared guidelines as well, जो कि हर type of lupus nephritis का भी बताते हैं, वही चीज़ें फिर हम ANCA vasculitis में करते apply. So the idea is that you pulse 30 milligram per kg in children, and you can repeat it weekly or monthly for the first 6 months and decrease the dose of oral prednisone to 20 from the get-go. The idea is, is वक्त के आपने for clinical remission, you want the steroids to come down to 0.15 milligram per kg within 6 months. 0.10 for remission and low disease activity 0.15 milligram within 6 months. और अगर नहीं हो रही तो फिर आप अपनी ट्रीटमेंट को एक्सेलरेट करें. और बच्चों में भी cyclophosphamide, those who can afford it, rituximab, combining rituximab and cyclophosphamide, and of course mycophenolate does wonders as well. So,
thank you very much.
ये मैंने सिर्फ ऐड करना था डॉक्टर साहब के वजह.
I just want to add that since we are doing induction with very high immunosuppressive agents, so as Dr. Sumaira has very rightly pointed out, that we are living in a country which is infection dominant or prone or whatever you call it, but we have a lot of infections here, and we should screen for the infection before starting the induction, but then again it is wastage of time, but you at least send the tests. I don't know if there is any recommendation, at least I don't do it, start the antibiotic along with it. So, but one scenario needs to be addressed because it is itself life-threatening in ANCA-associated vasculitis, and that is pneumocystic cranii infection, and that prophylaxis needs to be started straight away, even if we don't have anything available in terms of tests. So, yes, as far as steroids are concerned in adult population, my personal practice is that I would like to stop it as early as possible, or at least reduce it to a minimum dose as early as possible, but not for at least first 2 weeks after the pulse or rituxi or the cyclo is all given. So after that, I would like to taper it off and reduce it to as low as possible by 8 weeks or maybe maximum 12 weeks. As far as steroid-sparing agents are concerned, we don't have the luxury of those expensive drugs that you are mentioning, but we are lucky that we have mycophenolate mofetil with us, which is a steroid-sparing agent in itself. We have methotrexate, which is steroid-sparing agent in itself. We have azathioprine, which is steroid-sparing agent in itself. So we have other options which we should look into instead of looking into very specific treatment options which are not available, and which are, even if they were available, they are not in reach of every person, because even rituximab is not in reach of every person. So as Dr. Sumaira said, that sometimes we only have to resort to steroids. So that steroid is a tricky thing, as Dr. MSC said, is a double-edged sword. So it is your expertise and your knowledge and your sharp eyes that should recognize when and where to taper it, and it should be tailored in every patient. You cannot generalize. These guidelines are guidelines. These are not rules. They cannot be applicable to everyone. It is not that no right turn will cause a challan every time or an accident every time. You still have a possibility that if you take the right turn, you may go to a little left and save the patient. So in terms of treating the patient, we should follow the guidelines as much as possible, because they are made with the intention that the patient should get the most benefit without least of the side effects and least of the cost, but they are not always possible to follow. So I think we should tailor from patient to patient how we should approach. Yes, sinonasal disease control is important, but then again, as initially Professor Dr. Hafiz Mahmood from Aga Khan said, that comorbidity screening. So we should have a multidisciplinary approach, and we should involve the ENT surgeon, nephrologist, everybody, so that we can give the best out of what is in our pocket to the patient.
Thank you very much, sir. Your point has been well taken. It depends on the patient condition, and the patient-to-patient variation will be there for the glucocorticoids dosages. My question, but I need the crisp answer from Dr. Hafiz Saab. In this particular patient with rising creatinine, would you recommend Plex?
Before answering this question, I just quickly want to clarify a couple of points. First of all, rituximab is not fit for all. The patients who present with more severe renal dysfunction, like creatinine more than 4, we have no data for rituximab. So we should be opting for cyclophosphamide from the very beginning. Number 2, now we have sufficient evidence available of low-dose glucocorticoids also. Low-VAS trial tells us that even 0.5 milligram per kg per day from the very start is an acceptable option instead of our previous routine of 1 milligram per kg. And PEXI-VAS trial has given us another guideline that we could taper more quickly within a month to 2 months to go to the smaller dose. Coming to this question of Plex, the patient whose renal function is quickly worsening and also has pulmonary hemorrhage, this is a combination where KDIGO guidelines tell us to give plasma exchange. Simply just for pulmonary hemorrhage, ACR guidelines also do not recommend for this. So in this patient, if he develops some other organ involvement like having pulmonary hemorrhage and then creatinine is rising, then Plex is an option. And of course, we should be very vigilant about its side effects in terms of infection.
One thing I would like to add over here is that there is an overlap between ANCA vasculitis, GPA, and anti-GBM. And if there is an anti-GBM, so then obviously you would like to go for Plex, and that would be a modality for that.
Very rightly said that if it is a mixed disease having ANCA-associated vasculitis and anti-GBM, then Plex is the option.
Okay, sir. Thank you very much, sir. So this is a consensus by our panelists. Consider only if serum creatinine is 3.4 milligram. These are the guidelines as well as our practice over here. Rapidly rising creatinine due to active glomerulonephritis or diffuse alveolar hemorrhage with hypoxemia. So we also follow the same guidelines over here. Our practice matches with theirs. Mandatory in anti-GBM overlap, but the PEXI-VAS showed no broad benefit of the Plex in ANCA-associated vasculitis. So it is conditional, basically.
My question from nephrology panel is that biopsy, of course, is very important, and the presence of crescents show active disease, and presence of fibrosis, on the other hand, shows slightly less active or no active disease. But I was just wondering if we have a clinical picture in which the patient is deteriorating and we have performed the biopsy, and biopsy later on comes out with a fibrotic picture, do we stop our treatment or we just carry on with what we are doing?
It is recommended by the guidelines that the results of biopsy should not hamper you from carrying on the treatment. Even with some more advanced changes, continuing immunosuppression therapy has shown the benefits.
So in this context, I was just wondering, as a lame person, that should we really need biopsy? Should we really need biopsy?
Re-biopsy after certain time.
Should we really need biopsy?
In what case?
In this case, because if it is showing fibrosis, we are carrying on. If it is showing crescents, we are carrying on. So what is the fun of getting biopsy?
Sir, I take up your question. Actually, before starting the treatment, if we should go for biopsy and patient has cellular crescents. And I will add that more of our respected colleagues have contributed their experiences that the pexivas plaques along with the steroid plasma exchange along with the low doses tapering steroids. We should actually, in such cases, if patient not having alveolar hemorrhages, and we found patient has more than 50% cellular crescents, along with all the cyclophosphamide, rituximab, prednisolone, we should start given 60 ml per liter, 5 to 7 sessions of plasma exchanges as well, first thing. And even if we have fibrocellular crescents, we should continue this treatment. Yes, your question was that when we should go for the second biopsy. If initially there was activity index was predominant and chronicity index was not as at the first time, and patient has still dialysis dependent, yes, you are right. We should go for the second biopsy in 4 to 6 weeks.
Thank you, sir. Thank you, sir. We have to conclude it because time is up, and I require your answers very quickly and very concisely, please, so that we can end up on time. After successful induction, what is your recommended maintenance strategy for this patient? Just quick answer, please.
So you for the maintenance strategy, either you can continue with the rituximab or you can continue with that of the cyclophosphamide as well. In the oral treatment, you can start with that of the azathioprine. So both are the trials available. Either if you induct the patient with the cyclophosphamide, you can switch over to the maintenance therapy with the rituximab, or if you induct the patient with the rituximab, you can continue with the maintenance therapy of the rituximab as well. So for that of the maintenance, oral treatment, azathioprine, you can continue with up to that of, it all depends upon the monitoring of that and the disease. If the patient have achieved the full remission, you can switch over to that of the azathioprine as well.
So we will continue with the Manritrisan trials actually.
Okay,
for the maintenance.
जी ma'am, please.
I just want to say कि हमारा experience हुआ है with azathioprine in nephritis, whether it is lupus or ANCA. I don't know whether it's genetic or what, लेकिन हमारा ज़्यादा बेहतर mycophenolate. So maintenance अगर oral पे जाना है तो probably mycophenolate. If they can afford maintenance with rituximab, तो वो आप every 6 months.
And sir, ma'am, what about the background dose of the steroids?
Steroid तो आपको taper करने हैं.
वो 5 milligram.
Or less actually. अब तो कहते हैं कि less than 3 mg, or if you can come to 0, ideally, because
Yes.
you're increasing risk of infections and lot of other comorbidities.
Yes, thank you very much, ma'am. So our practice also matches with the international guidelines. So monitoring for the remission and relapse, how frequently and with what parameters would you monitor this patient for remission and early relapse? Ji sir, please. Sir Tafazul.
The frequency is initially from 1 to 3 months, or if possible earlier, because it's a life-threatening disease. So, but at least minimum 1 month, and if a patient is a little bit stable, then 3 months. As far as the parameters are concerned, they are again the clinical scenario. It's not ANCA. Please note that it's not ANCA. ANCA alone is not sufficient to give you an insight into what is going on. It is a helpful tool, but the clinical scenario, for example, in granulomatous polyangiitis, GPA, the ENT examination, the ENT surgeon's perspective, how the disease has settled, the urine complete examination, how RBCs have settled, how creatinine is settling, how proteinuria is settling, all these things, and blood pressure, all these things in addition to the ANCA taken together, should make the parameters complete, and let us decide that if we should reduce the treatment. And चेंज क्यों कर दिया यार, पीछे जाएं, वापस जाएं, ठीक है ना? रिमिशन हुई है कि नहीं? यस, पेशेंट रिमिशन अभी नहीं हुई है, बिकॉज वी डोंट नो दैट. We are not inside the body. We don't know. We are only monitoring the symptoms. We are only monitoring the maybe ESR and CRP. We don't know. So we will continue. We will remain aggressive. We will remain on toes. We will not stop, because this is something which can be the reason for a very valuable family member's loss. So please think about that as well. So you have to be, if they don't have the monetary funds available to them, there are hospitals now. They were not 10 to 15 years ago from. But there are hospitals now where they can go and get their disease monitored. So early relapse, whenever there is early relapse, you just increase the dose of the steroids, you just increase the dose of the maintenance disease-modifying agent, whichever you are giving, and then keep on looking, call an early follow-up maybe in a month's time instead of 3. And if it is a severe relapse, then you have to go for, unfortunately, reinduction. And reinduction is not always going to be with rituximab, cyclophosphamide, because most of these patients may be females and they have fertility issues. You can't give steroids to all diabetics with very heavy monitoring, very vigilant monitoring. You can't give steroids because of previous steroid exposure and lot of osteoporosis and whatnot. So, you have to be very careful when you are reinducting. So when you are reinducting, of course, rituximab is the best choice because it decreases the chances of exposure to more toxic drugs. But then it is sometimes not possible to give. As I said earlier, you have to tailor it. You cannot give cyclophosphamide over and over again, because the cumulative effect of cyclophosphamide is going to affect the fertility. It is going to cause biocytopenias or whatnot. So, and risk of infection, it will also increase the risk of infection. So that reinduction is going to be a big question mark in my mind when I'm doing it, because I have to be very, very careful.
Okay, sir, if the patient develops a relapse of the disease, what will be the dose of the steroids? You would go for the high dosages again, or do you practice something else? My question is with Dr. Hafiz. Thank you, sir.
For relapse, our practice is to increase the dose of steroids from the before, because we can give cyclophosphamide in the same dose, but steroid should be enhanced maybe 50% or more. That is for the relapse.
Okay, sir. Sir, Dr. Mateen, if you want to add.
Depends upon the monitoring of your relapse as well. If you are having a high titer of the PR3 and you will get still the active sediments in the urine on the urine complete examination, then it all depends. The relapse, you have to increase the dose of the steroids, or either you can start with again induction with the cyclophosphamide plus as well rituximab. If the patient initially having an induction with that of the cyclophosphamide, so you have to change the cyclophosphamide to rituximab. And if the patient have initial induction with the rituximab, you have to change the rituximab to the cyclophosphamide if the patient relapses.
Sir Ahmed, if you want to speak on it.
I would agree with our nephrology colleagues, Professor Mateen. So this should be the practice. If your patient has failed rituximab, the second induction should be with cyclophosphamide and vice versa.
Okay, sir. Is there a role of combination of the
combination, the role is
rituximab
over there.
plus cyclo?
Yes, that can be done, but risk of infections long-term should be kept in mind, because we know that that's going to add more burden to infection.
Okay, sir. Same, actually, sir, I want to extend this question for our audience. If you want to add, sir.
I just
If you
want to add one thing, that combining cyclophosphamide with rituximab is that you are putting the patient on an atom bomb. So you should avoid it as much as possible. Mine.
Actually, I am...
रीइंडक्शन के लिए कह रहे हैं ना कि
हाँ,
दोनों
जी, जी।
चीज़ें ना कंबाइन कर, एक अगर फेल किया तो दूसरे पे चले जाए, rather than
Okay. Okay, sir. Last but not least, if someone of us has the experience of using a Vacopan, or if you know about it, especially Sir Hafiz, if you have used this medicine.
So far, this is not available to us. It's like a $20,000 per month treatment. So we don't have experience, but from the trials and guidelines, we know that for more severe renal dysfunction, Avacopan has the edge. And improvement in serum creatinine also greatest with Avacopan compared to steroids. But let's hope when it gets cheaper and we are able to use them for our patients.
Thank you very much, all the panelists, for giving us insight into this particular topic of autoimmune nephritis. We have just touched ANCA-associated vasculitis. I would like to have you again, inshallah, for lupus and other diseases. I wanted to have some questions on lupus as well, but I have a minute left with time.
ज़बरदस्ती उसके ऊपर बोल लिया.
नहीं, ma'am, we had the plan, but thank you very much, sir, and rheumatologist panel as well. So kind of you.
Thank you so much.
Thank you for having us.
Okay, we have the honor of having Professor Masood Sadiq Sahab, who is the Vice Chancellor of the University of Child Health Sciences. I will request him to come to the stage and distribute the certificates of these panelists as well as the first session presenters. Sir, please.
Professor Dr. Hafiz Ijaz Ahmed. Once again, for Professor Dr. Hafiz Ijaz Ahmed, a big round of applause, everyone. Professor Dr. Ibadur Rahman. Dr. Mateen Ikram. Professor Dr. Muhammad Ahmad Saeed. Professor Dr. Sumaira Raja. Professor Dr. Tafazul Haq Mahmood. And our moderator for this panel, Dr. Ali Rukh Pirzada. And for the speakers of our first session, Dr. Maisam Afzal. Dr. Babar Salim. Dr. Hafiz Muhammad Mahmood Riaz. Let's begin with the first talk of this session. Takayasu's arteritis, a rare but serious large vessel vasculitis, presents unique diagnostic and therapeutic challenges, particularly in the pediatric population. Early detection is often difficult due to non-specific symptoms, yet timely intervention is critical to prevent irreversible vascular damage and life-threatening complications. A multidisciplinary approach, especially incorporating cardiology expertise, is essential for comprehensive management and improved prognosis. We're privileged to introduce Professor Dr. Masood Sadiq, a highly esteemed pediatric cardiologist and academic leader. Holding FRCP Edinburgh, FRCP CH UK, and multiple distinguished qualifications, he currently serves as Vice Chancellor of the University of Child Health Sciences and Head of Pediatric Cardiology at the Children's Hospital, Lahore. His vast experience and leadership in pediatric cardiovascular care bring a unique and invaluable perspective to this topic. I will request Professor Dr. Masood Sadiq to please come on the stage to share his extensive knowledge with us.
First of all, let me thank the organizers for this kind opportunity. My first disclosure is that I'm not a rheumatologist. I'm a pediatric cardiologist, so my perspective will be obviously different from rheumatology context, but I will try and be to the point. Takayasu arteritis, I have no disclosures to make, no relationship with any industry whatsoever. Takayasu arteritis was first reported in 1830, and this is the most common large vessel vasculitis which we see in pediatric age group. Let me tell you, because I'm a congenital heart expert, so I see adults with congenital heart disease as well. So the perspective will be obviously including both pediatrics and grown-up children, I would say. We all know that it's a chronic granulomatous inflammation, and it primarily involves major branches and pulmonary arteries. And it results in a segmental stenosis, occlusion, dilatation, and aneurysms. Interestingly, Takayasu was not a cardiologist or a rheumatologist. He was an ophthalmologist who actually first reported and published the characteristic findings which we see in Takayasu arteritis. And his context was ischemic neuropathy of optic nerve with annular arteriovenous neoanastomosis. So why does Takayasu arteritis matter to pediatric cardiologist or a cardiologist who looks after children? Very high mortality in pediatric age group. If you compare it with adult Takayasu, this is the only condition other than Kawasaki disease where we see coronary artery disease. We hardly see coronary artery disease in pediatric age group, but this is one condition where we do see coronary artery disease. And of course, these patients, because they have cardiac involvement at the time of diagnosis, hence it's not a rheumatology disease only. I think what presents in pediatric age group is hypertension, coronary artery disease, aortic regurgitation, and of course, most importantly, heart failure. So it's one of the things which is more common in terms of presentation in pediatric age group to a cardiologist than a rheumatologist, although we manage these patients jointly. And I think one of the important things about Takayasu arteritis is the delayed diagnosis. By the time it comes to medical attention, the child may already be in remission, or what we call a quiescent phase of Takayasu arteritis. And of course, Pakistan has a very high incidence of tuberculosis, and there is a correlation, although it's not a proven correlation, between Takayasu and tuberculosis. Let me start with a case scenario. This is a 14-year-old girl, thin, lean girl, presented with shortness of breath and chest pain for 3 months. There was history of palpitation, exercise intolerance, and headaches. 6 months ago, she developed fever, lethargy, and weight loss. Although there was no history of contact with tuberculosis, she was put on ATT. Pediatricians do that all the time. If we get a history like that, most of these children, particularly if they are undernourished, will be put on ATT. But when we examined that patient, she had cold left upper limb with reduced radial and brachial pulse volume. And of course, there was discrepancy and femoral pulses were feeble. As a cardiologist, if I see femoral pulses either being absent or feeble, the diagnosis is coarctation of aorta, full stop. So the only other condition other than coarctation which we will consider will be, of course, Takayasu arthritis. And you can see the limb difference in terms of blood pressure. Of course, her CRP was slightly raised, ESR was 40, and Mantoux was negative. This was the echo, which shows classical left ventricular hypertrophy, which you can see in both four-chamber and log axis view as well as on M mode. We went ahead and did a CT angio. And you can see she had a long segment, what we call coarctation of aorta. Head and neck vessels were also involved, and that's how you will differentiate from a congenital coarctation and Takayasu arthritis. Because congenital coarctation, even if ever involves head and neck vessels, it's only their origin and not distally. If distal vessels are involved, it's almost always Takayasu arthritis. We went ahead and did an angiogram. You can see on the left of your presentation here, over here, a long segment coarctation of aorta. You can see we put in a balloon to begin with to see how it inflates, and you can see a stent has been put in at the site. The moment we put in a stent, you could see that the bottom part of that vessel was also narrow and stenosed. So we went ahead and put in a second stent, and you can see the last angiogram showing very nice profile with no pressure gradient across that long segment coarctation, which on original CT looked like a very simple lesion, ended up with 2 stents. Of course, we started this patient on steroids. After stenting, was discharged home. My rheumatology colleagues at my institution obviously were looking after this patient when it comes to medical treatment. They started her on methotrexate as an adjunct therapy, along with folinic acid, vitamin D, calcium, both were deficient. And she has been on antihypertensive treatment since then and is being followed up. So you can see how pediatric patients with Takayasu arthritis would present, and if present early, could effectively be treated actually. And that treatment, of course, would involve intervention. If you look at the etiology, it's not a very common disease, like 2.6 per million per year worldwide, and 90% of these patients are diagnosed before 30 years of age. Of course, there is some female or significant female predominance, which is more so in adult population than in pediatric population, and the mean age is 12. So we as pediatricians are more likely to see Takayasu arthritis rather than an adult cardiologist or an adult rheumatologist. And I think in a country like Pakistan, where tuberculosis is so common, this co-prevalence adds to diagnostic complexity as well. And it is the vascular complications which really lead to morbidity and mortality. How do we diagnose, or what are the criteria which are being used for diagnosis? I think the mandatory thing is angiographic abnormality of aorta and its major branches. Unless we see that, you cannot make a diagnosis of Takayasu arthritis. And this day and age, I think most of us would go for either CT angio or MR. And I think once we have that, then of course, plus either one of these 4, 5 criteria: decreased peripheral pulses, blood pressure difference between the 2 arms or forelimbs, bruit over aorta or its major branches, hypertension as per normal pediatric criteria, and of course, raised acute phase reactants. Although in adult population, your criteria would be slightly different, like age at onset, weight loss, limb claudication, vascular bruit, again, absent pulses, vertebral or carotid artery abnormalities, abdominal aorta, and conventional angiographic abnormalities. This is the classical classification that we use in clinical practice in terms of involvement of various parts of the arch. If it's only the head and neck vessels, it's type 1. Of course, it involves ascending aorta, type 2A. If it involves also the thoracic aorta, we call it type 2B. And type 3 is where it is also involving the renal arteries. And of course, type 5 combines all the features, or if the whole of the arch, including head and neck vessels, as well as renal arteries are involved. And we add C or P if coronaries are involved or pulmonary arteries are involved. They're not invariably involved. They may be involved, but not in every case, and you would obviously classify it according to that. And if we look at the relative prevalence, the most common area which is involved, you can see, is thoracic aorta, 9 to 69%. And similarly, superior mesenteric artery and renal arteries. So the etiology of hypertension will not only be the involvement of aorta, but also involvement of renal arteries. And that's why the management becomes much more complex and difficult. So how do we differentiate a pediatric Takayasu arthritis from an adult Takayasu arthritis? I think age range, you can see our age group is usually 12 to 17. On the contrary, in adults, it's usually up to 40 years of age. In adults, females are far more involved than when it comes to pediatric population. We see them as hypertension. That's why they end up with pediatrician, with a pediatric cardiologist rather than rheumatologist. But hypertension in adults is relatively less common. Cardiac involvement is almost always there. Renal artery involvement is almost always there. Aortic type, of course, more common to have the entire arch involved. So type 5 and 6, where you also see coronaries and pulmonary arteries being involved. More common constitutional symptoms. The diagnostic delay in pediatric age group is usually 1 to 2 years. But in adults, and I will show you a case, can be decades actually. By the time they come to you, you might have missed the diagnosis for 10 years or maybe even longer. And of course, mortality is significantly higher because of cardiac involvement. So what are the red flags? Hypertension. Any child or adult with hypertension, please look for Takayasu as a possibility. Of course, we are not used to. We have the largest series of coarctation which we have reported in the literature. And you believe me or not, majority of these patients were adults who had been seen for years and years, but nobody checked the femoral pulses. So if you do not feel femoral pulses, you will not pick it up. So I think that discrepancy between upper limbs and lower limbs and presence or absence is crucial. Of course, aortic regurgitation, coronary artery disease, and most importantly, once they get into heart failure. 50% of pediatric population would also have cardiomyopathy. Because by the time you see them, they have developed hypertensive cardiomyopathy. So they will develop dilatation and dysfunction along with severe hypertension. So how do we approach them? I think red flags are, of course, clinical. Remember to feel pulses in both arms. Remember to feel pulses in lower limbs. And of course, bruit and other things will be something which a cardiologist will be more accomplished. But I think femoral pulses, any physician can feel femoral pulses. Raised acute phase reactants. Most important imaging is CT angio. In our setup, it is CT, but if you ask the rest of the world, MR is probably more approachable because it does not have radiation associated with. And of course, you can confirm it by using various criteria that we do in clinical practice. One of the important things is to see is the disease active or not? It's crucial for me because I'm an interventional cardiologist, and if I'm going to intervene on that patient, I need to make sure that there is no activity. And that's where I would involve the rheumatologist. I will request my rheumatologist to see if there is an activity, the child needs medical treatment, and once the activity has settled, only then I would consider doing an intervention, whether that's balloon dilatation, surgery, or stent implantation. And you can see there are various criteria. All of these are extrapolated from adults. There are not enough randomized controlled trials in pediatric population to actually validate these criteria which are being used for adult population. So how do we manage them? I think, of course, there are three contexts of management. The medical management, which will involve obviously immunomodulating drugs, treatment of hypertension, and prevention of thrombosis. We routinely use aspirin in these patients as an agent to prevent thrombosis. And of course, in certain selected cases, once the activity has settled, then you will either go for surgery or intervention. I think you are more qualified for medical treatment than what I would be telling you. But just to highlight, I think the first line treatment in all these patients is steroids. We use high dose prednisolone, 1 milligram per kilogram per day, maximum of 60 milligrams per day. You can use IV pulses as well for severe life-threatening Takayasu. And in pediatric patients, we use IV pulse plus low dose, which is often preferred. And once we have achieved the remission, then we start tapering them. And these are the guidelines which we follow at the moment. Of course, you can add on once you feel like, and the drugs which are being used in pediatric population are methotrexate, azathioprine, and of course, many other drugs. Cyclophosphamide is reserved for very severe cases. And I think since the biologics have come in, most of the people would use biologics rather than using cyclophosphamide. So that's not really something which is being preferred. But all the data on biologicals in pediatric age group is an extrapolation, because pediatric studies are so limited in terms of numbers that there are no randomized controlled trials on these drugs. Of course, interventions are either surgery or intervention. And that's again, if it's a coronary artery involvement, it becomes easier. CABG is obviously preferred because it has a lower restenosis rate in these patients as compared to angioplasty. Angioplasty in a patient with coronary artery disease and Takayasu is extremely difficult. You will need multiple stents and still you will not be able to achieve the good result. Of course, if it's aortic regurgitation, you need to replace the aortic valve. But if you find aneurysms and hypertension, long segment coarctation, the treatment is intervention and not surgery. Surgery in these patients can be extremely high risk. So that is where the role of an interventionist comes in. Of course, for pulmonary hypertension, you can treat the underlying disease and PAH. Percutaneous transluminal angioplasty is the palliative procedure which we perform, and I think the success rate is anywhere from 56 to 80%. This is the largest series from India. There is a recent paper also from the same group where they have used covered stents instead of normal stents. You need to do pre-intervention imaging to make sure that you get the exact segments and exact involvement of branch arteries as well. Once you have done that, then it's done under general anesthesia. You need a femoral access. You use heparin, complete hemodynamic and angiographic data, and then you use guide wire to cross and multi-track catheter for the procedure. You can see the procedure here. We are using a balloon here to dilate that very hard fibrotic vessel. You can see some degree of success. You can see the complete disappearance of waste. But once we did the angiogram again, you can see a very irregular pattern of that aorta. So same rules apply as for native coarctation. You try low pressure balloons first. If it works, great. Otherwise, you will do high pressure balloons and stenting. And these are the different covered stents we use in these patients, particularly the CP stent. Before I finish, I thought I will show you an adult case. This is a 38-year-old female, mother of 2 children, had severe headaches, but BP was checked in right arm always. And it was always low. Until her real nephew, who is a renowned pediatric cardiologist from US, came and actually examined her in full. Found that she had almost absent pulses in right arm and completely absent pulses in femoral arteries. And the cardiologist who was checking the blood pressure would always check it in the right arm. And because the right arm was involved, it would always come low. So nobody bothered to actually investigate her further or examine her further. And she had marked left ventricular hypertrophy, stenotic innominate, and CT confirmed classical Takayasu arthritis. And this is the angiogram that we did together. You can see very abnormal aorta. We went ahead and did a balloon dilatation first, didn't work. We did the measurements and went ahead and put a covered stent in that particular area. You can see a long covered stent being put in at the side. You can see the dilatation of covered stent and the final result, you can still see some narrowing at the top because we were not able to dilate that fully. But her hypertension resolved, of course, on treatment, and she is extremely well. She can see a major change in her life since then. Remember the complications. Because these are very fibrotic, stenotic lesions, you can create dissection. You can produce aneurysms and aorta can rupture. And I've seen that in a live case of Takayasu arthritis in CSI Frankfurt, where it ruptured and they had to put in 2 covered stents in that particular patient. Of course, malposition, restenosis. Lastly, how do you monitor them? Of course, 4-limb blood pressure measurements. The prognosis, there is a relatively high mortality. Cardiovascular disease is the #1 cause of death, and the modifiable mortality risk factor is hypertension. Of course, if the coronaries are involved, that actually affects the long-term prognosis significantly. And there is a very high relapse rate. So you need to be very careful, and it is really a combined management by both rheumatologist and pediatric cardiologist. To sum it up, I think Takayasu arthritis in children is more dangerous. It's 2 times higher mortality than adults, and that is driven by cardiovascular complications. We see Takayasu first because it is usually unexplained hypertension, aortic regurgitation, or heart failure. And 30% of these patients have coronary artery disease, which is often silent, and routine coronary screening is essential. Of course, diagnostic delay is harmful. Each month of uncontrolled inflammation would lead to premature or permanent vascular damage. And I think use of biologicals have changed the outlook of these patients, because if you can use them and reverse the process or at least manage them, and then once they are in remission, then the cardiologist can come in and go ahead with either surgery or intervention. But it must be in its remission phase. And that's why close collaboration between cardiology, rheumatology, and surgery is crucial. Of course, interventional treatment is effective palliation in short and medium term, and a combined surgical interventional treatment may be necessary. It's a lifelong disease, remember. It is a lifelong disease. You keep on having remissions and relapses. So I think serial multiple interventions and a medical supervision by a rheumatologist. Every child with unexplained hypertension, absent pulses, or heart failure deserves a vascular diagnosis. Thank you very much. I will be happy to answer any questions if there are any. Sure. We monitor them with serial CT. Ideally, they should be monitored with MRI. But because availability of MRI is an issue, and in pediatric age groups, sometimes even doing an MRI is an issue. So we monitor them with serial echocardiography and CT. Of course, you go on and do acute phase reactants, their ESR, CRP, and a very close collaboration with rheumatologists.
Sir, one question. When you measure the blood pressure, it is always different in different limbs. So what is the accurate measurement of the blood pressure? What do you recommend? It should be intra-arterial or something else while you are giving the antihypertensive especially, whether these antihypertensives are working or not. So what should be the accurate measurement of the blood pressure while dealing with Takayasu arthritis?
Very good question, because that's really the tough part. Most of the times what happens is that usually one of the limbs would have hypertension out of the 4 limbs, and that usually becomes your reference points. But in a very rare case where there is none of the limbs actually has a high blood pressure, then once you have done an invasive monitoring, you would know the difference between the actual and what you are measuring, and you need to keep a record of that. That's the only way. Otherwise, each time you cannot do an invasive monitoring.
Sir, a similar question, sir. What if if it is not a pulseless disease? The pulses are present and palpable, and still you are suspecting Takayasu. How do you suspect that?
Sorry, I didn't get the question properly.
The pulses are present, the peripheral pulses are present, but we don't know. But as a cardiologist, your suspicion is that it is Takayasu disease. So what should a rheumatologist proceed as?
I think if all the pulses are palpable, what actually that tells you that your major head and neck vessels and your descending aorta is not involved. And that's how, but your renal arteries could be involved, your coronaries could be involved, your pulmonary arteries could be involved. So a CT angio would still be required to make sure, because unless you have an evidence of arthritis and involvement of an artery, you cannot make a diagnosis of Takayasu arthritis.
Thank you so much.
My question is, while I'm working in a ordinary course in a platform, shared chest pain, I have two things in my mind. Takayasu arthritis, and the second sort of thing is Kawasaki disease. This is my difference, right? For the chest pain in a young, how I proceed? Is CT angiography or should I start with some medication? What is my approach towards a young patient presenting with chest pain and I have two differential diagnoses, Takayasu arthritis and
Kawasaki. Thank you very much. That's a very good question. For me, it's relatively simple because what I will do is after getting an ECG, I will do an echocardiogram. I make diagnosis of Kawasaki disease on echo because to make a diagnosis of Kawasaki disease, you need to have coronary artery dilatation. And coronary artery dilatation is classically seen with Kawasaki disease. You will have aneurysm formation, and the only thing which will be involved will be coronaries. In Takayasu arthritis, of course, 30% of the patients may have coronary artery involvement as well, but that's stenotic lesion and usually not an aneurysm. And they will also have involvement of aortic arch in addition to the coronary artery involvement. So diagnosis of Kawasaki disease is fairly simple because there is only involvement of coronaries and no involvement of major vessels. In Takayasu arthritis, you have involvement of major vessels. I will do an echo first as a cardiologist, and most of the times I will be able to differentiate whether it's Kawasaki disease or Takayasu arthritis.
Adult patients that Takayasu arthritis is our diagnosis. Temporal artery biopsy is the first line, or temporal artery pulsation is there, or they are coming, they get blind with that Takayasu arthritis. Should we start practicing or should we wait on the biopsy? Is temporal artery biopsy, my question, is the diagnostic test for Takayasu arthritis in adults?
I would let an adult rheumatologist answer that, but if you ask me, involvement, obviously temporal artery involvement is one of the major clues towards the diagnosis of Takayasu arthritis. So if the CRP is raised, if ESR is raised, and there is evidence of activity, you should start steroids before waiting for biopsy. Thank you very much. Thank you.
I have a question. So in a patient with Takayasu arthritis with renal artery involvement who presents to us with raised blood pressure and has fibrotic renal artery, the disease is controlled, ESR CRP is now normal and there are no constitutional symptoms. How can we help the patient in case of renal artery involvement?
You will have two types of patients who would have renal artery involvement. One, those who would also have abdominal aortic involvement as well as renal artery involvement. And second, very rarely you would have only renal artery involvement. If it's only renal artery involvement, we will go ahead and stent that. If it's an adult patient, we go ahead and stent those patients.
In a fibrotic vessel,
oh yes,
you
can stent. You will have to use a covered stent because it's a fibrotic lesion. So for a fibrotic lesion, ordinary stent may cause dissection. But if you use a covered stent, you can actually dilate those vessels very nicely. If it's a arch involvement as well, then you always treat the proximal lesion first. So we will treat the arch first, the descending aorta, stent that first, and then go into both renal arteries and stent them as well.
And cardiologists are performing this renal artery stenting, and which centers in Lahore?
We do not, unfortunately, have many interventional radiologists in the city. So that's why we are doing it. Ideally, renal artery stenosis stenting should be done by an interventional radiologist.
Thank you, sir.
Thank you.
Thank you, Dr. Masood, for this highly enriching talk on Takayasu's arthritis. Now I would call upon the stage Professor Dr. Tafazul Haq Mahmood for souvenir presentation to Dr. Masood Sadiq. Connective tissue diseases encompass a diverse group of complex autoimmune disorders that often present with overlapping features and diagnostic challenges. Mastery of subtle clinical signs and practical insights, commonly referred to as clinical pearls, can significantly enhance early diagnosis, guide appropriate investigations, and refine management strategies. Such practical knowledge is invaluable in improving patient care and outcomes in daily clinical practice. We're deeply honored to introduce Professor Dr. Janet Pope, an internationally renowned expert in rheumatology. She holds an MD and MPH and is a fellow of the Royal College of Physicians of Canada. As Professor of Medicine at the University of Western Ontario and Division Head of Rheumatology at St. Joseph's Healthcare, London, Ontario, Canada, she has made significant contributions to research, education, and clinical care globally. We look forward to learning from her vast experience and expertise. Please note that this is a pre-recorded talk.
Hello, I'm Dr. Janet Pope, a rheumatologist and professor of medicine in Western University, London, Ontario, Canada. And it's a great pleasure to talk to my colleagues at the Pakistan Rheumatology meeting again this year. I wanted to reinvent a talk that I gave successfully at the American College of Rheumatology that I thought you might enjoy. It's Secrets and Pearls of Rheumatology, and I'm going to base on connective tissue disease for this talk. These are my disclosures. So I want people to become more familiar with clinical signs and symptoms, some pathology reports as well, for your patients with connective tissue disease, and hopefully have some practical pearls for when you're seeing these patients. So we'll first talk about lupus. So these are some of my patients. You can see the malar rash. There's Jacquard's arthropathy, terrible photosensitivity in the bottom row. And the upper row, a patient with livedoid vasculitis. So this can be painful. It's different than livedo-reticularis, and it can ulcerate. Livedo-reticularis, which is painless, and another sun-sensitive but discoid deeper rash on someone's anterior chest, and many other features. So the first thing is not all lupus rashes are created equally. Different rashes have different risks of the patient having lupus that is systemic. So in other words, if someone has a classic malar rash, nose, across the margins of the cheeks, sparing the nasolabial folds, and it's not acne rosacea, it's not something else. If you have a malar rash, your patient has systemic lupus erythematosus. Whereas if they have discoid lupus, it is far less likely that they have systemic lupus, even though, of course, systemic lupus can have people with discoid lupus. So what do I mean by that? So these are from various sources, so there's a range. But if you have discoid lupus, so you present, say, with a lesion on the angle of your jaw or your upper arm or your forehead or something, and it's a biopsy of discoid lupus, 5 to 10% of these patients will have systemic lupus. So most won't. If you have systemic lupus, 1 in 4 or 25% will have discoid lupus. If you have subacute cutaneous lupus, like the picture in the middle, you can see here that it's a man and it is photosensitive. Half of those patients will have systemic lupus and half won't. Whereas if you have systemic lupus, 1 in 10 to 1 in 6 will have subacute cutaneous lupus. Malar rash, as I said, about 100% of these people should have systemic. And in systemic lupus, about half our patients will have a malar rash, so certainly not everyone. Any lupus rash occurs in about up to 1 in 3 to 1 in 2 of our patients with lupus. So depending on the rash, your risk of lupus will vary. And you can see in the first picture my patient who has scarring. Lupus that is discoid is commonly in the ears, on the face, angle of the jaw, the neck, upper arms, anterior chest. And it can be worsened by the sun, but it doesn't have to be. So there was a nice review done recently that you can read about for the types of cutaneous lupus. And in some studies now, you have to identify in research trials which type or types of rashes the patient has. So the other thing that's important in cutaneous lupus, the words matter. We're not always going to see the slide and look at it. And if I looked at it, I might not know what I'm looking at. But we are looking at key words: vacuolar but interface dermatitis, follicular plugging. There can be hyperkeratosis on the thickened outer layer of the skin. It can be band-like, but you're looking for lymphocytic infiltrate. And if they do histology and then start to stain with antibodies and complement, you're looking at a positive lupus band test, especially IgM and C3. But IgG would be more specific than IgM. So when you're reading a biopsy, if they say could be lupus, ask for the actual report on pathology, as it can be helpful, especially what I've highlighted in red. So what about lupus rash versus inflammatory myositis rash, so dermatomyositis features? So the clinical pearl here is the location. So in systemic lupus erythematosus, or you might sometimes call it LES, depending on the translation, in systemic lupus, in general, you're getting a rash between the knuckles. So between the MCP and PIP, or between the PIPs and DIPs. In dermatomyositis, you're getting it on the knuckles to start with, which would be Goitron's sign or Goitron's papules if it's raised. However, in this patient here where you can see a rash all over the place, it might be sparing some knuckles a bit. It's on the MCPs though, it's on the proximal fingers. Which is it? So when a rash is bad enough in systemic lupus or dermatomyositis, it's difficult to tell. So it's how did it start? Does the patient have pictures of it? So you can see lupus on the bottom one, then dermatomyositis across the knuckles, and then someone that could have had lupus and it got worse. And then the bigger picture here is another patient with dermatomyositis. The other thing is some things are called lupus, but they aren't. So both of these are patients with sarcoidosis who have lupus pernio. And you can see it quite obviously in the second picture where the woman has a lot of changes of raised areas on her forehead, on her cheeks, especially on her nose and down on her chin. Whereas this other patient is quite subtle because she's been treated. The one patient is from the internet. The other patient is one of my patients. So lupus pernio is from sarcoidosis. So in Canada, we have a lot of sarcoidosis, but it varies by region. It would be less common for you in Pakistan. So they're indurated, purplish, often raised, shiny lesions. Papules are common. Nose, cheek, lips, ears, fingers, and it can scar in tattoos. How do we make a diagnosis? The biopsy should be able to tell us. What are we looking for? We're looking for granuloma, and it should read compatible with sarcoidosis. So we have giant cells, which aren't common, but if present, they can be pathognomonic. And these giant Langerhans cells can also be in some different diseases, but they're pathognomonic if you think it's sarcoid in the location I showed you. But they can be associated, which it would be on your differential in Pakistan, with other mycobacteria. So the location might be different, the history would be different. You're looking for other mycobacteria. But again, the pathology report can be very helpful. So again, the other thing in many of our patients with rheumatic diseases is many rashes are lymphocytic. So I'm going to highlight some that aren't. And lupus, it's lymphocytic. dermatomyositis, mixed connective tissue disease, and Sjogren's in general. You can have other things happening. What about other rashes? An adult onset Still's disease, lymphocytes and neutrophils. Rheumatoid vasculitis is a neutrophilic rash. Sweet syndrome, neutrophilic, and you could think of that going with a biopsy around the neck, high fever, etc. Pyoderma gangrenosum, neutrophilic. Then we have fibrotic rashes, such as in systemic sclerosis, morphea, eosinophilic fasciitis, so the laying down of collagen. We have protein deposition, such as scleromyxedema. Lichen planus has dense lymphocytes, and in general, I diagnose lichen planus only because of a biopsy, index of suspicion. And then some rashes are eosinophilic. Some dermatomyositis, they're mostly lymphocytic, but can be eosinophilic. And EGPA, so eosinophilia with EGPA, so eosinophilic granulomatous polyangiitis. And this is a patient with Sweet syndrome. And again, in Pakistan, this could mimic an infectious disease. Fevers, high inflammatory markers, it's spreading, the patient feels sick and unwell. You do the biopsy because obviously the treatment wouldn't be antibiotics, it would be immune suppression. Okay, let's move on to lupus nephritis. So in lupus nephritis, again, to have a good quality biopsy, you need them to describe what they've done. We need microscopic, we need EM, we need the description of activity and chronicity, and we need to know where there is immune changes. So the on the mesangial areas, as a for instance of IgG complements being laid down. So we actually need all those features. And you are familiar in general with the World Health Organization classification of lupus nephritis. And the ones that we talk about treating are class 4 and 5. But class 6 is poor prognosis. It can be in anything, having then scarring and damage. And class 3, we might indeed want to treat if they have active systemic lupus erythematosus elsewhere, or if it's worsening. So they're the things we're looking for. So this is a patient of mine who gave obviously consent. So it is important. This patient obviously has systemic lupus. He has hair loss. He has a malar rash. He even has a little bit of a heliotrope area inside his mouth. He has oral ulcers. I know that with his active urinary sediment, he has renal lupus. I am biopsying for a couple reasons. I know the diagnosis. I want to know the severity. I want to know the chronicity. Is there damage or not? So when you have renal lupus, you must biopsy first episode. Recurrences, it's debatable. If you're not responding well after many months of appropriate treatment with lupus nephritis, there is a lot of talk about rebiopsying. Obviously, ideally, if we had a liquid biopsy where the urine or where the blood could give us accurate information on activity, the extent of activity and chronicity, then we wouldn't need to rebiopsy patients. At this point in time, if in doubt, get a needle in their kidney, not us, our colleagues to do that for us and get accurate information. So the quality of the biopsy is important for activity and damage, for diagnosis and prognosis. What about APS in the kidney mimicking lupus nephritis? And we need to know the classification. So light microscopy, immunofluorescence, and EM are all necessary. And as you're well aware, we had our 2023 guidelines from EULAR. We have the new ACR guideline summary that was from 2024, and we have the KDIGO. And just to remember, obinutuzumab is the new one. So we have belimumab, some kind of CNI. You might have voclosporin. In Canada, we don't. We use tacrolimus still. If we're using a CNI, and we have obinutuzumab, and many other trials will read out over the next year, anifrolumab, and many other drugs as well. So we will have a lot of options, and hopefully they'll be affordable for my patients and for yours as well. So the other clinical pearl in lupus nephritis is the SGLT2 inhibitors obviously are used regularly to help proteinuria, including our lupus patients. But GLP-1 might also help lupus nephritis. It's traditionally thought about where available is using it in atherosclerotic heart disease. SGLT2 are used in heart failure, but both of them actually now have data of helping lupus nephritis, and we might be combining them. So what do I mean by that? This is an editorial we did where we were showing the SGLT2 inhibitors in lupus. Some of these are case series, some of these are emulation trials. If it's an emulation trial, every one of the patients has diabetes. So obviously they're already used in diabetes, but there's added value in lupus nephritis even without diabetes, shown for some of the other nephritis conditions from rheumatology trials. No RCT in SLE, and we wouldn't do an RCT now because the data really do help renal survival if the patient has proteinuria. However, the GLP-1 receptor agonist, so that's your weight loss kind of drugs, but also help in heart disease, they also can reduce heart attacks, as we know, DVTs, but also what you might not be aware of is renal progression and all-cause mortality. So when you have chronicity damage in your kidneys, you often have atherosclerosis of renal arteries and arterioles. So that's probably where it's working its best effect. So now what could happen? My patient with lupus nephritis might be on an ACE inhibitor, but for proteinuria, might be on diuretics for hypertension and controlling fluid balance, as well as the ACE inhibitor. They'll be on a GLP-1 maybe as well, and for sure an SGLT2. So things are changing. Another clinical pearl in lupus nephritis, you can slowly taper to discontinue treatment of lupus nephritis only after the patient is in remission for about 5 years. So don't start tapering unless if there's a tolerability issue, and do not stop treatment until long-standing renal remission, because recurrence might be what puts your patient into renal failure. So the win lupus is not a winner. So withdrawal of immune suppression and lupus nephritis, after 2 years of treatment, if the patient wasn't in deep sustained remission, there were more flares. And if you withdrew quickly, there were more flares. So the flare rate, if you didn't withdraw over the next year, was 1 in 10. It was 1 in 4 if you withdrew immune suppression. So please keep your patient immune suppressed for a long time and keep them in remission before you even think of slowly tapering. So what about class 4 or 5 treatment? So it should consist of what we call triple therapy: mycophenolate mofetil or cyclophosphamide, glucocorticoids, hydroxychloroquine, of course, as the backbone, and then another immune suppressant. And that could be the ones that we've talked about, and even more will come to market. Again, there's always affordability issues, so we use other CNIs. We don't use cyclosporin because high enough doses will give hypertension and renal impairment, but we use, instead of voclosporin, we use tacrolimus because of access issues. And then all these other things, our colleagues might be better than me treating with proteinuria, hypertension, fluid balance, electrolytes, lipids, and all the cardiovascular risks. Get them to exercise. You're going to treat their lipids. You want to have target high BMI, or BMI that is ideal, not high. What about inflammatory myositis? So again, this is one of my patients. She has breast cancer, and she has a heliotrope rash. She has a bit of a malar rash. It doesn't seem to spare the nasolabial folds, but some days it certainly does. And she has on treatment Goitron's sign, they're not raised, and she has some periungual erythema. So this is a dermatomyositis patient, and it is perineoplastic. So you don't need cancer screening beyond the usual recommendations in all patients with inflammatory myositis. However, they need their regular recommendations, mammogram, stools for occult blood, or colonoscopy, looking at testicular cancer in a young man. Like, you're going to do some kind of search, but you need to do usual cancer screening for your country. So for us, it would be stools, mammogram, etc., rectal exam. But for low-risk patients, routine screening is adequate, but who's low risk? So the main antibodies, if you're able to get the extended myositis panel, anyone who is NXP2 or TIF1 gamma needs a more involved cancer workup. In some countries, it might be PET scan. In other countries, it might be pan CT scans of chest, abdomen, pelvis. So my patient had the breast cancer presenting first as chemo was dampened down and finishing, and dexamethasone was then done as part of her chemotherapy. Dermatomyositis developed. So she is indeed NXP2 and TIF1 gamma. So she's a high risk patient, and she's will be continued to be treated for dermatomyositis, and obviously PET scan being done to see if the cancer has recurred, etc. So high cancer risk, TIF1 gamma, NXP2, everybody should memorize that. They need the look. So antibodies act differently in an orchestra versus solo as well. So you don't have to learn everything, but learn NXP2 TIF1 gamma equals cancer till proven otherwise. It still might not be true, but till proven otherwise, look for it. So these are another way of looking. This is an older paper that I looked at. So some antibodies are associated more with dermatomyositis and ILD, or inflammatory myositis and cancer, and inclusion body myositis will have different things going on. And that's from unicorns, dragons, and polymyositis. So you have to just be aware. And every year, I think a new antibody is being described. But you're going to remember your NXP2 and TIF1 gamma equals look for cancer more than usual screening. So another pearl is rashes in inflammatory myositis can have the same pathology on biopsy, even though they look different. Mechanic's hand, a heliotrope, goitrons, the shawl and cape sign all might look very similar, if not identical on biopsy, but we go, these aren't identical at all. So again, use your words. You're looking for interface dermatitis if you're doing a biopsy. Usually these are classic and we don't need a biopsy, and there's other features that suggest dermatomyositis, but it can be confused with other connective tissue disease and other problems as well. If you're not sure, you're looking again for interface dermatitis. You heard that kind of wording in lupus rashes. Vacuolar changes, you heard that wording as well. Inflammatory infiltrate, you heard that. But you're looking for mucin deposition, and you're looking for some differences in biopsy findings. If you said to the dermatopathologist, if you're lucky enough to have one at your center, is this systemic lupus or inflammatory myositis, no muscle weakness, normal CK, ANA strongly positive, other antibodies pending, they will help to tell you the difference, but it can be very difficult. So lupus can look like inflammatory myositis. Different inflammatory myositis, dermatomyositis features might look the same on biopsy. Weird. ANA patterns, of course, can be helpful. So not everyone gets ANA patterns, but speckled, homogeneous would be common ones. Nucleolar, we're thinking of systemic sclerosis more commonly, but it can be another pattern. It can be in lupus. Centromere, of course, we're thinking of limited cutaneous systemic sclerosis, but it can occur in Sjogren's. And peripheral or rim is often a strongly positive double-stranded DNA. There are many, many, many more patterns now, but you're going to see most commonly the first two that are on the screen there in our patients. So the first thing on anti-nuclear antibody is please don't order it if you have a low index of suspicion of its usefulness. If a patient has fibromyalgia and she sunburns easily, don't order an ANA. That person is not described as even any criteria for lupus. And if it's positive, it doesn't change your mind. So that's the first thing. Many, many positives. There's way more positives. There's probably 100 times more positives that are false than real, because about 1 in 3 women might have a positive ANA, whereas only 1 in 1,000 would have lupus. And don't repeat a positive ANA. It is a total waste of money if it was positive to see if it's still positive. We don't care. All you need is one positive ever as one of our criterion. So all you need is an ANA never, or once in your life if you have a medium or high index of suspicion. Also, the extractable nuclear antigen ENA can only be positive in a negative ANA if the patient is Rho positive, Rho or SSA. All other ANAs are, if they're negative, then your ENA is a waste of time and money. So if I'm expecting that a patient, I'm looking in a pregnant woman with Sjogren's, ANA negative, I'm going to do the Rho because I want to know if she's Rho positive, SSA. But in general, if you have a positive PMSCL and ANA is negative, it's a false positive. If you have a positive topoisomerase 1, that's SCL70, and ANA is negative, it's a waste of time. It's negative. Just don't do an ENA if the ANA is negative. Just order a Rho if you're looking for it in the right index of suspicion if the ANA is negative. So in other words, all anti-nuclear antibodies are antigens in the nucleus, which is in your blood cell, except for Rho can be perinuclear or nuclear. So I think that will save you money, and you can teach the referring physicians. So if the AN is negative, don't order an anti-DNA. So again, anti-double-stranded DNA is in one place. It's in the nucleus. Single-stranded DNA can go out and talk to our mitochondria for cellular machinery, etc., in the cytoplasm. But single-stranded DNA, we all have had a single-stranded DNA possibly after an infection. If ANA is negative, do not order the ENA. You can order Rho if you have an index of suspicion of Sjogren's, cutaneous lupus, but don't order the ENA and don't order the double-stranded DNA. So at this point in time, I'm hoping that in conclusion, you have thought about lupus and rashes differently, dermatomyositis, rashes differently, lupus nephritis, that we really have to be polypharmacy appropriately for these patients. And when we're ordering tests such as ANA, double-stranded DNA, and ENA, that we really realize these tests are only helpful if we use our brain. Perhaps AI will help you, but I think if your index of suspicion is low, don't keep looking, and don't repeat a test where your index of suspicion is low. A referring physician that sends a patient negative ANA, strongly positive double-stranded DNA, you say it's a false positive, never repeat it again. The patient has fibromyalgia or gout or mechanical back pain or a post-COVID issue or something. Do not keep reordering. It doesn't prove anything. You just say, the only way a double-stranded DNA can be positive is if the ANA is positive. So the kits are no longer specific and they're too sensitive. Remember, a double-stranded DNA came from the HEP2 liver cells from sheep. Now it's ELISA and other ways of looking, and it lost its specificity. It is too sensitive and non-specific. So again, I hope you have a wonderful meeting, and I hope to meet people in person at another year of your meeting. Thank you very much.
We're grateful to have learned so much from Dr. Janet's talk on connective tissue diseases. Now moving on to the last talk of this session. Dermatomyositis remains a challenging autoimmune condition characterized by complex immunopathogenesis and variable clinical manifestations. With the advent of mechanism-driven therapies and emerging phase 3 clinical trial data, the management paradigm is rapidly evolving. Staying abreast of these advances is essential for clinicians to deliver personalized, evidence-based care and improve patient outcomes in this difficult-to-treat disease. It's a great pleasure to introduce Dr. Julie Peck, a leading authority in myositis research and clinical care. She serves as Associate Professor in the Division of Rheumatology and Co-Director of the Myositis Center, as well as Director of Clinical Trials at Johns Hopkins Bayview Medical Center, Baltimore, USA. Her work at the forefront of translational research and clinical trials positions her uniquely to share cutting-edge developments in this field. This will also be a pre-recorded talk.
Great, thank you so much for having me here today. I will be discussing dermatomyositis in 2026, mechanism-driven therapy and emerging phase 3 evidence. These are my objectives for this talk today. First, I will be reviewing some early proof of concept studies of JAK inhibition in dermatomyositis. And then I will delve into highlighting the key findings of a recently published and completed phase 3 trial of brepocitinib in dermatomyositis. And then lastly, I will then contextualize these findings in relation to earlier studies and clinical practice. These are my disclosures. So I don't think I need to tell this audience about the heterogeneity of the clinical presentation in idiopathic inflammatory myopathies. It can be quite challenging, but also very rewarding because our patients can present with so many organ manifestations, including obviously the skeletal muscles and the skin, but also interstitial lung disease with pneumomoniostinum, for example, with MDA5 dermatomyositis, and cardiac involvement, which can be quite challenging, especially with myocarditis to treat. But despite this heterogeneity, I would say the myositis community has tried to gain some clarity by dividing patients with myositis into different subgroups. And I think in the past 10 to 15 years, we really appreciated there were 4 main subtypes of myositis, including dermatomyositis, immune-mediated necrotizing myopathy, inclusion body myositis, and of course polymyositis, which is really a diagnosis of exclusion. But I would say in the past 3 to 5 years, there's been a greater understanding that there may be even more nuanced, distinct subgroups of myositis. And those are anti-synthetase syndrome. And there's been an international collaboration through this classification project that really anti-synthetase is unique and a distinct entity. And lastly, I think we are going to be hearing more about overlap myositis because these patients have been conventionally ignored in clinical trials and always excluded. And I do think there will be some changes in the next 5 to 10 years about really including these patients and also understanding and classifying them better. Now, moving on to treatment paradigm of myositis, I think I probably did discuss this a couple of years back, but I wanted to bring this slide back and say, we're still kind of in this old era of using steroids and using one of these agents. And this is largely based on uncontrolled trials and case series. And how do we decide? It's usually based on expert opinion and what we have available for our patients. But it is also, of course, as a rheumatologist, we're trying to finely clinical phenotype our patients and determine whether a patient has more joint involvement with their skin and muscle disease, in particular for dermatomyositis, versus if they use methotrexate in that case, or if they have more lung involvement, we tend to reach for azathioprine or mycophenolate. And of course, we have looked at our Johns Hopkins myositis registry in conjunction with our leading expert, Dr. Sonia Danoff, in the ILD, Interstitial Lung Disease Center, where we try to look retrospectively and see if is azathioprine or mycophenolate more effective, which one is more efficacious, and it looks pretty much the same. And I think this is why we don't have any head-to-head studies, but maybe in the future we can actually do more large-scale studies that can look at this using cohort registries data. But as I was saying, the reason I'm bringing this slide up again is because this is a paradigm that has been perpetuated over many, many years, as you can see, since the 1990s, since we started treating myositis patients. And it's always been this empiric step-up therapy. We'll start with one of these DMARDs, and then we usually add one of these other agents, depending on if they have dysphagia or if they have rheumatoid arthritis, in conjunction with myositis, we use rituximab. But I think the field is really changing. And one classic example is in dermatomyositis. I think in the past, 10 to 15 years and more, the first publication about the importance of type 1 interferons was in the 1990s. And similar to lupus patients, we know that patients with dermatomyositis can have really high type 1 interferon signature in the blood, in the muscle tissue. And I'm going to highlight some of that in our proof of concept trial briefly and then delve into the phase 3 data. But knowing that the type 1 interferon pathway is so important in dermatomyositis, it was not a surprise that there was a publication out of Germany back in 2014 where they reported an accidental use of Jakafi or ruxolitinib. In the US, it's called Jakafi, but I'm not really sure here in Pakistan. But it was used to treat a dermatomyositis patient. And of course, there was this controversy that you're treating the myelofibrosis, and this patient was an accidental discovery that the patient's dermatomyositis improved. And so there was controversy whether this was really mechanistically made sense to use a JAK inhibitor in dermatomyositis. But I do think the authors, Dr. Hormug here, initially really reported back in correspondence saying that it really did mechanistically make sense to use a JAK inhibitor because it does block the downstream pathways of type 1 interferon. So after that case report was published, around the same time, there was also a case series of patients from Brigham and Women's by Dr. Ruth Ann Voigels, a leading dermatologist who studies autoimmune skin diseases, about using tofacitinib for refractory cutaneous dermatomyositis. And since then, obviously, we also had a case report, one of the first case reports from our center where I had a patient where we used tofacitinib for refractory dermatomyositis, where not only their skin disease improved, but also their muscle disease improved on quantitative strength testing. So these were the initial case reports and early clinical observations supporting JAK inhibition. And that really led to a collaborative clinical trial from Hopkins, where I was the PI or the principal investigator, to design a trial that will ask the question of whether inhibiting this interferon JAK signaling, because we know interferon is a key driver of disease activity in refractory dermatomyositis, and questioning whether tofacitinib will reduce the skin and muscle weakness in our patients with refractory dermatomyositis. So I named the study of tofacitinib in refractory dermatomyositis, and this was the first proof of concept clinical trial as an open label study of 10 patients where we were able to actually have all the patients completely wash out of all their agents, including IVIG, methotrexate, azathioprine, mycophenolate. They had to be off of everything. And they were given monotherapy with tofacitinib 11 milligrams XR daily. And based on what I had read in the RA literature when tofacitinib came out and was FDA approved in 2012, we decided to use week 12 as the primary endpoint. And this was important because you will see that this also led the foundation for deciding when the phase 3 trial of when to start the steroid taper. But I will discuss that a little bit later. But I think these first early proof of concept trials can, yes, of course, we would like to see efficacy, but it can really open up the field in a sense that if you have the clean mechanistic data to show whether the disease medication that you're trying to use works or doesn't work, it really gives us that foundation needed to move forward to either a phase 2 or phase 3 trial with much more confidence than just blindly choosing a drug. And so I think this was the case, and I was very grateful that back in 2015-16, when I wrote this protocol, was able to incorporate, skin biopsies, needle muscle biopsies, muscle MRI, and also research blood, and also included a mandatory steroid taper to really assess the true effects of monotherapy with tofacitinib. So the primary outcome measure we used was this 2016 ACR EULAR myositis response criteria as measured by the total improvement score, or the TIS. The weighted scores from 0 to 100. And you can see there's these 6 clinical domains, including the physician global, patient global, manual muscle testing, the health assessment questionnaire disability index, muscle enzymes, and the extramuscular activity or disease activity score. And minimal improvement is 20, moderate is 40, and major is 60. So what you're going to see here in this proof of concept study that was published in 2021 was that you can see that there was at least, out of all the 10 patients who received the drug, which there were only 10 patients, the median total improvement score was at least 40 in all these patients, which is, significant in a sense that the patients did have more than a minimum improvement. And also, one of the striking observations that you also see duplicated in the phase 3 trial was that these patients responded very quickly at week 4. The biggest limitation, however, of this proof of concept trial is that there was no placebo group. And I think this is a big limitation. But, a picture is worth 1,000 words. And you can see clearly, like, you cannot hide the skin improvement. And this patient's baseline skin score of the CDASI, which is the cutaneous dermatomyositis activity and severity index, where the skin is scored by how red it is and how flaky it is. This patient's score at baseline was around 57, and at week 12 was almost completely resolved, except just a little bit left in the posterior neck. And the V-neck sign you can see significantly improved by week 12 as well. And in terms of the additional mechanistic data that provided more robust evidence that this pathway can be actually very beneficial in targeting, was using the skin biopsies and showing that STAT1 was definitely upregulated in these 2 patients, as you can see here. This is the first patient, and the second row is the second patient, where this is very highly upregulated, STAT1. And then by week 12, with monotherapy with tofacitinib, it was significantly diminished. We also looked at chemokines to better understand downstream regulators of type 1 interferon and type 2 interferon. And we not only looked at CXCL10, but also CXCL9, which was surprising because I had actually hypothesized that more CXCL10 would be downregulated, because that is primarily driven by type 1. But CXCL9 was also downregulated, as you can see with the 2 asterisks here, was also statistically significant. And this is primarily induced by type 2 interferons, highlighting that maybe these refractory patients, both type 1 and type 2, are upregulated, and these are why these patients don't respond to more traditional medications. In addition to gathering chemokine data, we were able to do muscle MRIs, and you can see that pre and post treatment, there was improvement, but this is qualitative, and there could be some limitation because I may have to convince you that there was edema here, and then this improved, and the subcutaneous edema was here, and it also improved in the posterior muscles with the muscle edema. And so this is why I will show you a little here, this slide, that we took a bit of a deeper dive, and this is just recently accepted for publication in ACR Open. It's in press, but we also took a deeper dive and wanted to quantitatively show improvement using diffusion weighted images. And fortunately, gratefully, that when I designed the trial, I wanted to capture quantitative improvement because of my given long-standing interest in muscle MRI. And so we were able to go back and actually quantify these scores with diffusion weighted images and show that here, this is the STIR image, and there's improvement here in the muscle edema, as you can see in the posterior compartment. And then we were able to quantify, looking at diffusion weighted image and doing a ROI, that this improvement was quantifiable and also correlated with improvement in muscle strength. Now, going back a couple slides, in addition to the muscle MRI, we wanted to understand mechanistically if type 1 interferon signature was downregulated. And you can see here clearly there was a 40-fold downregulation or inhibition of type 1 interferon, log-fold change, and also for type 2 was greater than 30, about 35. And this is highlighting again what I corroborating what I showed you with the STAT1 downregulation. The skin biopsies are also showing type 1 interferon downregulation, and the muscle was also showing type 1 downregulation as well. And we were able to also incorporate a interferon score, looking at all the gene signatures of interest in the muscle. And you can see here in this volcano plot, you see IFI27, MX2, ISG15, which are very classically upregulated in dermatomyositis patients in the skin, but also in the muscle. And so we were able to calculate the score. And we a priori said if the score was greater than or equal to 1 of a log fold change, that was significant. That was statistically significant. And we even took it further and said if it's greater than 2, it's significant. Obviously, the log fold change, and it was statistically significant. But as you can see here, the average interferon score change was about a 6. So it was definitely, even though a lot of these patients had more refractory skin disease, the target organ of the muscle that we all see as rheumatologists was definitely downregulated after treating with tofacitinib, highlighting that it can exert its therapeutic effects in the muscle. All right. So that's kind of the foundation of how JAKs were starting to be used in a very well-designed, I would say, proof of concept trial. And of course, we were very excited to see this. We're very lucky to see this kind of efficacy results. And this is why we also did a long-term extension to see safety and also efficacy. And we went out to week 96. And you can see for sure the skin, there was definitely continued improvement with people tolerating the medication. And that is why actually when the pandemic happened, very lucky that once the trial was completed, it was like the last patient, last visit was at the time of the pandemic when it started. So it was good because everything was shut down at Hopkins, and I'm sure it was also the same in Pakistan, unfortunately, with the pandemic happening. And so during this time, we were trying to understand whether JAK inhibitors, what is the international use of JAK inhibitors? What is already published since the completion of our clinical trial, of the proof of concept clinical trial? And what we did was we did a systematic review, and you can see the total records was about 749, and we reviewed 313 unique records. And we actually took that December 2014 as the start point when that ruxolitinib was used in dermatomyositis as that initial case report, and out to August 2021. And you can see there was 84 unique adult patients and 34 publications in adult dermatomyositis. And there were also in JDM, you can see there were about 15 unique publications as well. So certainly there's a lot of use of JAK inhibitors in JDM. But bottom line, what did this systematic review tell us? It told us that there was a lot of overwhelming evidence that cutaneous disease, there was no doubt that there were many publications, and all patients had improvement, and the skin disease tended to improve between 4 and 12 weeks of treatment. Versus muscle disease, there was significantly less, almost half, 14 publications, and only 16 patients where there was some improvement in the muscle. And I think that was the biggest question for me, and it was a question I received a lot, was in the adult dermatomyositis patients, the initial study that we completed of 10 patients, I only had 2 patients who had significant muscle weakness, right? And so the question was, yes, I know it works in the skin. There was no question, and you can see that there was a lot of publications supporting that as well. But for muscle disease, I couldn't confidently say, even based on our proof of concept trial, that everyone or a majority of the patients were going to improve. And so when a small biotech company had approached me about trying to do a bigger study, either a phase 2 or phase 3 trial in dermatomyositis, I was very excited, but I wasn't 100% sure if it was going to work in the muscle. But I was excited because there was a biotech company who was very interested in targeting patients with rare diseases and also a strong unmet need, and trying to do a bigger trial. And so that drug was brepocitinib at the time when I was approached by them. And I would have to say, I didn't know that much about brepocitinib, but what we knew at the time, in discussing with this biotech company, a Priovant, was that it had already been used in psoriasis with some degree of success, but Pfizer was not going to move forward with using brepocitinib in further development. And so this company decided to go in together, 50-50 with Pfizer and Priovant, and try to look at drug diseases where this drug can actually be very helpful for patients. And so obviously one of the diseases that have a high unmet need at the time during this pandemic, when I started to talk to this company, was actually dermatomyositis, because we know type 1 interferons are much, as I told you, as I discussed, was highly upregulated in these patients. And so we're excited that, that they actually decided, by listening to all of the KOLs in the US, including myself, and also internationally everywhere, that this could really be potentially a drug that can work in dermatomyositis. And so this drug is a first-in-class oral selective TYK2 JAK1 inhibitor. And as you can see here, it's an inhibitor of the catalytic domains of TYK2 and JAK1. This dual TYK2 JAK1 inhibition, when I remember talking to them, during the pandemic about this drug, was that it uniquely targets both type 1 and type 2 interferons. And it can also, target IL-6 and IL-10, IL-12, and IL-23. And there are some benefits because in contrast to the non-selective JAK inhibitors like tofacitinib and baricitinib, there's no kind of undesirable effects on the JAK2 and 3 pathways like hematologic side effects. And it is thought to be a bit better than pure JAK1 inhibition, because there's no impact on TYK2 and you're not going to be getting as much type 2 interferon down suppression. And so based on this, we designed a protocol that actually would target a large population of patients with dermatomyositis and try to capture those patients who have real world clinical disease. And so what that trial at the time was, when we designed it, and I have to say, I do have to give some kudos to the company, because of the fact that they really listened to all the KOLs, key opinion leaders, to design the best trial for our patients with dermatomyositis. So what did this trial entail? The eligible patients were definite or probable dermatomyositis. They had to have at least minimal skin disease activity. Remember, 5 or less is remission. So anybody with minimal skin or higher was greater than or equal to 6. Muscle disease activity had to be less than or equal to 142, meaning they needed to have at least mild weakness. And then they had to be refractory or intolerant to standard of care therapy. And the permitted background therapy was an oral immunosuppressant. For example, they had to be on methotrexate, azathioprine, mycophenolate, tacrolimus, and they could also be on a antimalarial like hydroxychloroquine and or oral corticosteroids. But they cannot be on like methotrexate and azathioprine together, not two oral immunosuppressants. And as you can see here, it was a tall order because the FDA, the FDA actually said you have to do a 52-week treatment period, which is very different from the IVIG study, prodrome trial in dermatomyositis, where they allowed a 16-week study. So this was a tall order, because trying to put patients in a trial for a year can be very challenging. But, we did it. And this 52-week study had 3 arms, so brepo 30 milligrams, brepo 15 milligrams, and placebo. And as I was telling you, there was a mandatory steroid taper that was enforced in the clinical trial. And it started at week 12 because, as I told you about our initial proof of concept study of tofacitinib in refractory dermatomyositis, that was the time point where we thought the drug at least started to work at week 12. And the taper was drawn out to week 36. And after that, the taper could be further enforced at the investigator's discretion. And the primary endpoint here again, time point was 52 weeks, 1 year. And the endpoint was again that total improvement score that I showed you, where there's 6 domains that capture physician and patient global muscle enzymes, muscle strength, and disability index, the patient-reported outcome measure of health assessment questionnaire. So what did the VALOR study enrollment look like? So it was a global study where I was one of the global leads, but you can see that there were multiple US sites, and about 40% were from US and Canada. And then there were European sites, as you can see here, including Hungary, Israel, Germany. And then in South America, Chile was also strongly represented, and Mexico. And there were 2 sites in Asia, including Taiwan and also South Korea. And I was going to say that there were 241 patients that were enrolled, which is quite large. And I'm sorry, 244. So this is the baseline disease characteristics. As you can see here, the mean age was approximately 50, and the females were predominantly represented. And I already told you about the regional distribution. Duration of disease less than 3 years versus greater than or equal to 3 or more years. So I thought it was a good representation all across the board, across the 30 milligram group, which is the high dose, and then a 15 milligram group, and then placebo. There was also prior history of neoplasm. So you may say, of course, the patients who had, cancer-associated dermatomyositis were excluded. So if you had a cancer within 3 years, you were excluded. But if you did have squamous cell cancer of the skin, you were allowed within a year. And if you had thyroid cancer within a year, you were also allowed, as long as that was treated and resolved. And then there was also, as I was saying, these are when we designed the study, we really wanted to include those who had, real world disease, as I would say it, like, cardiovascular disease. A lot of our patients have hypertension. So anybody with hypertension, obesity, coronary artery disease, as long as they didn't have angina for like 3 months prior to enrolling, they were allowed into the trial. So about 67% or 60% all across the board had more than one cardiovascular risk factor. There was also a history of ILD that was allowed, but you couldn't have severe ILD being on oxygen to enter the trial. So about 20% across the board had ILD on entry to the study. Now, for baseline disease and treatment characteristics, the muscle strength score, as you can see here, maximum is 150, meaning you have 5 out of 5 strength all across the board. But here our patients had about 120, which means they had at least 4 minus out of 5 strength in multiple muscle groups. And the CDASI activity score is also out of 0 to 100. And you can see, remember, you could just have mild skin disease, but the average skin activity score was around 19.5, 18 to 21 across the board. And that means that they had at least moderate skin disease activity. And their disease disability index, as a patient-reported outcome measure, was 1.28 in these groups, 1.2. And this is indicative of at least mild to moderate disability. And this is a questionnaire that a patient fills out that captures like how much muscle pain do they have? Can they get out of a chair without, disability? There's multiple questions. It's like almost 7 domains of quality of life that they are answering these questions. So again, 0 to 1 is, no weakness. 1 to 2 is mild to moderate weakness, and 2 to 3 is severe, not weakness. 2 to 3 is severe disability. Okay. Now, the medications at baseline, most of the patients were on a non-steroidal immunosuppressant because that was required by the clinical trial. But of course, if you were not on it and you had active disease, you could enter it with just being on Plaquenil as well. Or if you had side effects, you could be on prednisone and a oral immunosuppressant, as I was telling you, methotrexate, azathioprine, mycophenolate, or tacrolimus, but not combination therapy of the oral immunosuppressants. And the mean steroid dose was about 12.2, 10 to 12.2 across the board. And 2 or more DM medications means that they were on either an oral immunosuppressant and oral steroids, or oral immunosuppressant with an anti-malarial plus steroids. And again, not more than 20 milligrams of prednisone was allowed at baseline when entering the Valor clinical trial. So about 20% across the board were also treated with IVIG, but clearly had a failure to IVIG, and they were entering the Valor clinical trial. So what is the patient disposition? As you can see here, 241 subjects were randomized, and the 30 milligram experienced the highest completion rate and lowest rescue rate. If you were rescued with steroids, then, after the taper period, then you were considered as a non-responder. But as you can see here, 93% completed the blinded treatment period, and only 12 subjects, or 15%, received rescue medications. In stark contrast, you can see the placebo group, 82% completed the blinded treatment period, and 30% received rescue medication. And rescue medication is steroids or primarily steroids, higher dose of steroids, and also increased dose of their baseline immunosuppressants. And I'm largely going to be talking about the Brepo 30 milligram group and comparing it to the placebo group. And I will explain later, but there was some dose response. There was some response with the 15 milligram group as well. But the company is not moving forward for FDA approval with the 15 milligram because it was not as statistically significant by week 52. But as you can see here. So this is I would say, money slide, the key slide from the clinical trial that we were all involved in. And you can see here the top is a 46.5, and that means there's at least, moderate improvement. And this 37.5 was not statistically significant from the placebo group, and that's the 15 milligram arm. And this is why the 30 milligram arm is the one that's moving forward for FDA approval. But again, you can see that by week 4, it's a brisk response. These patients getting this drug had an early response at 4 weeks, similar to the proof of concept study trial that I led, the study of tofacitinib in refractory dermatomyositis. Here you're seeing that early response by week 4, and it's sustained durability out to week 52. And so it was very statistically significant. The change in the TIS was about 15.3, the delta, and that was statistically significant compared to the placebo group. And here is also a very important aspect of this trial. This mandatory steroid taper really allowed us to ascertain the direct effects of brepocitinib in these patients because they're not on background steroids, and they were able to taper the steroids. And look at this marked improvement of 62% were able to taper to less than 2.5 milligrams at month 12, and 42% were off steroids by month 12, which is more than double what you see in the placebo group, which was great. And I'd like to happily report that this was our clinical trial was accepted for publication in the New England Journal of Medicine in March 2026, March 28, just a few weeks ago. And we're very excited to see that it was accepted for publication because it is very clinically meaningful for our patients to potentially have this new drug available for our patients. So that was the primary endpoint. The secondary endpoints, a priori, you can see, the CDASI, which is the skin assessment, the DMOMS. This is a new dermatomyositis outcome measure developed by Dr. Vicki Worth at University of Pennsylvania. And this is really trying to get at those patients who have a myopathic disease. And you'll see some future papers on this coming out of this trial, but this also met statistically significant results. And here, I'm not going to go through all of them, but all of the secondary endpoints and the primary endpoint met statistical significant results in the 30 milligram arm. So going back to that initial question of do JAK inhibitors work in the muscle? And unfortunately, I'm sorry that this did not come out properly, but this dark blue, it should be dark blue on the top. So the Brepo 30 milligram arm, definitely on the top here, you can see, definitely had improvement in muscle strength. And you can clearly see here that it started to show improvement in the muscle strength scores at around 18 weeks, and it was sustained out to 52 weeks. So it was great to see this data because it answered my question of whether JAK inhibitors, JAK in particular, maybe because this is JAK-TYK inhibitor, works to improve muscle strength. Now, it is slower than, the skin disease, because as you can see here, for the skin disease, you're seeing it show improvement as early as 4 weeks. But I think that, physiologically makes sense because for skin, there's rapid turnover of the skin. You can see the results quickly versus muscle takes time to regenerate and the inflammation to go down. So I don't think it's a surprise that it will start to kick in a little bit later for the muscle disease. But look at this here. For the skin disease, the change from baseline in the activity score was at 4 weeks and sustained out to 52 weeks, and it was at least 11.7-point difference from the placebo group. And that change is statistically significant and clinically meaningful because there is data out in the literature to show that if there's at least a 5-point change in the CDASI activity score, that means that it improves quality of life tremendously in our patients with dermatomyositis. Similarly, disease clinical remission for cutaneous disease is a CDASI activity score of less than or equal to 5. And at week 52, you can see 44% were able to achieve that clinical remission by using the Brepo 30 milligram arm. And these are the representative pictures of the patients who showed improvement at week 12 and week 52. And you can see this posterior shawl sign improving gradually and almost completely resolved by week 52, similar with the V-neck sign. And there are also demonstration of the resolution of severe and ulcerative skin disease by week 52. And this, ulcerative disease at baseline in the elbows completely resolved here. And then in the face also completely resolved by the forehead also at week 52. Now, I think we want to always take it to another level in these clinical trials. And it was great to see when analyzing this data with the team that, the initial ProDerm trial using IVIG in dermatomyositis that was published in the New England Journal in 2022, the FDA only required a TIS of 20, which is minimum improvement, right? There's TIS 20, total improvement score 20, then there's TIS 40, and then there's TIS 60. I think now we've really moved beyond this TIS 20, right? That minimum improvement, we can do better. And so the question was, did Brepo actually do better than a TIS of 20? And you can see with overwhelming evidence here that there was rapid and sustained achievement of moderate response of TIS greater than or equal to 40. About 68% were able to get to that TIS of 40, a moderate improvement at week 52. And it was seen as early as week 8 and sustained out to week 52. And then TIS 60, which is major response, this is a high bar, you can see about 43% were able to get to that by week 52 as well. What about taking it to another level from response to remission? So if we define achievement of low disease activity as a physician global of less than 4, patient global of less than 4, and being on steroids less than 5 milligrams, you can see here that by week 52, 53% were able to achieve that low disease activity score. And for clinical remission, we don't have a good definition, but we defined here as that is published, but we defined here for the purposes of this data analysis that it would be a physician global less than or equal to 1 and patient global less than or equal to 1 and steroids less than 2.5. So even a stricter definition of clinical remission, and more, about 24% were able to achieve that clinical remission, which is nearly 3-fold higher than placebo, which is, I think, great to see. So the summary of the safety data, as you can see here, because the biggest question was, fortunately, nobody died, which is great, because we don't want to see any deaths in any clinical trial. And the side effects you can see here, the serious adverse events were primarily infections and not surprisingly zoster, viral reactivation, but it was 5%, and you can see it was also seen with placebo, probably because they were on, steroids and their disease was not well controlled. But overall, the cardiovascular events and thromboembolic events were not very high at all, as you can see here. And it was more prevalent in the placebo group, highlighting that potentially, not controlling someone's disease is more concerning than putting on a patient worrying about their side effects. Now, I do want to be careful and say this is phase 3 data in very, uh, a very select group of patients with dermatomyositis, over a 52-week period. So I think we do need, over time, more data like in a phase 4 data to see if there are going to be any other more severe adverse events over time. Now, I think this is almost my second or third last slide, but I just wanted to highlight that I think we're really moving into a modern era of targeted therapy. And Valor represents a unique milestone, I think, because not only is it the largest dermatomyositis clinical study ever conducted, as you can see here. But of all these trials I have here, ravulizumab was a failed trial. Ustekinumab also. FCARD is still ongoing, so hopefully we'll see the results of this. But this only had about 30 patients enrolled with a dermatomyositis. IVIG, I love IVIG. We use it all the time in our patients, but 95 patients. This is 241 patients in this clinical trial. And I think this is highlighting a new era for our patients with dermatomyositis. So this is a summary slide of brepocitinib. It's a first positive 52-week placebo-controlled trial in dermatomyositis. And I know there's a lot of points here, but if I had to give you 3 points about this trial, the take-home messages is that brepo works quickly. Within 4 weeks, benefits were seen. It's durable, sustained out to 52 weeks, 1 year. And lastly, it's a targeted therapy that is directly exerting its therapeutic effects on type 1 interferon pathway. And so I think we're heading into this new era that we're not going to be just doing step-up therapy gradually, but we're going to use a drug that we know mechanistically makes sense in dermatomyositis patients. So this was an old review article that I did, not that old, but 3 years ago. I guess now it's getting older. So if I had to update this figure, I would say with this data, I would really use brepo early on. We have another, in addition to IVIG, we have a new drug that we can use that's oral once a day for refractory skin and muscle. I think this is a very exciting time for all of our patients. So again, in conclusions, I hope I was able to impart to you that these early proof of concept mechanistic trials can be valuable signals for later phase 2-3 trials. And again, efficacy was quick at 4 weeks, durability out to 52 weeks, and skin and muscle both had improvement after treatment with brepocitinib and dermatomyositis. And the decision for the FDA approval, they did an expedited review, which is excellent because it's a rare disease. And in the US, we're expected to hear the results of approval or not, hopefully approval, by late August of 2026. So thank you for all, especially to all of the Valor trial patients, investigators, and coordinators and staff who made this study possible. And thank you for your attention. And I hope to join you potentially next year in person, if possible, and if you will have me. Thank you very much.
Bismillahirrahmanirrahim. Good afternoon, everyone, and a very warm welcome back. I hope you had a refreshing lunch break and are feeling recharged for the afternoon ahead. I am Dr. Zainab Malik, and I am delighted to be your host for this session. We have an exciting program lined up, and I look forward to an afternoon of engaging discussions, fresh perspectives, and meaningful insights. Let us begin. Seronegative arthritis presents a significant diagnostic dilemma due to the absence of conventional serological markers and the overlap of clinical features with other rheumatologic and non-rheumatological diseases. Accurate diagnosis relies heavily on clinical acumen, imaging, and a thorough understanding of disease patterns. Addressing these challenges is crucial for timely intervention and prevention of disease progression and disability. We are honored to introduce Dr. Alam Zaid Zayed with extensive national and international credentials, holding FCPS in both rheumatology and medicine, along with FRCP from Ireland and Glasgow. He is also a fellow of American College of Rheumatology. Dr. Alam brings exceptional expertise to the field. As assistant professor and head of the rheumatology department at Khyber Teaching Hospital, Peshawar, he has made notable contributions to patient care and medical education. Please join your hands together for Dr. Alam Zaid Zayed.
Bismillahirrahmanirrahim. Assalamu alaikum. Extremely thankful to the Shaikh Zayed Hospital team, especially Dr. Aflaq and Dr. Tafazzul Saab for inviting me as a speaker to this very nice scientific program. I think the people are busy in the meal and the post-meal, post-sleep effects, they will be there, but I will be discussing the diagnostic challenges of seronegative arthritis. So whenever we are talking about the challenges, it's not just only be the problem or the challenge of a single person. We all are facing in one way or another way, not only in Pakistan, but throughout the world as well. So today, the talk given to me is about the seronegative arthritis, the challenges in diagnosing and reaching the final effect of this. The learning objective for this session will be, as not all the consultants are here, there are a lot of people, they are not consultants from the GPs, along with it, the fellows, and the other concerned and clinicians allied field. So the learning objective for this session will be how you will differentiate the seropositive and the seronegative arthritis on the basis of clinicals and immunological effects. And especially, we'll discuss the makers of these seronegative arthritis. And the common and the most important part of this discussion will be the common challenges we are facing in reaching out the diagnosis of this seronegative arthritis. Okay. Do we know what are the seropositive and seronegative status, and on which basis we are deciding about whether this is seropositive or seronegative? And this is not only a challenge for a rheumatologist. The challenge starts when somebody is coming to you with the suspicion of arthritis. You're thinking clinically, the patient is having arthritis. But the moment you send the serology, and it's come negative for these factors, we say this is seronegative rheumatoid arthritis or seronegative arthritis. Later on, basing on your clinical features and the presentation of the phenotypes, you decide whether this is seronegative rheumatoid arthritis or other type of arthritis, inflammatory arthritis. Let's discuss what are these factors. Rheumatoid factors commonly, everybody after having the joint pain, even a layman know the rheumatoid factor about, and they prescribe, they advise the rheumatoid factor for diagnosing any type of arthritis. If these tests are negative, they say there is no arthritis, because they don't know that arthritis may be present even if these factors are negative. And again, the anti-CCP antibodies is produced in the body, the same pathway with any antigen presenting to your cells, and they say If there is any citrullinations in the arginine, they produce the cyclic citrullinated peptides, and antibodies produced against it, and we call that status as anti-CCP as positive, and that positive status is called seropositivity. So these two factors are important for labeling any patient that is seropositive or seronegative. Let's discuss how many patients presenting to you with arthritis having this positive status. Any idea? And 60 to 80% with positive results of these as giving you this is rheumatoid arthritis, seropositive rheumatoid arthritis. The remaining negative serology is giving you 20%. Okay, this is an umbrella terminology and we call seronegative inflammatory arthritis. So the seronegative inflammatory arthritis is not just only seronegative rheumatoid arthritis. We have others phenotypes and other diseases of this categories, that's spondyloarthropathies. We have psoriatic arthritis, SLE, MCTD, and other connective disease, undifferentiated arthritis, viral and systemic disease-associated arthritis. But these are the mimickers, and we know that once we have negative serology for seropositive and seronegative, then we are thinking of whether this is what type of arthritis among these inflammatory arthritis. But at least we should know the features, the clinical presentation, and all distinctions. The global burden of rheumatoid arthritis on the basis of this WHO fact sheet as this 18 million people throughout the world. I don't know, some of the countries will be not having the registry for it, but at least assess the generalized WHO report that 18 million people are having rheumatoid arthritis, whether this is seropositive or seronegative, and on the basis of this, patients, they have divided it into the 70 to 80% are having positive serology for RA factor and anti-CCP, and they're labeled seropositive. But the remaining 20 to 30% are having negative serologies. If you look at the burden of this disease, that's out of 18 millions, if you take it 20 to 30%, there's a huge number of patients, they are having negative serology for this rheumatoid factors and anti-CCP. And we have challenges in diagnosing these patients at that level. So why are we concerned whether this is seropositive or seronegative? Does this matter? Yes. If we are thinking of any disease diagnosing earlier, because one of the phenomena, especially in rheumatology, is that we treat the patient according to our NN objectives, and that is the treat to target phenomena. And we only achieve that on the basis of commencing your treatment as early as possible once you diagnose it. But if you have challenges in diagnosing a patient with arthritis, definitely we'll be missing this window of opportunities, and that is important. Window of opportunities, generally we discuss it, and it's a period where your treatment can change the progression of the disease and the outcome of the disease with the treatment. And precision medicines, you know, we are heading toward the precision medicine, and nowadays there are a lot of biologics available in the market. And the pathogenic pathway for any disease, the mechanism and the origin of the disease, knowing about it is very important. If you know the pathological pathway of the disease, you can decide rightly and the right times what treatment should I offer to this patient. And that's the way it is helpful in deciding about the precision medicines and the response to the treatment. Once you know the type and the patterns, the pathogenic pathway, you can monitor the response to the treatment rightly and the right times. Even a short conventional DMARD can be decided on that on the basis of your early diagnosis and type of arthritis. I usually say you should know the ancestry of that's arthritis. Let's discuss this common scenario. At least we will have some of the idea of the common challenges we have faced here. A 30-year-old female with history of arthralgia, morning stiffness, and swelling of the joint of the hands. She visited one of the rheumatologists nearby, and the ESR and CRP, the common inflammatory marker, was negative, was normal, and the RF factor, rheumatoid factor, and anti-CCP were normal. But clinically, the patient was having arthritis. At the same time, she had multiple visits to local doctors and the GP, and she was prescribed some medications. Along with that, NSAIDs, on-off some injections, that the people are usually giving it for the common relief at that time, with some response to that. But anyway, when she visited a rheumatologist, she was diagnosed with arthritis, but she was in a denial state. How is it possible that she is having negative rheumatoid factor and anti-CCP and the inflammatory markers are normal? So how can I have the arthritis? After proper discussion and counseling, she was started on treatment and the response was very good in our proper over a period of time. So what challenges we faced here? If you look at from the very start, because referral of patients on the right time, if you don't know, is very important, especially when you don't know. And everybody, especially the patient, know, and the GPs and the common doctors are not aware that we can have arthritis without these things, and about the ESR and CRP. So we'll discuss later on in the coming slides as well. In another scenario, a 45-year-old female diagnosed with arthritis, seronegative arthritis. She was started on treatment. Initially, the response to methotrexate was good, but later on, the response was mission poor, and she was started. And she was, after discussion with her, it was decided to give her biologics therapy. Because of the time frame, she decided to receive rituximab. And if you look at her later on, it was noticed that she developed some psoriatic rash, and the response to that drug was Mr. Wayne. So what challenges we faced here? Again, the common challenges in day-to-day practice we're facing machines when they decide. So the first slide will show why we are concerned. We are concerned because we are facing these challenges, and we want to know we have to diagnose a patient early as possible, and the point pattern and phenotypes and the pathological pathway, whether this is seropositive, seronegative, or among the seronegative inflammatory arthritis, the common pattern, whether it's spondyloarthropathy, psoriatic arthritis, so that we can decide precisely the medicine that's good for the treatment. Okay, so let's discuss the common markers of seronegative rheumatoid arthritis. And the second scenario, you notice that the patient was having actually psoriatic arthritis, but it was not noticed initially. Clinically, this is very sound importance for every doctor that you should take a good detailed history, whether this is from your presentations, previous history, past history, family history at least, to exclude all others type of inflammatory arthritis before deciding and commencing on any treatment. Here we have peripheral spondyloarthropathies, that's very much, the rheumatoid factors and anti-CCP is negative. We're thinking of other type of arthritis. And if you know ABC of rheumatology, at least with the clinical presentation, you can decide whether this is seronegative rheumatoid arthritis or spondyloarthropathies, because involvement and the pattern of involvement of the joint is different in these categories. And osteoarthritis, we know that some of the osteoarthritis is presenting very similarly, especially in the nodular osteoarthritis and the recessive type of osteoarthritis that's close differential to this seronegative type of inflammatory arthritis. So we have to think of that as well before commencing on any treatment, because if you start a patient on any DMARDs for no reasons, you have to continue it, but at least to look for the response. If it is indicated, that's okay, but if it is not indicated, you are just giving the patients a wrong treatment, and they can damage the patient. So the other type of arthritis, and especially when we focus on, there's the fibromyalgia, very commonly this misdiagnosed with the seronegative inflammatory arthritis, especially in that category. Clinical assessment, as I discussed, is very crucial for your decisions, because the lab is not helping you here, and that's your clinical judgment you decide. I think it's a crucial part of your any assessment of the patient, that you have to take a detailed history, then examine the patient properly and make an assessment. And your diagnostic decision must be physical examination and patient history, not only the lab results. As in the first scenario, we saw that nothing is helping us except your clinical assessment, because ESR, CRP were normal, rheumatoid factors and anti-CCP were negative. So our force is here that being a rheumatologist or any doctors, we should not ignore these two things, the clinical assessment, the history and examinations, whether clinicians will not to believe on only labs. Is there any things that's criteria we design it? There's a classification criteria, is not a diagnostic, but still it can help us in reaching out whether this type of arthritis can differentiate from this is rheumatoid arthritis or this is another type of lesion, because it is used for the research purposes, not lesions. Is this helpful in diagnosing a patient with seronegative rheumatoid arthritis or rheumatoid arthritis? If you look at the first part of it, it's only on the clinical judgment, that as the first slide discussed lesions, the clinical assessment, you have to count down the joints, the area of the joint involvement, and then the size of the joint is important. But if you look at the immunology sections, it takes very good 3 marks out of 10. And we need just 6 out of 10 to conclude. So we remain just only 7 out of 10 to decide about the treatment. I think the specificity or the sensitivity for the seronegative inflammatory arthritis, rheumatoid arthritis has decreased with this value. Okay, now this is very important slide here. In the first scenario we saw, there's the ESR and CRP is high. First of all, any patients coming to you with the suspicion of mild disease, mild type of inflammatory disease with the not full-blown synovitis, and you think this possibly the clinical features, the history and the examination is inflammatory in nature. Does these investigations help us like ESR and the CRP, and the results come normal? So again, you are in the confusion whether should I start the patient on this DMARDs or just wait and see, because we need to start the treatment in window of opportunities. But unfortunately, the ESR is a chronic condition. Even if patients coming to you with arthralgia, arthritis, it may be possibility that at this time the patient is having some chest infection and UTI or the chronic infection in the lungs, as is usually in the practice that we see patients coming not only with a single disease, they will be having comorbidity as well. But if you talk about the CRP is an acute reactant, and the half-life is very short. It takes just only 19 hours to return normal. Even if a shot of steroids given to a patient at that time of presentation can reverse it back. It's just helpful. Okay, that's the other scenario. But that's 30 to 40% presenting to you with the seronegative arthritis inflammatory. If you're talking about the spondyloarthropathies, it's increasing to 50 to 60% of spondyloarthropathy is having normal ESR and CRP, and at the same time, the seronegative rheumatoid arthritis having 30 to 40% with normal EC. So we don't have to believe on that. So a patient with normal ESR and CRP can be having arthritis. Okay, this is very important. So ESR, CRP, and the immunology is not helping us. Do we have any other modalities or tools for diagnosing a patient with seronegative rheumatoid arthritis? Any thought? Yes, we do have. That's starting from your radiology, ultrasonography, and MRI, along with this with some more details and complicated niches, complex type of devices for digging out other type of immunological markers and some inflammatory markers as well. We'll discuss one by one here. These are the X-rays commonly taken in after the serology, the common practice when we don't have immunology, positive immunology, and the ESR, CRP is not helping us. We do advise the X-ray for, especially of the hands and the affected joints. Here in the first X-ray on the left side, you see these are the periarticular osteopenia. We see it in common and we read it out. And the second, there are some erosions, but it is helpful, especially for differentiating your one type of arthritis to another type of arthritis, and even especially the osteoarthritis as well. But if we are talking about the diagnosis early as possible, it's not helpful because the X-ray changes are always delayed. And we are talking about initiating the treatment at that time when the patient is presenting to you. It's take about it takes about 6 months to 24 months to the X-ray changes is appearing. Maybe there were some variations that are taking late, so it's not that much helpful, especially in diagnosing. It's good for your monitoring and other things, but again, a normal X-ray does not exclude your arthritis, and we are still in the confusion whether we should decide whether the patient is having arthritis or not. Okay, this is very important, especially in the new era of medicines, and this is called stethoscope of rheumatology, and we need expert in it at this era. Dr. Babar is trying to train the people, but I think we need more trained musicians. Our radiologists, again, are not a musician. They are deficient, especially in musculoskeletal radiology. And the changes in the ultrasound can impact even with the patient is not having clinical synovitis, and subclinical synovitis can be detected with these tools. And again, we have problem with that as well, because these signals, the power Doppler signals with the active blood flow is showing some inflammation, the subclinical inflammations, and some other compressibility and displacements. They are the rules there usually fall to look for echoic and anechoic lesions. But again, it's highly operator dependent. We are not trained that much. Every rheumatologist not trained in that, and the radiologist again not trained. And we need further training for it to overlap the gap for diagnosing and delaying the diagnostic value of this. So ultrasonography, I think, is a new tool in medicine and can be added, it should be added in the training program, especially for rheumatologists to detect earlier arthritis to overcome the inflammatory markers in the lesions. MRI, again, we prescribe it, but again, we have some limitation of it. It's not available everywhere, so very expensive. We have a lot of people that can afford it. Even starting, you prescribe the MRI, who will report that the patient is having subclinical synovitis and detection of that. Late changes can be detected by the X-ray and clinical examination as well, but we need early diagnosis. And is early detection of synovitis can be packed with the X-rays, and erosion and hypertrophy and bone edema for the early detections. But unfortunately, we need a trainers for it and the radiologist. Do we have any other tests that can help in diagnosing the patients with seronegative arthritis? Yes, we do have. These are the new markers in immunological markers, anti-carbohydrate proteins, very commonly. It is positive in 34% of patients of seronegative arthritis, rheumatoid arthritis. Unfortunately, not available throughout the world machines and universally. If it is available, at least it will cover 34% of the seronegative inflammatory rheumatoid arthritis. And again, here at 3, again, as a test, it can be done, and it shows some in the seronegative and seropositive patient as well, but it covers some of the seronegative, and it shows the disease activity in response to methotrexate. The people who are positive for it have a very good response to methotrexate, and this 1433 ETA protein, it is also available in a very aggressive disease and can be detected in the bloods even earlier before the patient has clinical synovitis. These are the new markers that are available, and even if your ESR, CRP is not helping, we have these systemic immune inflammation indexes, and these are the indices of the common blood value like your platelets and your neutrophils and lymphocytes, and they have some value of the ratio of these value and give you the indices. If the indices is high, they can give you there's the inflammation is there in the clinic. Calprotectin is also an inflammatory marker and can be detected earlier, and they show this there is inflammations. The adhesion molecules, cytokine receptor and metalloproteinase and growth factors, these are the 4 different type of mutations as commonly we see, and we are looking for it. But it's available, and in complex diseases, you can look at the ratio of these diseases, these markers, to look for the inflammatory. And it is given a score of 1 to 19, it's mild disease, and it go off. So the value, if you increase the value of these, there will be. Okay, any other options here, because we are left with everything, the immunologies, inflammatory markers, radiology, ultrasonography, and everything's we done, but still it's not helping. We need some help as well. If you are burnout condition, you don't know whether should I label the patient as arthritis, because as I said earlier, this is your clinical judgment that you decide. Don't believe on the labs and other things. Yes, this is one of the phenomena commonly, and most of you and us are essentially as trying it. When we have the strong suspicion of this inflammatory arthritis, we give a trial of these drugs one by one, mentioned the way, and look at the response of that. But it is very important, especially once you diagnose a patient with one disease, the reassessment is very important, especially clinicians. Let's discuss this commonly misdiagnosed condition, the fibromyalgia and seronegative inflammatory arthritis. Most of the time, the patient is having fibromyalgia, and we label the patient as arthritis. And the same time, the patient is having arthritis, we label as fibromyalgia. And we know that 25% of patients taken as arthritis are having fibromyalgia, and at the same time, arthritis is 15 to 20%. And the two ways they are not good. If we decide this is arthritis and treat it as fibromyalgia, later on has come out this is fibromyalgia, so we over-treated the patients. And again, if it is arthritis and we misdiagnose as fibromyalgia, so we delayed the treatment and leading to deformities. Seroconversion and reassessment, you know that once you diagnose a patient with seronegative rheumatoid arthritis, we have to reassess because there is some ratio of the people presenting to you as having positivity later on if you test it. And you know, the 2 to 5% of CUPAR after 2 years if you diagnose a patient with seronegative rheumatoid arthritis. And why it is important? Because deciding about your biologics therapy, as we saw in the first scenario, we gave rituximab to a wrong patient that was later on psoriatic arthritis. So decision about the biologics and further precision medicine is important. So we have to reassess and check the serology. And anti-CCP is positive, especially for this 1 to 8% after 5 years of conditions, longitudinal pattern of the disease. So reassessment periodically, and it has been studied in the literature, show this 30 to 40% reclassified over a period of times, not only just the one type of disease, like maybe it's having spondyloarthropathies, psoriatic arthritis, or other type of disease. Okay, so the take-home messages for this is rheumatoid factor and anti-CCP are not necessary for labeling any patient with arthritis. As in the first scenario we saw, the lady was not happy for that she is having arthritis, as the rheumatoid factor and anti-CCP was negative. So I think these concepts and the myths should be addressed to the public and the common doctor as well. These are not necessary for clinicians. The clinical assessment is more important than lab, and it is especially for this category of arthritis if we are thinking of seronegative inflammatory arthritis. Musculoskeletal ultrasounds and MRI, they should be normally included in the routine labs and testing for any rheumatoid arthritis, especially any type of arthritis, because we have to commence on the treatment as early as possible. At the same time, it is also important we don't have to waste extra money on that, because we are living in a country where we are facing financial constraint most of the time. A careful monitoring therapeutic trial can be diagnostic as well as disease modifying. As I discussed in the last slide, there's if you are weighing under your clinical judgment as your clinical equipment is saying that this is arthritis, you have to start the patient on treatment and monitor it over a period of time. Always reassess, especially if the patient is not responding. And this is a key take-home message, because we have to keep an eye on the patient response and side effect of the drugs, along with their reassessment to reconsider whether we are on the right pathway. Thank you very much for bearing with me. If there are any questions, so I'm here to listen.
The therapeutic landscape of ANCA-associated vasculitis has undergone a remarkable transformation over the years, from traditional cytotoxic agents like cyclophosphamide to targeted therapies. such as avacopan, treatment strategies have become more effective and safer. Understanding this evolution is essential for clinicians to make informed decisions, minimize treatment-related toxicity, and improve long-term outcomes for patients. It is a privilege to introduce Dr. Aflaq Rashid with FCPS qualifications in both medicine and rheumatology, along with MCPS in health professions education. He currently serves as Associate Professor and Head of the Department of Rheumatology and Immunology at Shaikh Zayed Federal Postgraduate Medical Institute, Lahore. His leadership and dedication to advancing rheumatology makes him an ideal speaker on this topic. Let's give a big round of applause for Dr. Aflaq Rashid.
Zainab, thank you very much for the introduction. And let's see, can we have my presentation? So I can recall in my previous nearly 22 years of rheumatology that the systemic sclerosis was once an orphan disease. Yes, yeah, madam and sir. And now we can modify the disease pattern. So with that, we today are going to have a newcomer for us in special disease, ANCA-associated vasculitis, and I'm going to highlight regarding what we have and how we are going to be changing in future regarding ANCA-associated vasculitis. Can I have my presentation? So I'm going to discuss about the layout of this presentation is I'm going to discuss a classification of ANCA-associated vasculitis with a little bit of pathophysiology so we can understand that where rituximab, where corticosteroids, where cyclophosphamide, and where this newcomer is getting its place. And along with that, I'm going to discuss a few trial history of this drug, which has been ongoing for the last 8 to 10 years. Okay, so layout would be like that. And we know that classification is very precise, and it is absolutely clear that granulomatosis with polyangiitis has a granuloma, and microscopic polyangiitis, there are no granulomas. And the thing which Professor Tafazzul discussed in the panel discussion, that anti-proteinase 3 antibodies positivity is more related to granulomatosis with polyangiitis. Likewise, myeloperoxidase as well as anti-proteinase can occur in microscopic polyangiitis. The eosinophilic component is actually a separate animal. So I would like you to concentrate on this picture. It is an interesting picture. Don't be afraid that it is a difficult picture. Just concentrate that we have T cells and B cells, and we know that T cell and B cells combine to form activation of B cells, which later on causes makes ANCA antibodies. Likewise, neutrophils. These three agents, the culprits, starts to trigger. And what happens is that neutrophils, we know that cytoplasmic PR, perinuclear, and central antibodies are basically inside the cell, but they translocate over the cell membrane of the neutrophil, where B cell, T cell, which triggers the B cells, cause ANCA antibodies, and they combine and they further trigger chemoattraction with formation of neutrophil extracellular traps, which is going to be deposited in the vessel and cause intense inflammation, which causes activation of the complement system and cause C5a production, the complement alternate pathway activation, leading to this all inflammation. Likewise, it also activates the dendritic cells, which in turn causes further B cells to activate and also helps in formation of the granulomas. So keep in mind this picture. So in epidemiology, pediatric age group doesn't have such incidence of this problem, but if it is around 11 to 14 years, and it is usually GPA form. Likewise, in adults, GPA is more common. It is more common than eGPA. Like it occurs in 50 to 70 years in GPA, MPA, and eGPA is 40 to 50 years. Likewise, slight male predominance for MPA and GPA, and female predominance for eGPA. Now, if we can see the incidence, I just want you to focus on this globe. This is GPA and this is MPA. As we go from west to east, whole of the scenario starts to change. This is GPA, blue is GPA, and as we go towards Japan, MPA is the most one. So we don't know what are the characteristics or genetics behind this. Perhaps someday we are going to identify. So for Pakistan, if we calculate the international or global population, we could have nearly over 4,000 cases per year of either GPA or MPA. So what are the key considerations in developing personalized vasculitis treatment? Number one, different vasculitis may share similar symptoms and treatment recommendations. Each disease is distinct and each patient is distinct, and one treatment may not work in a certain patient if it is working in the previous person. As well as there is a need of multidisciplinary approach. Rheumatologists along with nephrologists and dermatologists and pulmonologists are the integral part towards a successful treatment. And there must always be a shared decision for the patient, because the patient's goals, patient's preferences are the most important things. So there is an induction and there is a remission maintenance phases of the treatment, and regular treatment is required. Regular monitoring is required for its safety. Frequent follow-ups are required. Blood testing, imaging, and we need to check the medications for its side effects. Regarding management tools, we have guidelines. They are essential for us in planning a treatment. Expert tailor the plan to specific situation, and proactive participation of the patient is also very much important. So what happens is that in induction therapy, we divided the disease into non-severe and a severe organ-threatening disease. And glucocorticoids, rituximab and cyclophosphamide remains the mainstay of the induction and severe disease phase, while in non-severe disease, methotrexate and mycophenolate can be. Usually it is in the sinus disease. So targeted advanced therapies which we have now is rituximab, and recently in 2021, 5 years ago, Rheumacon has been approved by FDA. So for maintenance therapy after induction therapy, we have rituximab, azathioprine, and methotrexate in non-renal cases. And what are the characteristics of specific autoantibodies? In the proteinase 3 ANCA, which is granulomatosis with polyangiitis, there is higher relapse risk, and rituximab is preferred. And in microscopic polyangiitis, there is more renal limited as well phenotype, and we have to individualize the maintenance duration. Likewise, we have safety snapshots as well. For rituximab, hypogammaglobulinemia, late onset neutropenia, and in cyclophosphamide, cytopenias, infertility risk, and malignancy risk. For Rheumacon, liver enzymes elevation, and for glucocorticoids, its toxicity everybody knows. So, in treatment algorithm, we have a confirm organ severity. We have to confirm the organ severity, initiate rituximab, cyclophosphamide, based induction, minimize glucocorticoids or no glucocorticoids and only avacopan, and continue rituximab maintenance in high relapse risk patients. So, this previous slide was a summary of the guidelines, which I'm just going to touch briefly, that this is the BSR guidelines which have recently been published. And again, we have a life-threatening and no life-threatening disease and for which we have separate algorithms. But we can always skip glucocorticoids now. Here it is not available yet, but avacopan is being used internationally and it has shown to be very superior to glucocorticoids in certain studies. Likewise, in severe disease with avacopan as a steroid sparing, rest of the treatment remains the same, rituximab, cyclophosphamide, or combination of both if it is severe in nature. Likewise, ULAR in 2022 also updated, and it was again the similar picture. And lastly, the KDIGO guidelines, which were published 2 years ago, also gives us an insight that the consensus between the nephrologist and rheumatologist is there, except that regarding plasma exchange, there must be a fast raising renal compromise, as well as along with alveolar hemorrhage. And rituximab and cyclophosphamide combination in the treatments. So avacopan is a selectively blocks 5A through a 5A receptor block. And how does it occur? This C5A is going to go to the neutrophil. In the next picture, I'm sure that there are also receptors for C5A here on the neutrophil, and it blocks and stops all the cascade in which it is going to cause endothelial injury and persistent inflammation. Well, this is the neutrophil, and there are receptors to C5A receptors, which triggers further inflammation and netosis, and this drug at this level stops it, while azathioprine, cyclophosphamide, and rituximab stops at the DNA level. So, how we get here? It has demonstrated effect on ANCA-associated vasculitis in phase 2 trials. Phase 2 trials, in phase 1 trials, just normal volunteers are given this drug and there are no side effects. Then in the phase 2 trials, it is given in the diseased patients in a small cohort. And in phase 3 trial, which is a larger trial, it is given and its effects are seen for a longer period of time, relatively longer period of time. So it's the first in class oral selective C5A receptor inhibitor designed to block C5A receptor. In mouse studies, it has been shown promising effects by inducing MPO, myeloperoxidase antibodies related ANCA-associated vasculitis. And likewise, I have just told you that currently they are enrolling phase 4 long-term 5-year trial in the community, and it is going to complete in 2028. So active patient selection considerations are very much important. Active disease requires steroid-sparing therapy, or when the patient requires it, difficulty in tolerating high-dose steroids, rapidly deteriorating kidney functions at presentation, and diffuse alveolar hemorrhages refractory to conventional therapy. It is not recommended in chronic liver disease or severe liver disease, and safety in pregnancy and breastfeeding is not known due to the fact that the data is not there. So before started, all the biologics, all the targeted synthetic DMARDs, LFTs, CBCs, and infection screen is necessary. And by calling and saying infectious screen, it is latent tuberculosis and hepatitis B and C infections. and vaccination should be there prior to its treatment. So, 3 guidelines to मैंने बता दी हैं. CAN vasculitis, Canadian vasculitis also included this drug, and real-world studies between 22 and 25 have shown a reduced steroid exposure and improved quality of life, though concerns have been raised about liver injury. So what are the benefits of this drug? It is orally administered. It is a steroid-sparing, relatively well-tolerated, used in combination with standard therapy of rituximab or cyclophosphamide, and can improve even kidney functions. The cons are its cost, as we know that it is extremely expensive, potential liver toxicity. It is a 30 milligram twice daily dosage, and 1 capsule which comes in a 10 milligram formulation. So 3 capsules morning and 3 capsules evening. And we do not have a data beyond 1 year, because the study which was conducted upon which it was been approved lasted 1 year. So this was the study, the Advocate trial. I'm just going to give the salient features, not going to go into the details. So there were nearly 330 patients in an Evacupan arm and in the conventional control group. So what happened, there were the endpoints were interesting, that at 26 weeks, clinical remission, and then at 52 weeks, that remission must be there. In Evacupan, after induction, Evacupan was started and given for 52 weeks, and for this segment, control arm, glucocorticoids were given, and they were tapered in 20 weeks to minimum dose of 5 milligram per day. And which patients were included? Newly diagnosed, relapsed patients having diagnosis of GPA 181 and MPA 149 with these antibodies profile, renal elements involvement, then rituximab was given in 214 patients, and oral IV or oral cyclophosphamide in 116 patients. There were 2 endpoints which I've just discussed, that at 26 weeks and at 52 weeks. And usually it was considered that the Birmingham vasculitis activity score should be 0. It is 0 to 63, and mean score in these patients when enrolled was nearly 13 to 16. And the endpoint was remission at 26 was 0, and no glucocorticoids for this disease in previous 4 weeks, and then sustained remission at 52 weeks. Secondary were the glucocorticoid-related attributes, including time to relapse to vasculitis, change in kidney functions, health-related quality of life, and safety and adverse effects. And at week 26, it was evident that Evacupan was non-inferior to prednisolone, and it was superior at 52 weeks. And we can see that this is the 26th week when active control arm, there was a 70.1, and this was 72.3, nearly no difference. So it was not inferior to causing relapse. And at 52 weeks, it even extends as compared to the conventional arm. So Evacupan arm improved the renal function, and it even improved the creatinine clearance at week 26, and at week 52 more than that. So what about this drug's safety profile? Because it is again a drug can cause this whole bunch of side effects. But in March end, there was a drug safety communication to the manufacturer by FDA. And what they say that they have found some fallacies in 9 of the 331 patients in Advocate trial, and they have asked them to reconsider their endpoints, as well as hepatotoxicity was also mentioned as a concern.
On 28th January, the manufacturer denies that they are not aware of any of these 9 patients having some endpoint fallacies, and they are not going to withdraw the drug. And as it is, its risk is far less than the benefits. And what FDA depicted? FDA identified 76 cases of drug-induced liver injury with reasonable evidence of causal association with Vacopan, out of which there were 54 hospitalizations and 8 deaths. And out of 76, 60 cases of initial liver injury, which improved later on, and most cases out of 76, 66 were from Japan. There was a study I was reading that why Japanese people have a good effect of methotrexate low dose as compared to European people. So there were certain genetic attributes which lead to a low dose increased levels of methotrexate for the rheumatoid arthritis patient as compared to the European population. So it can be something like that of an attribute causing this problem. The median time of onset of this injury was 46 days from the time of start, and out of 76 cases, 7 reported biopsy confirmed vanishing bile duct syndrome, which is a lethal disease, and 6 died from Japan and 1 from Canada. 3 of them were fatal. So what FDA recommended? FDA again recommended, like it has recommended for rest of the biologics and the disease-modified drugs, and that is LFTs every 2 weeks while starting in the first month, then monthly for the next 5 months, and then as clinically indicated. And we have to stop Vacopan if ALT or AST is more than 3 times the upper normal limit, or ALP is more than 2 times, or there are symptoms which leads towards a cholestasis, jaundice, or pruritus. And if liver test abnormalities or symptoms of liver injury do not improve, patient should be referred to a hepatologist. So in conclusion, the FDA said that DLA associated with Vacopan predominantly reported in Japanese population. FDA is continuously monitoring the patients on Vacopan, monitor patients of adverse reactions, especially in the first 2 months. So the last slide. ANCA-associated is an aggressive disease. New insights in pathophysiology directs towards targeted therapy, as we have Vacopan now. And treatment guidelines are rapidly evolving, including new options like this one. And steroid sparing have emerged as promising alternatives, and safety profile will be established as upcoming data is analyzed. And careful in decision-making and monitoring is pivotal by us, by the rheumatologist or the treating physicians. Thank you.
To conclude, the introduction of Avacopan represents a meaningful shift in management of ANCA-associated vasculitis. Thank you so much, sir, for this enriching session. Polymyalgia rheumatica is one of the most common inflammatory rheumatic conditions affecting the elderly, often presenting with significant pain, stiffness, and functional limitation. While glucocorticoids have long been the cornerstone of therapy, their prolonged use is associated with considerable adverse effects, particularly in aging population with multiple comorbidities. In recent years, the evolving role of biological therapies has opened new avenues for more targeted and safer treatment strategies. Redefining PMR management through these advances is crucial for improving patient outcomes, minimizing treatment-related toxicity, and enhancing quality of life. It is a great honor to introduce Dr. Nigat Ahmed Mir, a highly distinguished rheumatologist with exemplary international credentials. In addition to being a diplomat of both the American Board of Rheumatology and American Board of Internal Medicine, she is a master of the American College of Rheumatology. As chair of the Department of Rheumatology at National Hospital and Medical Center, she has demonstrated outstanding leadership in clinical care, education, and research. We are privileged to have her share her expertise on this evolving and highly relevant topic. Please join me in warmly welcoming Dr. Nigat Ahmed Mir.
Bismillahirrahmanirrahim. Thank you so much. Thank you for the kind introduction. सिर्फ 15 मिनट हैं, 15 भी नहीं है, अच्छा 10-12 मिनट हैं, but respected faculty and यहाँ पे ज़्यादा rheumatologists हैं या physicians हैं in audience, but अस्सलाम वालेकुम. And thank you so much for having me here, and my heartiest congratulations, Professor Tafazul, Aflaq, Shaikh Zayed team, to organize this every year. Fantastic work. अच्छा जी, मुझे तो कहा गया था कि PMR के बारे में बात करें, लेकिन I don't think PMR isolated कोई ऐसी चीज़ है, और अगर ऐसी कोई चीज़ कोई समझ रहा है तो आज पता चल जाएगा कि ऐसा कुछ नहीं है. तो इंशाअल्लाह ताला 10-15 मिनट्स में जो रूमेटोलॉजिस्ट है उनको तो सारा कुछ आता है, तो शायद थोड़ा सा उनकी नॉलेज में इजाफा हो जाए, लेकिन देयर इज़ अ टेक होम मैसेज ऑल्सो फॉर देम. सो ऑब्जेक्टिव्स जो PMR है, जो फिजिशियंस हैं, दे ऑलवेज से कि जी डॉक्टर साहब बताएं हमें कैसे पता चले कि ये रूमेटॉइड आर्थराइटिस है या पॉलीमाइल्जिया रूमेटिक, प्लीज़ गिव अस अ टॉक. रूमेटॉइड फैक्टर पॉजिटिव आ गया तो क्या वो RA है या PMR? तो आप भी सब कह रहे थे कि हमने टेस्टों को नहीं देखना. दिस हिस्ट्री एंड अ क्लिनिकल एग्जामिनेशन विच टेल्स यू द डिफरेंस. तो क्योंकि यहाँ पे रूमेटोलॉजिस्ट ज़्यादा हैं, सो मुझे फिक्र नहीं है कि वो PMR को मिस करेंगे. सो बहुत आसान कर दिया मेरा काम डॉक्टर फ्लाक ने. वेस्कुलाइटिस आपको पता है कि इट affects the entire vascular tree, and there are so many classifications. Today we are going to, and they overlap also. So what we are going to talk about today is large vessel vasculitis. और सबको पता है कि inflammation in the vascular tree, granulomatous inflammation, and obviously when it occurs, it leads to thrombosis, and all the symptoms are due to ischemia. बड़ी इंटरेस्टिंग इसकी हिस्ट्री है, और मेरा ख्याल है अगर आपको हिस्ट्री नहीं आती तो फिर आई डोंट थिंक यू कैन बी अ गुड क्लिनिशियन. दिस इज़ व्हाट आई बिलीव. वेरी इंटरेस्टिंग. आजकल मिडल ईस्ट की सारी बात हो रही है, शुक्र है पीस हो गया, बल्ले बल्ले हो रही है. पाकिस्तान की भी और हमारे मुसलमानों की तो यहाँ बल्ले बल्ले ही थी. 10th century में द फर्स्ट पर्सन टू डिस्क्राइब दिस एंटिटी was an ophthalmologist, and he was from Baghdad, और नाम भी उनका अली था. तो he said that there was some relation between loss of vision in certain patients who had some inflamed arteries. That was his first description. Then it was Hutchinson in 1890 who was treating an 80-year-old patient, described his findings as thrombotic arthritis of the aged. तो his arthritis was so bad कि देखिए सबसे ज़्यादा उनको फिक्र हेड की होती थी ना, कि his hat जो वो पहनता था तो उसको पेन होती थी. तो basically temporal arthritis began to gain popularity in 1930. जब ये पता चला कि PMR जो कि एक inflammatory condition है, we all know it leads to bursitis, tendinitis, and sometimes arthritis as well. But it is linked to another condition which is not just inflammation, but this is something else. So let's, ये केस मैं आपको थ्रो करती हूँ, एंड ये रूमेटोलॉजिस्ट के लिए, और ये मैंने अभी 2 दिन पहले ही देखी है और अभी उसको पल्स मिल रही है इस वक्त. 70-year-old woman with history of PMR, diagnosed 2 years ago. She had several relapses. Whenever you try to taper prednisone, she relapsed. She was on 15 milligram of prednisone and was tapered finally to 15 milligram daily over the past 6-7 months. But she comes back and her ESR is 70, CRP is 35, and she develops severe abdominal pain and back pain. Which of the following is the most appropriate next step in the management? इसको पढ़ लीजिए, इसके ऊपर हम आएंगे दोबारा कि क्या करना चाहेंगे आप लोग इस पेशेंट के साथ. I think rheumatologist, young faculty सोच ले, not difficult, but क्या करना है इसके साथ. So PMR and GCA is a spectrum. It's not like ये PMR है और ये GCA है. No, it's a spectrum and an overlapping spectrum. और उसके अंदर भी जब आप giant cell arthritis की बात करते हैं, so there's cranial GCA with just cranial involvement, extracranial GCA, and then an ischemic GCA. We can just present with just loss of vision. That could be the only presentation. And sometimes it's just isolated aortitis. So when you talk about PMR, you see that it's a whole spectrum. So these all things can overlap in one patient, or they can present as one entity. For example, this was an excellent study. Berlin had 367 patients, and they found out that 50% of the patients with GCA have PMR symptoms. So we look at this, you can see that cranial GCA is only present in 48% of the patients, and extracranial, which involves other vessels outside the cranium, is 21%, and then you have both, which is seen in about 22%. So this was an earlier description, and you can see that such patients can present in any clinic. Sudden loss of vision, that could be the first symptom. They could have a stroke, that could be the first symptom. The jaw claudication, and even, sometimes necrosis of the tongue, ulcers in the oral cavity. And the patient I'm talking about, she had been referred by ENT because she had an impending perforation, not perforation, in her nasal mucosa, who was having epistaxis. So I looked up the literature, and I was so surprised that patients with giant cell arthritis can have, obviously we all know visual, we all know auditory, but nasal symptoms also. So sometimes it may become very difficult to differentiate it from giant cell arthritis from GPA, because you also have sinusitis and nasal crusting and epistaxis. So it may become very difficult to differentiate the two. So we must remember that we have classification criteria, लेकिन आप पहले तो clinician है ना. Classification criteria जो होते हैं वो are there for research purposes, because you want uniform population to be recruited in the trial. So this is the ACR used LAR classification criteria for GCA, और इसका स्कोर जो देख लें कि अगर greater than 6 points है तो फिर of course आप फॉरन डायग्नोसिस. लेकिन आप क्लिनिक में कितनी दफ़ा क्लासिफिकेशन क्राइटेरिया निकाल के बैठते नहीं. इट्स योर क्लिनिकल जजमेंट, एंड वी नो दैट एज हैज़ टू बी ग्रेटर देन 50 years. अब आप 20-year-old को अगर सर में दर्द हो रही है तो आप उसको यू आर नॉट गोइंग टू से दैट शी हैज़ GCA. तो एंट्री एवरीबडी ग्रेटर देन एज 50 who has temporal headache or all these symptoms, jaw claudication, new onset headache, scalp tenderness, all this, then you consider them having GCA. आपने ये देख लिया कि टेम्परल आर्टरी बायोप्सी को सबसे ज़्यादा पॉइंट्स मिल रहे हैं, बट आपके कितने पेशेंट्स हैं जो टेम्परल आर्टरी बायोप्सी करा रहे हैं? अब जैसे ही आप कहेंगे ना कि आपकी बायोप्सी यहाँ से होनी है, यू डोंट सी देम अगेन. उनका मतलब है जी करना है तो इसके बगैर ही करें. एंड ऑल्सो बिकॉज रिसेंटली आई सेंट अ पेशेंट विद टेम्परल आर्टरी बायोप्सी, वो KPK से आया था. आलम ज़ेब तुम्हारे पास भेजा, मैंने उसको वापस. वो कहते हैं जी मुझे टेम्परल आर्टरी बायोप्सी नहीं करानी. सो भाई क्यों नहीं करानी? नहीं जी वो सब लोग कहते हैं उसका कोई फ़ायदा नहीं होता, बिकॉज वी ऑल नो दैट दे आर स्किप लेजन्स एंड यू हैव टू हैव अ सर्टन सेगमेंट ऑफ द वेसल विच इज़ एटलीस्ट 2.5 cm long, which will obviously be important to not miss the diagnosis of giant cell arthritis. तो अब आप ये देख लें कि आप सब लोग, हमारा टॉक PMR के ऊपर थी, polymyalgia rheumatica, which is not a dangerous condition as long as it is PMR. It is easily treatable with low doses of prednisone. You can start with 15 milligram and you can start tapering. And if you can't taper, you can add biologics. But some of them will have GCA. And giant cell arteritis is a surgical emergency, it's an emergency. And you see that these different studies, which were done in different countries, revealed the subclinical GCA being present in patients with PMR, at least 23% in another study, 22% in another study, 15%. So they are PMR patients, but they have subclinical GCA. Don't miss it. And we all know, अब ये तो पता ही चल गया कि 50-year-old है, women में ज़्यादा है, और जो है ज़्यादा हमारे यहाँ नहीं है. They say that it's in the European descent, but we see a lot of PMR and GCA. We don't have any studies, unfortunately, कि हमारी prevalence क्या है. And I think जब आप young लोग आ रहे हैं, कुछ prevalence studies हमारी होनी चाहिए. So when you look at this, the PMR and GCA, fever, weight loss, symptoms, aching shoulders, aching neck, gelling phenomena, bursitis shoulders, bursitis trochanteric, ये सब कुछ तो दोनों में हो सकता है. दोनों में ये सार ज़्यादा हो सकता है, CRP ज़्यादा हो सकता है. But look at cranial GCA. Look at those symptoms which we already talked about. Any patient whom you are suspecting that patient has PMR must go through this history, because आपको वो नहीं बताएंगे कि खाना जब आते हुए मुझे दर्द हो रही है. क्या अभी जो कल पेशेंट आई थी उसने कहा कि तुम्हें कभी आंखों में कोई प्रॉब्लम हुई है? हाँ, कई दफ़ा तो मुझे ऐसा लगा मुझे नज़र ही कुछ नहीं आ रहा. सो यू हैव, बिकॉज उसको क्या पता कि मैं तो इनको पास आ रही हूँ शोल्डर की पेन के साथ, तो इनका आंख से क्या ताल्लुक है. सो यू हैव टू हैव स्पेसिफिक क्वेश्चंस आस्क्ड टू मेक श्योर यू नॉट मिसिंग ऑन साइलेंट अकल्ट जाइंट सेल आर्थराइटिस. अच्छा जी, टेस्ट तो करने ही करने. ये सारा कुछ जो हम ट्रेनिंग कर रहे थे, बाहर सब कुछ देख आए थे, यहाँ कुछ भी नहीं हो रहा था. यहाँ क्या था? ESR CRP. सो PMR के लिए तो कोई डायग्नोस्टिक टेस्ट नहीं है. यस, नाउ वी हैव क्राइटेरिया, शोल्डर बर्साइटस हो, ट्रोकेंटेरिक बर्साइटस हो, ESR हो, CRP. पहले तो कुछ भी नहीं था. बट यू नो वी कैन डू टेम्परल आर्टरी बायोप्सी. इसके ऊपर 2 टॉक्स हो सकती हैं टेम्परल आर्टरी बायोप्सी पे सिर्फ. When to biopsy, not to biopsy, repeat biopsy, changes, when do the changes disappear, how does it, affected by treatment. तो ये जल्दी से अगर मैं कवर करूँ तो हमारे लिए तो बेस्ट अल्ट्रासाउंड है. गरीब मुल्क हैं, नॉट ओनली गरीब मुल्क हैं, बल्कि अब तो जो आप आगे देखेंगे उसके अंदर इट इज़ कंसिडर्ड एज स्टैंडर्ड डायग्नोस्टिक टेस्ट टू डायग्नोज जाइंट सेल आर्थराइटिस. पेट स्कैन कर लें, पेट स्कैन भी अवेलेबल हो जाता है. MR एंजियोग्राम, इट हेल्प्स. MR एंजियोग्राम इज़ वेरी हेल्पफुल बिकॉज इट टेल्स यू वेयर द डिजीज इज एक्टिव और नॉट एक्टिव. अब ये सारी जो चीज़ें होती हैं ना, ये यूलार रिकमेंडेशंस और ये सारा कुछ, ये आपके पास रेफरेंस है. जब दिल करे खोल के देख लें कि क्या कह रहे हैं. सब ये कह रहे हैं कि जो पहली चॉइस पहले हमारी है, दैट इज़ एन अल्ट्रासाउंड ऑफ द टेम्परल आर्टरी. सो अगर आपको हेलो साइन नज़र आ जाता है तो प्लीज़ बस ठीक है. क्लिनिकल हिस्ट्री, एग्जामिनेशन, ESR CRP, हेलो साइन. अब कितने लोग अच्छा अल्ट्रासाउंड करते हैं? बाबर यहाँ पे बैठा है, वो कराता है इतना अच्छा कोर्स अल्ट्रासाउंड का. बाबर, आर यू डूइंग दिस हेलो साइन? यू नॉट डूइंग द वैस्कुलर. वी शुड डू द वैस्कुलर. सो उसके बाद तो स्काई इज़ द लिमिट. MR एंजियोग्राम करा लें, पेट स्कैन करा लें, जो मर्जी करा लें. बट रिमेंबर वन थिंग, दैट GCA इज़ एन इमरजेंसी. सो बर्लिन और यूरोप में इन्होंने एस्टेब्लिश फास्ट ट्रैक क्लिनिक्स in preventing permanent visual loss. And what they do is, उन्होंने इनको educate कर लिया कि अगर patient को PMR है and they develop jaw claudication, they develop double vision, or they have suddenly loss of vision, then please forget about treating them with 10-12 milligrams of prednisone. Send them to a rheumatologist, fast-track clinic, and you will see that the blindness in such patients was remarkably reduced, as you can see, from 37%, 9%, वहाँ पे 19%, 2%. So it shows कि fast track clinics help. मेरे पास कई दफ़ा पेशेंट्स आते हैं रिकरेंट स्ट्रोक हो रहे हैं और PMR की पेशेंट है. सो अच्छा जी कोलेस्ट्रॉल होगा, ये होगा. नहीं, मतलब दे प्रॉब्ली हैव जाइंट सेल आर्थराइटिस. ये भी स्कोर है, रेफरेंस है, देख लीजिएगा. बट यू नो कि हर एक चीज़ को उन्होंने पॉइंट दिए हैं, क्लिनिकल फीचर्स को भी दिए हैं, और हर एक को एक 2 पॉइंट, 1 पॉइंट, 3 पॉइंट. बट आप क्लिनिशियन है, यूर रूमेटोलॉजिस्ट, यू शुड बी क्लिनिकली एबल टू जज. यहाँ पे इन्होंने कह दिया कि अगर लेस देन 9 है तो प्रॉबेबल है, और अगर 10 to 12 है. अगेन दीज आर पॉइंट्स बिकॉज यू वांट टू हैव अ यूनिफॉर्म पॉपुलेशन to recruit in trials. लेकिन आपकी जजमेंट सबसे अच्छी है. So ट्रीटमेंट क्या करेंगे? सबको पता है स्टीरॉयड शुरू करेंगे. सबको पता है कि पीएमआर के लिए 15 मिलीग्राम्स भी ठीक होगा. टेपर करते जाएं स्लोली, करें उसको 2 इयर्स में. अगर उसको जीसी है तो फिर तो इमरजेंसी है. फिर क्या करना है? अब बायोलॉजिक्स प्ले अ ग्रेट रोल. व्हेन वी वर बिगिन ट्रेन, पीएमआर के लिए कोई ऑप्शन नहीं था. हाँ, मेथोट्रेक्सेट पहले भी थी, फिर चली गई, अब फिर आ गई. कोई फ़ायदा नहीं होता खाली मेथोट्रेक्सेट से. सो वी हैव अ बायोलॉजिक फॉर पीएमआर. व्हाट अबाउट जीसीए? जीसीए के लिए भी बायोलॉजिक है, बिकॉज स्टीरॉइड्स sparing agents are very important, and now we know that having patients on long-term steroids means morbidity, mortality, long-term. So everybody is trying to bring in biologics to minimize the steroid exposure. अच्छा जी, अब आप ये बताएं कि एक पेशेंट है, उसको पीएमआर है, और लेकिन आपको पता है कि उसको साइलेंट जीसी है. ठीक है जी, आप उसको ट्रीट करेंगे aggressively या नहीं करेंगे? So see the difference. So actually आप ये देखें कि 4 times higher rate of relapses are there in patients who were treated with PMR and not treated for GCA. So make sure, आपने हर दफ़ा सोचा होगा कि मेरा पेशेंट को क्या है, मैं 10 से 6 पे जाता हूँ तो ये फिर रिलैप्स कर जाता है, 10 रिलैप्सेस हो रहे हैं. So think about it, that patient may have occult GCA or occult malignancy, and that's why that patient is not responding to your treatment. It's so important to make sure that you do other studies and make sure that the patient, you may do a PET scan to see if they have occult GCA, because that's the only reason they are relapsing. ये तो ग्लूकोकॉर्ड टेपरिंग कोई साइंस नहीं है, हर बंदा उसको डिफरेंट तरीके से यूज़ करता है. द गोल इज़ टू टेक देम ऑफ प्रेडनिसोन और कीप देम ऑन लेस देन 5 मिलीग्राम ऑफ प्रेडनिसोन. एंड यू नो कि हायर डोजेज आर रिक्वायर्ड इन पेशेंट्स विद जीसीए. और अगर इमरजेंसी है, इमरोसिस हो रहा है, आईसाइट जा रही है, यू डोंट वेट फॉर एनी टेस्ट. प्लीज डोंट वेट कि अब बायोप्सी आएगी या कुछ आएगा तो मैं करूँगा. वी ऑल नो दैट वी हैव टू पल्स देम विद स्टीरॉइड्स एंड स्टार्ट देम ऑन एटलीस्ट 40 मिलीग्राम्स ऑफ प्रेडनिसोन अ डे. अच्छा जी, अब लॉन्ग टर्म जो आप सबको पता है कि क्या होता है. ऑस्टियोपोरोसिस होता है, हाइपरग्लाइसीमिया होता है, हाइपरटेंशन, ये सब कुछ हमें पता है. और सबसे ज़्यादा अफसोस मुझे पता है किस चीज़ का होता है. द पेशेंट्स ऑन स्टीरॉइड्स इवन 5 मिलीग्राम्स फॉर मोर देन 3 months, ना डेक्सा हुआ है ना कुछ हुआ है, और पेशेंट जो है ना फ्रैक्चर हो रहे हैं उसके थोरेसिक वर्टेब्रा, और वो कह रहा है कि मुझे बैक पेन हो रही है. येस्टरडे आई सॉ अ पेशेंट हु हैड एन MRI ऑफ लंबोसेक्रल स्पाइन, क्योंकि बैक पेन इतनी हो रही है कि हिला नहीं जा रहा. अरे उसका तो वर्टेब्रा थोरेसिक 2 फ्रैक्चर हुए हुए. So आपको सबको पता है कि anybody on steroids should have at least a thoracic and lumbar simple X-ray. आपको silent वहाँ पे collapse vertebra मिलेंगे, and if you don't treat them, if you don't treat one vertebral fracture, it's going to have a second one and a third one, and they'll be bedridden for the rest of their lives. So इस वजह से एडवांस ट्रीटमेंट वो तो अच्छा हुआ. कहाँ चले गए अफलाक तुमने वो सारे T सेल, B सेल, IL-17, IL वो सब कुछ बता दिए. मेरा ख्याल है इस वक्त किसी को समझ नहीं आएगी. बट लेट मी टेल यू कि जो द काइनिन्स विच प्ले अ रोल इन PMR एंड GCA आर IL-6 एंड IL-17. ठीक है जी. और अब तो जैक इनहिबिटर्स भी आ गए, और उपाडा इज़ देयर, एंड होपफुली that will help us a lot, because people hate injections and they would love to swallow pills. And so, you know, sometimes when we don't have anything and patients don't want to do anything, off label आप उपाडा यूज़ कर सकते हैं अगर उसके अंदर वो रिस्क फैक्टर्स नहीं है जो कि हम नहीं यूज़ करते हैं दिन में. तो सिरिलिमैब आ गई है, और IL-17 इनहिबिटर आ गए हैं, और एक्टिमरा आ गई. एक्टिमरा किस में यूज़ करेंगे? एक्टिमरा किस में यूज़ करेंगे? लंग्स आर इन्वॉल्व. एक्टिमरा कब यूज़ करेंगे आप? इन पेशेंट विद PMR, GCA, when you are unable to taper steroids. Actually GCA में तो फ़ौरन ही शुरू करने चाहिए, because you can't keep them on 40 or 30 or 20 milligram of prednisone. तो recommendation जो है कि start simultaneously with a biologic, and Actimra or tocilizumab is here, so we use that a lot. For PMR, which IL-6 inhibitor do you use? Cirilumab It's not available in Pakistan, sorry, but सबको होश आ गई है बाहर के मुल्कों में कि PMR के लिए तो कुछ नहीं था, just steroids and methotrexate. अब IL-17 inhibition का बहुत role है, because IL-17 has been found in the wall of the vessels and how it plays around the IL-6, the IL-17, the TH-17 in GCA, and they augment each other, and you can interrupt any of them, IL-16, IL-17, and as I said, the JAK inhibitors now are in the pipeline. So, ये जो study अब हो रही है, वो secukinumab की हो रही है in patients with GCA. तो हमारे patient को क्या करना है भाई? जल्दी से कोई उठे. बाबर, why? Good. Just has aortitis. And if you want to prove it, तो क्या करोगे? CT angio. Excellent, very good. PET scan भी हो सकता है. ठीक है जी, हमारी ये पेशेंट जो है इसका अभी हमें पता चल गया कि इसको, you know, she had PMR, but she has occult GCA. So here's the summary, and I'm sure that this will help you to know that you have to differentiate PMR and GCA. They are overlapping, they are present. In majority of the patients, both are present, and you have to take a very good history, a very good clinical examination, and you have to, if you are a physician, you don't play around with your prednisone. A fast, strict clinic should immediately recruit these patients and start them on high-dose prednisone, a biologic, which in our case is what I told you, and sirolimus बहुत नहीं मिलती तो हम methotrexate से गुजारा करते हैं, and that is recommended. And hopefully, when you know that your patient is not getting better, always revisit. Always revisit your diagnosis. You can't keep on saying, फिर से बिठा लें, पूरी history करें, पूरी examination करें, पूरे सवाल पूछें, and you'll find a solution. So we know this. ये सबको पता है कि क्या कर रहे हैं. Very, thankful to Allah ji that He gave us the capacity to make Arthritis Care Foundation, myself, Sumaira Ahmed, and I think इसके बगैर मुझे लग रहा है कि एक लम्हा का ऊपर साया है, और ये उन लोगों का जो की डोनेशन से हम टेस्ट भी करा लेते हैं. एक पेशेंट का पेट स्कैन हो जाए तो दूसरे को कहते हैं वो बेचारा इंतज़ार कर रहा है, उसका अल्ट्रासाउंड ही करा दें. तो इस तरह से कर करके माशाल्लाह वी आर टीचिंग, ट्रेनिंग, पेशेंट केयर, and inshallah we have laid the foundation of an Institute of Rheumatic Diseases, which is going to be run by the ACF board, inshallah ta'ala, where treatment for everybody, because मैं कहती हूँ कि जब हम अपने बच्चों के लिए अच्छा सा rheumatologist, अच्छा सा hospital, अच्छी सी जगह ढूंढते हैं, तो फिर बाकी बेचारों का क्या कसूर है? Don't we owe it to them? And can we ever say to them that no, एक पर्ची लिख लो, दवाई नहीं ले सकते हो, मैं क्या करूँ? अब मैं शुरू से from the day one, जब से मैंने यहाँ पे क्लिनिक शुरू किया था, अगर किसी को पर्ची हाथ में पकड़ानी थी तो नेक्स्ट क्वेश्चन था कि क्या दवाई ले सकते हो, क्या टेस्ट करा सकते हो, नहीं करा सकते तो भाई फिर आप भिखारी बने, उसके लिए लें, उसका कहीं से इलाज कराएं. सो थैंक यू सो मच. ये ज़रा ज़्यादा जज्बाती हो के बोल. थैंक्स अ लॉट.
Giant cell arteritis and PMR represent overlapping manifestations of a shared inflammatory disease spectrum. Making careful evaluation is essential to ensure timely diagnosis and appropriate management. Thank you, Dr. Nigat, for sharing your valuable feedback with us today. We're grateful for your contribution to our conference. Despite significant advances in therapeutic options, suboptimal adherence to long-term treatment remains a major barrier to achieving sustained disease control in rheumatology. Factors such as medication side effects, patient perceptions, and healthcare system challenges contribute to poor compliance. Addressing adherence is therefore essential to bridge the gap between treatment efficacy and real-world outcomes, ultimately improving patient quality of life. We are pleased to introduce Dr. Asher Ahmed, a dedicated and accomplished rheumatologist. With MRCP and specialty certification in rheumatology from Royal College of Physicians, UK, he brings strong international training and expertise. Currently serving as Associate Professor at Dr. Ziauddin Hospital, Karachi, Dr. Asher is committed to enhancing patient care and advancing clinical practice. We look forward to his valuable insights on this critical issue. Please welcome Dr. Asher Ahmed on the stage.
So, good afternoon, dear colleagues. It's indeed a great privilege and an honor to stand in front of you, and thank you to Dr. Aflaq and the rest of the organizers for inviting me to deliver this talk. The thing is that no matter how much rheumatology has advanced, and all day we've talked about different treatment strategies, all the newer options that are available, and treat-to-target strategies, dose reduction strategies, but all of that will fail if your patient doesn't take the treatment. So, adherence is a major issue. Basically, we'll just go through what adherence is, what do we mean by the concept, and basically what are the factors behind it, what do the studies say about it, and what can be done. So this key paper highlights that medication taking behavior has been inconsistently described over time using terminologies like compliance, concordance, and adherence. Now, Horn and colleagues here, they argue that the traditional idea of compliance is actually outdated and should be replaced with more patient-centered approach. Because compliance is basically when the patient passively follows the doctor's orders and is sort of a more paternalistic view. When you use the term adherence, then this is a little bit better, which means that the degree to which the patient will follow the agreed treatment plan, but again, this is more clinician-driven. The most important concept is actually concordance, which is a shared decision-making process between the doctor and the patient, and it tends to recognize the patient's beliefs, preferences, and there's a degree of autonomy in that decision-making process. Another paper by Vrigens and colleagues addresses this long-standing problem of inconsistent terminology in medication-taking behavior. The authors then proposed a standard taxonomy that defines adherence as a dynamic process rather than a single behavior. It's divided in 3 phases: initiation, implementation, and discontinuation. Initiation, obviously, is the process of starting the prescribed medicine. Implementation is how closely the patient's actually following the dosing, the prescribed dosing regimen over time. And discontinuation is when the patient actually makes a decision to stop the medication completely. Additionally, they also define persistence as the duration of time from initiation until discontinuation. So this framework actually helps to distinguish different types of non-adherence, whether the patients actually never start, they do not take the medicine correctly, or whether they stop early, and allows for more precise measurement and more targeted interventions. Medication non-adherence also has a major economic impact, costing around 125 billion euros annually in Europe and about USD 100 billion in the United States. In the UK alone, it contributes to approximately 500 million pounds per year in additional NHS costs, and this is due to hospitalization and extra treatment. This highlights that despite advances in therapy, non-adherence still remains a key barrier to effective disease control. And particularly, this is true for chronic conditions like rheumatoid, like rheumatic disease in general. So in rheumatology, it's actually the perception that drives adherence rather than the prescription. Medication adherence varies widely and can be strongly influenced by patient beliefs, including the perception of treatment effectiveness, its necessity, and the patient's actual confidence in therapy. Now, reported adherence to biologic DMARDs ranges broadly from 30 to 89%, and this is across various studies. In the ARCO study, for example, adherence to subcutaneous biologics and oral DMARDs was relatively high at about 85.7%, but this study also suggested that simpler dosing schedules, particularly less frequent administration, are associated with better adherence. Overall, the findings highlight that beyond clinical efficacy, patient perceptions, treatment satisfaction, as well as the convenience of taking the medicines are key determinants of adherence in rheumatic diseases. Another 6-month prospective cohort study by Balsa et al. Highlighted that adherence is not determined by a single factor, but it's rather influenced by a combination of patient level, treatment level, as well as healthcare system level variables. The key findings showed that psychological factors such as patients' beliefs, again, we've talked about this, the perceived necessity and concerns about adverse effects were strong predictors of adherence. Clinical factors alone were less predictive as compared with behavioral and perceptual variables. At the treatment level, simpler and more convenient regimens were associated with better adherence. And at the system level, stronger patient-physician communication, follow-up support played adherence, supported the adherence outcomes over the 6-month period. And again, overall, this study reinforced a multi-level model of adherence in rheumatoid arthritis, where psychological, therapeutic, and healthcare-related factors interacted to determine the medication-taking behavior. So as we look at these factors in more detail, we see that patients with rheumatoid arthritis have a significantly increased risk of mental health disorders, and especially things like depression and anxiety. Now, this was a UK-based cohort study by Jacob and colleagues, which showed that approximately 30 to 36% of patients with RA developed depression within 5 years of diagnosis, with a higher risk observed in women as compared to men. This highlights that depression is a common as well as early complication in rheumatoid arthritis. In addition, a qualitative study by Mackin and colleagues explored anxiety and depression in RA patients, found that these conditions are frequently under-recognized in clinical practice, and this is because patients tend to face stigma and perceive that clinicians prioritize physical disease over mental health problems. Again, barriers to recognizing mental health disorders in clinical practice include limited consultation time as well as fragmented care, while improved communication and continuity with healthcare providers can be associated with better management of psychological problems. Overall, both of these studies emphasize that depression and anxiety are highly prevalent in rheumatoid, often go undetected, and strongly influence both disease burden as well as healthcare system, as well as the healthcare delivery. Now, the reason this is important is because depression in patients with rheumatological disorders is associated with reduced motivation, a sense of hopelessness, and impaired self-care. And this can then lead to poor medication adherence, missed appointments, as well as overall lower engagement with their treatment process. Depressed patients are about 2 to 3 times more likely to be non-adherent. Anxiety can also negatively impact adherence by increasing the fear of side effects, particularly with biologic and immunosuppressive therapies. And this can result in both delayed treatment start as well as premature discontinuation. Treatment fatigue can often develop in patients on long-term therapy, especially DMARDs, whether they're biologics or synthetic or the targeted synthetic variety, and this can lead to psychological exhaustion. This can again reduce the motivation to continue treatment, especially in chronic lifelong conditions like rheumatoid arthritis. The perception of illness can also play a key role, as patients tend to underestimate the disease severity, or they may have doubts about the effectiveness of their treatment, and are then more likely to reduce adherence or discontinue therapy. Overall, addressing psychological comorbidities is absolutely essential to improving adherence, disease control, and quality of life in patients with rheumatic disease. Economic factors obviously play a major role in determining whether patients can initiate and maintain long-term therapy. This is true in places where the expenses are out of pocket, as well as where they are funded either by charity or by governments. And a key issue is the high cost of advanced therapies, particularly biologics and targeted synthetic DMARDs. As we know, these treatments are often required long-term to maintain remission or low disease activity, and this significantly increases the burden on patients financially. As a result, cost can become a direct barrier to treatment initiation as well as its continuation and adherence in routine clinical practice, and this is something that we all see on a day-to-day basis. So when applicable, and this is especially true for our patients with corporate cover, insurance and reimbursement policies can become key determinants of access to advanced therapies in rheumatic diseases. Limited coverage can delay treatment initiation, can also interrupt ongoing therapy, or force patients to switch to less effective alternatives due to just cost constraints. The same thing applies to patients who access therapy through charitable funds, whether these are government or whether these are private. In addition, medication availability in Pakistan is another major barrier because we are a resource-limited healthcare system. Biologics and even other DMARDs may not be consistently available due to supply chain issues, and this can also lead to treatment interruptions, discontinuation, and subsequently flare-up of the long-term disease. So economic barriers are especially pronounced in low to middle income countries where patients often face high out-of-pocket healthcare expenses and limited access to biological therapies. In addition, weaker healthcare infrastructure can restrict the regular follow-up and consistent availability of the medications. Clinically, these financial constraints then contribute to poor adherence, discontinuation of treatment, and suboptimal disease control, which ultimately increases the disability and the long-term healthcare costs down the line. Therefore, it's important to address economic barriers through improved insurance coverage, patient assistance programs. Broader access to affordable therapies is also essential to optimize adherence and long-term outcomes in rheumatic disease. So this is actually data from a conference abstract which was presented at the ACR Convergence 2023. The All of Us cohort is a large NIH-led database which combines the healthcare records and patient-reported data from over 1 million individuals, and this is designed to study real-world health outcomes. This slide actually shows the financial burden of medication in patients with systemic rheumatic disease, and this is compared to those without. So about 18.2% of patients with rheumatic disease did not obtain their prescriptions due to cost, versus 11.6% of those without rheumatic disease, and this highlights a clear gap of affordability. Cost-related non-adherence is higher across all the rheumatic disease groups, particularly in conditions like lupus and ankylosing spondylitis, according to this data. Many patients were also using certain cost-cutting strategies, such as skipping doses or delaying their prescription refills, and this may also impact their disease control. And this is also likely compounded by overall lower socioeconomic status in patients with rheumatic disease as compared to those without. Clinically, this emphasizes the need to consider affordability when prescribing and to actively address barriers to adherence. Again, this cross-sectional study by Kumar et al. Examined the sort of determinants of adherence to DMARDs, and they compared whether there is there's a racial and ethnic difference there as well. So they compared a white British and a South Asian population with rheumatoid arthritis. Now this study highlighted that adherence is influenced by a combination of demographic, cultural, as well as psychological factors, and the key findings showed that beliefs about medication, particularly the perceived necessity and the concerns about harm, these were all strong predictors of adherence in both ethnic groups. However, cultural and language difference also influenced understanding of disease and treatment. For example, with South Asian patients being more likely to report communication barriers and differences in health beliefs, and this affected their adherence. The study also emphasized the importance of doctor-patient relationship, their trust in healthcare providers, and the effective communication in improving adherence across both populations. Overall, the findings tend to suggest that while core psychological drivers of adherence are constant, the cultural context and communication also play a crucial role in shaping medication-taking behavior. Getting to the specific drugs, this study evaluated adherence to methotrexate in rheumatoid arthritis patients, and it found that while the overall adherence was generally good, many patients actually had limited knowledge about the drug and its side effects, and over half of them experienced side effects. Better adherence and awareness were associated with factors like higher education, age, and longer disease duration, and were linked to improved quality of life. So still sticking to methotrexate, this prospective cohort study examined adherence to methotrexate in early rheumatoid arthritis over a period of 6 months. A significant proportion of patients were non-adherent early in the treatment, showing that adherence issues begin at initiation. The strongest predictor of non-adherence was patient belief about the medication, particularly their concern about side effects and doubts about the actual need for treatment. Clinical factors like age and disease severity were actually less influential. Non-adherence was mainly intentional, and this was driven by concerns about harm and the perceived lack of benefit from methotrexate, rather than forgetfulness. Overall, the study highlights that improving adherence requires addressing patients' beliefs and concerns through education and shared decision-making rather than just focusing on disease activity. Again, this real-world study shows that switching methotrexate from oral to subcutaneous tends to improve adherence, with higher adherence increasing from about 42 to 51%, and nearly 60% of patients improving or maintaining strong adherence. Now, importantly, this translates into better clinical outcomes, with remission or low disease activity more than doubling to over 50%, along with improved quality of life, even without the need to escalate dose, just by switching the mode of therapy. The key message is that changing the route of methotrexate is not just a pharmacokinetic decision, it's a practical strategy to improve adherence and outcomes in routine clinical care. So this study actually evaluated whether the FDA black box warning on JAK inhibitors affected medication adherence in rheumatoid arthritis patients as compared to TNF alpha blockers. And the overall message was that adherence and discontinuation rates were similar between JAK inhibitors and TNF inhibitors. And importantly, the black box warning did not significantly impact adherence or persistence. This real-world study evaluated adherence and drug survival of biologics and tofacitinib in patients with rheumatoid arthritis, including both treatment-naive and treatment-experienced groups. And overall, adherence was generally good across therapies, but notably about 50% of treatment episodes were discontinued or switched. And this highlighted challenges with long-term persistence. Drug survival actually varied by agent. Some biologics like adalimumab, certolizumab, and rituximab showed higher discontinuation risk as compared to etanercept, suggesting differences in real-world durability. Patient factors also mattered because older age was associated with actually better persistence, while comorbidity and healthcare utilization predicted discontinuation. Overall, the study emphasized that beyond efficacy, real-world drug survival and patient factors are key in treatment selection and personalization. So this prospective study evaluated the adherence to subcutaneous anti-TNF therapy in rheumatoid arthritis patients and specifically examined the impact of injection site experience. Over a 12-month period, around 22% of patients were non-adherent, indicating that adherence remains a significant issue even with biologic therapy. Importantly, injection site pain and skin sensation were strong predictors of adherence, highlighting that the physical experience of injecting oneself plays a critical role in treatment continuation. Other factors influencing adherence included age, disease activity, and comorbidity burden, with older patients and those with higher disease activity showing a better adherence. Interestingly, there was no significant difference in adherence between the different anti-TNF agents, which suggested that the patient experience rather than the actual drug choice might have been the driving factor here. Again, another cross-sectional study by Joseph Smolin and colleagues evaluated real-world adherence in patients with RA, psoriatic arthritis, and ankylosing spondylitis. Now, across rheumatoid, psoriatic, and ankylosing spondylitis, adherence was consistently higher with TNF-alpha blockers as compared with conventional DMARDs or NSAIDs. In rheumatoid, adherence was highest, which was over 75%, in patients receiving combination therapy with TNF blocker and a conventional DMARD, suggesting that patients are more likely to continue treatment that is providing better symptom control. The difference was especially marked with ankylosing spondylitis, where conventional therapy had very low adherence. So to NSAIDs, people showed very low adherence. Overall, the key message was simple. Patients are more likely to stick to treatments that are more effective and better tolerated. And so improving adherence is not just about counseling, it also depends on choosing the right therapy. Another cross-sectional survey showed that most biologic-naive patients prefer IV over subcutaneous biologics, regardless of their gender. However, the age influenced their preference, because patients that were between the ages of 40 to 60 tended to prefer the subcutaneous therapy, probably because of its convenience and more in keeping with an active lifestyle, whereas the older age group patients strongly favored IV treatment. And this was possibly due to perceived safety of a monitored environment and physician supervision. The key takeaway again is that route of administration should be individualized, as patients' preferences can vary, and that this can actually impact adherence and satisfaction. Slightly old data, but still relevant. The Danish DanBio registry evaluated the adherence and effectiveness of biologic monotherapy in rheumatoid arthritis. Approximately 1 in 5 patients receive biologic monotherapy. Importantly, drug survival, which can be taken as a proxy for adherence, was around 70% at 2 years, which is quite robust for real-world practice. Adherence was broadly comparable across the biologics, with one key exception. Infliximab showed significantly lower persistent, possibly reflecting problems with immunogenicity as well as infusion-related factors. Crucially, biologic monotherapy still achieved clinically meaningful remission and sustained response, suggesting that combination therapy is not always required for effectiveness. And again, overall, this data supports that biologic monotherapy can be a practical and durable treatment strategy, especially in patients who cannot tolerate methotrexate. Data from a large US claims-based study evaluated adherence and costs in over 10,000 patients with rheumatoid arthritis taking biologic therapy, initiating biologic therapy. And the key finding here is that adherence was suboptimal, only about 46% at year 1 and just 34% at 2 years. Importantly, adherence was strongly linked to treatment effectiveness. Patients who responded in the first year had nearly 60% adherence at year 2, compared to only 32% in non-responders. IV biologics were associated with better adherence, likely reflecting supervised adherence and structured dosing. Interestingly, higher adherence was associated with higher healthcare costs, driven primarily by ongoing biologic use. This qualitative study explored how rheumatologists perceive medication adherence in patients with rheumatoid. It found that clinicians rarely use formal adherence assessment tools, instead only rely on patients' self-report. And they use clinical judgment as well as disease control markers. But adherence was viewed as a multifactorial issue, which involves patient-related factors like their beliefs, fears of side effects and costs, physician-related factors like communication and education, and system-level barriers like access and time constraints. Rheumatologists noted that non-adherence is often underreported by patients, making it difficult to detect it in clinical practice. Overall, the study highlights that improving adherence requires patient-centered, multidisciplinary approach focused on education, communication, and simplifying treatment wherever possible. So, what strategies can we use to improve adherence in patients with rheumatoid? Effective communication and active patient engagement tend to build trust, and they improve understanding of the treatment plan. Shared decision-making, or the concordance model, which we talked about, is particularly important, as involving patients in the treatment choices increases their confidence and their commitment to therapy. A multidisciplinary approach, including rheumatologists, nurses, pharmacists, and allied health professionals, can provide consistent education and reinforcement of adherence behaviors. And finally, closer monitoring of high-risk individuals or patients that can be more vulnerable will allow early detection of non-adherence and timely intervention, ultimately improving the long-term outcomes. Again, improving adherence in rheumatology also involves expanding and individualizing the treatment options, offering different routes of administration like oral versus injectable therapies can improve patient acceptability. Simplifying regimens through once-daily dosing or longer-acting formulations can further improve the treatment burden. Tailoring therapy according to patients' lifestyle and preference while optimizing the dosing to minimize the side effects, also supports better long-term adherence. In addition, practical and technology-based interventions can play an important role. Simple tools like dosette boxes, pill organizers can help older patients manage complex treatment plans, while these days mobile apps provide reminders and tracking support. More advanced smart adherent technologies like the electronic pill dispenser and wearable injection devices offer real-time monitoring and can significantly enhance medication taking behavior. Patients should be educated about the consequence of poor disease control, including disability and long-term functional decline. Access to reliable educational resource and patient support groups can further reinforce understanding and engagement with therapy. At a broader level, health policy and socioeconomic support are essential. Reducing medicine costs, improving access to biologic therapy, and strengthening the healthcare coverage can significantly improve treatment continuity. Policy-level awareness and support systems are also needed to address structural barriers to adherence. Overall, improving adherence requires a multi-dimensional approach that integrates patient education, simplified treatment strategies, technology-based support, systemic healthcare, and policy intervention. So to conclude, how do we bridge the gap between therapy and outcomes? Non-adherence remains a major under-recognized barrier to optimal disease control in patients with rheumatic disease. Despite all the advances in conventional DMARDs, biologic DMARDs, and targeted synthetic DMARDs, outcomes are often limited by patient-related factors rather than the efficacy of the drug. So adherence is multidimensional, which is influenced by psychological factors, economic constraints, treatment-related issues, as well as patients' beliefs and awareness. So thank you very much for your time. If there are any questions, I'm happy to take them. Thank you. जी बिल्कुल नहीं, you're absolutely right. And मतलब दुनिया भर में तो पेशेंट सपोर्ट ग्रुप्स मौजूद होते हैं, लोकल लेवल पे आई एम श्योर लोगों के होते हैं इस तरह की स्टोरीज, टेस्टिमोनियल्स. We tend to advertise as well. And I was just speaking with Dr. Babar this morning, and I think even from a PSR viewpoint, I think this is one of the things, Dr. Babar, that you were discussing this morning, which is your idea of patient engagement. So I think patient stories are very important because doctors का मतलब obviously patient डॉक्टर रिलेशन इज़ वन थिंग, बट टू एक्चुअली हियर फ्रॉम समबडी हुज टेकन समथिंग और वो इम्प्रूव हुआ हो, तो वो एक रियल वर्ल्ड एग्जाम्पल होती है जिसका के इम्पैक्ट बहुत ज़्यादा हो सकता है. सो थैंक यू वेरी मच. एब्सोल्युटली राइट. एग्रीड. थैंक यू.
To conclude, ultimately enhancing treatment adherence not only leads to better disease control and functional outcomes, but also significantly improves the overall quality of life for individuals living with chronic autoimmune conditions. Thank you so much, sir, for such an enriching session. It is a privilege to introduce Dr. Aisha Mahmood Ali Malik, consultant rheumatologist. She holds FCPS qualifications in both medicine and rheumatology, along with MRCP, reflecting her strong academic background and clinical expertise. Dr. Malik is recognized for her dedicated patient care and contributions to the field of rheumatology. We are honored to have her as the moderator for this panel discussion on the topic of IGRA as a traditional screening test for latent TB. We look forward to an insightful session under her guidance. Please welcome on the stage Dr. Aisha.
Thank you, Madam, for your kind words. So, Assalamu alaikum, everyone. I welcome you all. I know this is the last session for today's conference, and it's been a long day, and we've been running behind time now. So, today we are joined here by a galaxy of esteemed professionals who are experts in their respective fields, and I'm sure with their wisdom, we shall gain insight into today's session, which is of considerable clinical and public health importance. As we all know, it's about IGRA as a traditional screening for latent tuberculosis in TB endemic settings, before the initiation of biologic DMARDs, evidence, guidelines, and real-world dilemmas. I would first like to introduce our panelists. So we are honored to have with us Professor Dr. Nigat Mir, who is pioneer of rheumatology in Pakistan. Her distinguished career is marked by excellence in clinical practice, academic leadership, and contribution to advancing rheumatology care. She is diplomat of the American Board of Internal Medicine and Rheumatology, and fellow of American College of Rheumatology and the American College of Physicians. Currently, she serves as chair of Department of Rheumatology at National Hospital and Medical Center. Madam, please join us stage. And this way. So it is my pleasure to introduce our next panelist, Dr. Ashraf Ali Khan. Dr. Khan is an infectious disease specialist who holds diplomat certification from the American Board of Infectious Diseases and Internal Medicine. He currently serves as assistant professor at Rashid Latif Medical University and practices at Hamid Latif Hospital, Lahore. With his dual expertise in infectious diseases and internal medicine, Dr. Khan brings a vital perspective to today's discussion. Thank you, sir, for joining us. I would like to welcome our next panelist, Dr. Khalid Pervez Babar. Dr. Khalid is a highly accomplished physician and academic, currently serving as professor and head of the Department of Rheumatology at University Medical and Dental College, Faisalabad. He holds distinguished qualifications including FCPS in medicine and rheumatology and MRCP from Ireland. Moreover, he has certification in musculoskeletal ultrasound from the Canadian Rheumatology Ultrasound Society. His areas of expertise include autoimmune and inflammatory disorders, musculoskeletal diseases, and advanced rheumatology practices. Thank you, sir, for joining us. We are also honored to welcome Professor Dr. Muhammad Irfan Malik, who is Professor of Pulmonology, Critical Care and Sleep Medicine at the University of Lahore. He is a distinguished pulmonologist with extensive expertise in respiratory medicine, critical care, and sleep medicine. He holds FCPS Pulmonology, FRCP, FCCP, and is a European diplomat in respiratory medicine. He serves as international advisor to the Royal College of Physicians and Surgeons, Glasgow, UK. With his deep expertise in respiratory infections and guideline development, Professor Malik brings valuable insights to today's discussion. Thank you, sir. So our next panelist, and it's a pleasure to invite him, as always, Professor Dr. Babar Salim, who is currently serving as head of the department at Fauji Foundation Hospital, Lahore. He is FCPS Medicine and Rheumatology, along with fellow of American College of Rheumatology. Moreover, he also holds a master's degree in pain management. Thank you, sir, for joining us. So we know with the advent of the biologic therapies, management of autoimmune and inflammatory disorders have markedly improved patient outcomes. However, these agents are accompanied by a well-organized risk, which is the reactivation of infections like hepatitis and latent tuberculosis, particularly in regions like ours, where TB still remains highly prevalent, necessitating robust strategies. Studies have inculcated in rheumatologists as if it is a sin to start biologic DMARDs without testing for latent TB and hepatitis, though in previous years, these DMARDs have been used not only by the rheumatologists, but by even other specialty healthcare providers without prior infection screenings. Many of these patients fared well, either because they were fortunate enough not to have the infection or because they simply didn't show clinical decline. However, the modern clinical practice has firmly established that initiating biologics without first testing for latent TB and hepatitis is a serious medical oversight. So in view of this, we have formulated a panel for discussion to get on either side of this gray area. So our discussion will highlight the nuance of applying global evidence to local realities to ensure that patients receive both effective treatment for their rheumatological conditions and protection against TB reactivation. So, sir, we do have so we will have some questions, and we would ask our experts for their opinion on them.
Aisha, sorry to interrupt. Can we have Professor Tafazul here also?
Oh, yes, sir, please join us. Professor Dr. Tafazul Haq. Thank you, sir, for joining us. So, do you need... So I think we do have that in front. So this was a little bit of a panel discussion theme. So do we have this on the main board? This is not coming on the main board. We can't see it up on the screen, so nobody can see the questions there. Oh, so that's it. Okay, it's right here. Sorry. So our first question is, should universal latent TB infection screening be performed before biologics in endemic countries, or should it be risk-based? Sir, thank you, sir.
When you say that in endemic countries, it means that the risk of tuberculosis is already very high in these countries, for example, ours. So the latent tuberculosis recognition is an important indication for not starting biologics or JAK inhibitors or any other synthetic targeted DMARD because these endemic cases can become overt and can lead to tuberculosis activation. Right. This is my...
Bismillah, madam. Thank you so much, and very pertinent question. Pakistan ranked 5th in high burden country for tuberculosis. So I, as a pulmonologist, fully endorse this statement. Before the start of biologics, you should screen for latent tuberculosis. And the rough estimation is almost 26 to 40% of our population have latent TB. Mm-hmm. So our consensus is this. Thank you.
Echo कम हो सकती है माइक की please.
So in short, the testing is must before the start of biological agents. It's especially true for the anti-TNF agents because the TNF is a granuloma stabilizing agent, and if you are inhibiting it, so it leads to reactivation. So it's especially true for anti-TNF agents. And among anti-TNFs, monoclonal antibodies, especially, they are more likely to reactivate pulmonary tuberculosis. So, in short, we have to go for testing before start a biological agent.
Thank you so much. Very important subject which you brought up. What I want to say is that these guidelines are not meant for us. Yes. We have tuberculosis in our country. There are like, 10 cases maybe, 10, 20, whatever cases per 100,000 population. Over here, we have like 100 times more.
Absolutely.
And so there's absolutely no reason that we should apply their guidelines to our region at all. और मैं वैसे because I have to leave early also, मेरा ख्याल है कि जो एक treatment में आप एक patient के you will spend when that patient develops tuberculosis, that amount spent 3 months, 6 months therapy or whatever therapy it is, and it can even be, life-threatening if they develop miliary tuberculosis. It's not worth it. So there's no question. I think the question is that everybody has to be screened. Everybody, the test, which test, yes, whatever the cost, somebody has to pay it. Yes. And has to be treated. And we have to offer them the treatment and the test, and it's up to them, educate them, and we cannot simply miss anybody with tuberculosis, latent tuberculosis. That's what I think about it.
Thank you, Dr. Aisha. I think that all the rheumatologists would say that definitely screen every patient who has to be given on biologics or JAK inhibitors. I think the perspective of Dr. Saab is very important because we need to know, is it, so I'm more interested to see, listen to his
perspective on this.
Okay, so there are 5 questions in front of me that I'm reading right now. Should universal LTBI screening be performed before biologics in endemic countries, or should it be risk-based? So the answer to that would be that I think patients with rheumatic diseases or rheumatoid diseases are a high-risk group because they're going to go on biologics at one point in their life or another. So if they are expected to go on biologics, I would consider them those high-risk patients that WHO recommends should be screened for TB, latent TB. And if it's found to be there, then they should be treated before they go on the biologics.
And like Madam is also, sorry.
I'm sorry, can you hear me?
Sorry, and we were just saying, and like ours is in endemic areas, so I think everybody is a high risk here for...
Everybody is high risk, but you know, we have a 23 crore ki abadi. We're not going to be able to you know, provide latent tuberculosis treatment to everybody, right? But yeah, I mean, sure.
What is, I tend to disagree, I'm so sorry. Even if you're prescribing patients prednisone, it's not even biologics, you know. So, already wo endemic area mein reh rahe, they have latent tuberculosis, and we have the figures in front of us which tell us kitni yahan pe latent tuberculosis hai. Even if you ideally steroids और methotrexate other DMRs के साथ भी हमें स्क्रीन करना चाहिए, तो चलें छोड़ दिया हमने एक तरफ रख दिया. But with all these biologics, can you imagine one breadwinner, गरीब है, ड्राइवर है, जो मर्जी है, आपने उसको मिस कर दिया, वो तो 6 महीने के लिए बेचारा breadwinner भी नहीं रहेगा, उसकी वो सारों को spread करेगा. So I don't. This is an excellent debate, but I think there is no debate. They have to be screened. Whatever, this should be our recommendation. This should be our guidelines. That yes, screen everybody and find out the means. We should have guidelines and we should pressurize the government, everybody. देखिए ना, हम अगर खुद ही बैठ जाएंगे पीछे और हम कहेंगे कि नहीं जी कोई ज़रूरत नहीं है, जब होगा तब देख लेंगे, इतनी कॉस्ट नहीं है. भाई आप गाइडलाइंस बनाएं, प्रेशर ग्रुप्स बनाएं, अब जाएं, मिलें सारी पार्लियामेंट से, सबसे मिलें, हेल्थ मिनिस्टर से मिलें, एज अ ग्रुप मिलें. दिस इज़ हाउ थिंग्स चेंज इन USA एंड अदर कंट्रीज. तो हम क्या अगर कह देंगे कि हमने नहीं करना, तो फिर तो ठीक है, गए फिर सारे.
डॉक्टर निकित, थैंक यू सो मच मैडम. आई फुली इंडोर्स मैडम. एक्चुअली एक चीज़ मैं आपको बताता जाऊँ कि जो शॉर्टेज ऑफ मेडिसिन इज़ नॉट देयर. The medicine to treat latent tuberculosis is freely available in almost our BHU too. Yeah. So a shortage is not an issue. In our country, as a pulmonologist, the debate was going on. We are unable to catch active TB case. तो क्या हम इनको latent TB treat करें? But the debate is over now. So the consensus is that in this scenario, that's like Madam is saying, if you are giving delta cotyl to any patient for longer period of time, so patient is immunocompromised. My patient, Pakistan rank almost 2nd or 3rd in diabetes. Yes, in obesity rank 5th, or obesity is a metabolic syndrome. So मुझे तो वैसे मेरी तरफ से अगर रिकमेंडेशन लेना चाहिए तो हम सब की भी स्क्रीनिंग होनी चाहिए for latent tuberculosis, and we should have latent TB in Pakistan treatment. So, and as far as pulmonologist is concerned, in our recent guideline, which will be launched in 2026, next month, we are recommending this for every patient to screen for latent tuberculosis. Even वो patient जिसके relative में smear 1+ आ गया है, so उनको भी latent के लिए screen करें और इसको treat करें, because जो इसकी drug है वो अब available है, और वो भी बड़ी interesting है कि you can give 2 drugs once a week for 12 weeks. So वो concept जो था कि आप 2 drugs देंगे 3 months के लिए, 1 drug देंगे 6 months के लिए, तो ऐसा नहीं है. और जो WHO है या अदर जो NGOs हैं वो appreciate करती हैं उन centers को जो इनको treat करते हैं, और they are well funded now up till now.
So Dr. Irfan, another question, so should we screen even beyond the biologics then, since our patients, they are immunosuppressed, they are on high-dose steroids, they are on JAK inhibitors. So should this screening even go beyond just the biologics then? So,
I have a question from Dr. Irfan. Dr. Irfan, the risk of reactivation of tuberculosis is highest around 5 to 15% if the patient is using infliximab. That is the highest, okay? And it is lowest with the JAK inhibitors, followed by conventional synthetic derivatives. So with the JAK inhibitors, it is around 2%, 1 to 2%. And with the conventional synthetic, it is less than 1%. So in the general public, endemic area, the prevalence would be probably in points. The risk of reactivation is in.
Let me tell you the statistics in Pakistan. Unfortunately, we don't have the true statistics, but rough estimation is almost 26 to 40% population is having latent TB. Remember, one patient who got tuberculosis, which is active TB, he spread 10 to 15 patients per year. Okay. Or let me complete. In our estimation is 6 lakh patients should be diagnosed tuberculosis in Pakistan per year as per the incidence and prevalence जो हम show करते हैं. We are treating only almost 3 lakh or 3,50,000 patients, and the pool is increasing from the birth of Pakistan. So we have a significant number of pool of active as well as latent tuberculosis. The incidence which you are telling to me is not of Pakistan. This is very important. This country has TB and we ranked 5th in high burden country. We have to understand this. Yes, 5th in the world.
इसके ऊपर अगर ये है कि for example हम asymptomatic patients comes with latent TB positive, we start treating it. ठीक है. Risk versus benefit tolerance के बारे में आपके क्या?
So this is an important question. Like as doctor, you are asking me, and I am telling you, we have a drug which you should give once a week for 12 weeks. 2 drugs, once a week for 12 weeks. Fair enough. Very good compliance. So data is available.
कल को फर्ज करें उसको tuberculosis होती है, तो वो those medicines are going to be working.
This is important. So if you treat latent TB, the chance of reinfection with the same bug, ये याद रखें, usually they have a span of 8 to 10 years. So you save 8 to 10 years. Remember this, okay, when you treat latent tuberculosis. But the problem is reinfection because we have so much exposed to the patient. इसके बारे में कोई data available नहीं है. So at least we know for a decade this patient is safe. We are exposed to such patient a lot. Did you ever went for IGRA? I did. I have treated myself. I was positive. Yes. I have 6 PGs right now. 2 PGs are positive and they are taking treatment. So we are in favor.
Right. So the other question that comes in here for us in our resource limited setting gets cost versus the benefits now. So how do we? It's the cost of the test to do this, the IGRA itself.
It's a difficult question to answer, by the way. We have 2 guidelines which we follow. One is by WHO, and WHO, because of some circumstances, they rank both tests equal. उसकी मैं logic आपको समझा देता हूँ. They say TST because it's relatively cheap, and IGRA is costly. ये सबसे बड़ा issue है. But अगर आप CDC को पढ़ेंगे तो वो IGRA को ऊपर ले जाता है. उसकी एक वजह ये भी है कि because we are BCG vaccinated nation, तो BCG vaccination अगर होगी तो TST जो है वो falsely positive आ सकता है. One thing is ये. TST का सबसे बड़ा issue ये है कि how to give TST is a challenging thing. How to measure it, and you have to call the patient after 48 to 72 hours. और ये हमारे लिए पहले ही नॉन एडहेरेंस की सबसे बड़ी इशू है कि हम फॉलोअप कैसे करवाएं. सो इस वजह से कंसेंसस स्टेटमेंट इस पे हमारी तरफ से IGRA ही है. अब IGRA कॉस्ट की वजह से TST से इन्फेयर हो रहा है और कोई इसमें लॉजिक नहीं है.
We all agree on that. IGRA is superior to TST in TB endemic.
Yeah,
BCG
because
vaccinated population. Sir Ashraf.
Let me just finish before.
Sorry,
TST has actually a 70% sensitivity. There are, 30% false negative. Okay? And on the other hand, false positive in case of BCG vaccination. And sometimes people who are on immunosuppressants, they can also have false negative. a PPD skin test. And I remember I have been doing personally PPD test because it was not done by the lab technicians, because it has to be so superficial, even you can physically see the needle inside the skin when you, intradermal injection. So it has to be, so that's why there are a lot of issues with the TST. So IGRA is superior nowadays.
अब मेरा ख्याल है कि जी आप देख लें कि आपका जब एक पेशेंट को टीबी होगा तो उसकी कॉस्ट क्या है, ठीक है जी, आप उसको क्यों नहीं देख रहे? एंड आई वंडर कि हम लोग जो इतने माशाल्लाह इतनी बड़ी सोसाइटी ऑफ रूमेटोलॉजी है, आपकी सोसाइटी है, इन्फेक्शियस डिजीज़ की सोसाइटी है, तो हम क्यों अपने पेशेंट्स को डिप्राइव कर रहे हैं इस टेस्टिंग से, और क्यों डिप्राइव कर रहे हैं हम उनको इस सब चीज़ों से? व्हाई कांट वी मेक अ टास्क फोर्स एंड मीट एंड मेक श्योर दैट दीज पेशेंट्स गेट द टेस्ट एंड दे गेट ट्रीटेड? देयर आर सर्टन हॉस्पिटल्स, कुछ सर्विसेज हैं जो जिन्होंने कहा है कि हम इकरा करा लेंगे आपको. सो हमने ऐसे तो नहीं छोड़ देना कि अच्छा ठीक है जी ना कराओ क्योंकि रिस्क जो है वो इतना है और वो इतना है. मतलब वी नो, अब मेरे पास फिगर्स हैं, आई एम सॉरी मुझे भेजने थे आपको, कि एक पेशेंट जिसको टीबी हो जाती है वो कितना कॉस्ट पड़ता है टू द इकोनॉमी, treating that patient, then screening all their relatives, and then can the kids go to school? If the kids go to school, फिर वो कितना, it's like a vicious circle. So it's a public health issue. So you can't just wrap it under the carpet and say कि जी कोई भी नहीं, हाँ हमने risk benefit. I don't believe in this. I think we should find means to do it. Sorry.
Yes, sir. Dr. Ashraf.
Which, sir?
Dr. Ashraf was going to give your opinion before.
Yeah, I totally agree with everybody that IGRA is the test that should be done and not TST, if that's your question. Yeah.
Yeah.
It's the preferred test.
Can IGRA can be positive in endemics? False positive हो सकता है?
मैं कुछ और कहना चाह रहा था. मैं ये कह रहा था कि आइग्रा जो है वो हर जगह अवेलेबल नहीं है, ठीक है. सो इट मे बी सुपीरियर टू टीबी स्पॉट टेस्ट, बट इट्स नॉट डन बाय एवरी लैब. एंड सेकंड, not all labs are reliable. So all labs are not reliable in giving you the exact result. Even the best labs are seen to make mistake. So isn't it better that if you have a clinical suspicion as well as a test, then you start treating, as Dr. Saab said, weekly dosage and do it for 12 weeks and then start the biologic. Make it as easy, convenient and less costly for the patient and for the economy itself.
Yes. So if data is not present over here in Pakistan or other countries like us, is there any data जो by default किसी को दे दी गई हो ATT, sorry, biological DMARDs या targeted synthetic DMARDs, और वो convert हो गए हो tuberculosis? क्या हमारे पास ऐसा कोई data है?
Data नहीं, but we saw a lot of patient. We saw a lot of patient जिसमें biologics थी. On one evidence which I can share was जब एक्टेमरा बेतहाशा यूज़ हुआ कोविड में, तो हमने देखा एक्टेमरा टोसिलिज़ुमैब है, ये उतना हम इसको नहीं, IL-6 एंटागोनिस्ट है, इसकी वजह से भी, और उसमें एक ड्रग बरसटनी भी दी गई थी इफ़ यू रिमेंबर, तो इसके साथ भी हमने रीएक्टिवेशन देखी है. ठीक है.
अच्छा सर, यहाँ पर एक मैम दो चीज़ें मेरी हैं. एक तो देखें, हम लोग डे टू डे प्रैक्टिस में भी एनकाउंटर सच पेशेंट्स हु हैव बीन गिवन टारगेटेड सिंथेटिक DMARD सिंस लॉन्ग by orthopedic surgeons, and I should not take the names, okay, everybody is. लेकिन हमारे पास तो ऐसे पेशेंट्स नहीं हैं जिनको ओवर ट्यूबरक्लोसिस हो गई हो. नंबर वन, हमने अभी तक ऑब्जर्व नहीं किया. ओके मैम, ठीक है, आप शेयर कीजिएगा. दूसरा ये कि मैम मेरा खुद का ये टॉपिक है, मैं इस पर रिसर्च कर रहा हूँ और इंशाल्लाह मैं इसको पब्लिश भी करवाऊँगा, जिसमें मेरे पास जो आइग्रा पॉजिटिव पेशेंट्स आए हैं उनको मैंने टारगेटेड सिंथेटिक DMARDs भी दिए हैं और बायोलॉजिक्स भी दिए हैं. तो 3 साल हो गए, 3 ईयर्स से मैं उनको वॉचफुल उनके लिए. अभी तक किसी की जो है ना ट्यूबरक्लोसिस नहीं आई है और मैं उनको फॉलो अप कर रहा हूँ. जी जी, लेटेंट ट्यूबरक्लोसिस की ट्रीटमेंट दी है जिनको, और जिनको नेगेटिव थे आइग्रा, उनमें भी अभी तक मेरी ऑब्जर्वेशन में एक भी पेशेंट नहीं उनको ट्रीट किया, और अभी तक 3 इयर्स तकरीबन हो गए हैं। ठीक है, लेकिन मैम हम ऐसे पेशेंट्स देखते हैं जो कि टोफासेटेनिब ले रहे हैं बहुत अरसे से, लॉन्ग पीरियड ऑफ टाइम, बाय जनरल फिजिशियन एंड ऑर्थोपेडिक सर्जन्स। अभी तक आप कह रही हैं अपना ज़रूर शेयर कीजिएगा, लेकिन हमारे पास अभी तक किसी के पास ट्यूबरक्लोसिस नहीं है। सर ये क्वेश्चन आपको भी है सर, काइंडली।
जी मेरे पास
Dr. Ashraf, can we have your take on this too?
देखिए ये आप जो सवाल कर रहे हैं ना वो ये है कि अगर एक आपको ऐसा मरीज मिला है जिसमें इग्रा पॉजिटिव आ गया है और आप उसको ट्रीट किए बगैर बायोलॉजिक्स पे डाल देते हैं, दैट्स रॉन्ग. You know, why is this test available to us? Why do we do IGRA? IGRA is to identify those people with latent tuberculosis infection that need to be treated before they go on biologics. अगर आपने वो करना ही नहीं है तो फिर छोड़ें उसको, यानी फिर टीबी को छोड़ देना कि हाँ वो भी कोई एक है इन लोगों में रिस्क. अगर if you believe that TB is a risk for patients who are eventually going to be immunosuppressed, then you better look for the TB before starting immunosuppressive agents.
Yeah. Okay.
आइग्रा पॉजिटिव में तो हम we treat the patients first, लेकिन this has been observed lot of time. कुछ मुझे लोग अगर सपोर्ट करना चाहें कि orthopedic surgeons and GPs prescribe tofacitinib, which is notorious to reactivate latent tuberculosis. This is what we know. Without doing IGRA टेस्ट उनका हुआ ही नहीं होता. तो अगर हम उसमें देखें तो उसमें कोई हमें ट्यूबरक्लोसिस नहीं मिलती. तो मेरा पॉइंट ये,
एक डॉक्टर इरफान और एक डॉक्टर अशरफ, प्लीज आप लोग बताएं, आप लोगों के पास ऐसे पेशेंट्स
मैं आपको आई कैन शो यू 2 पेशेंट्स. वन अभी जो मैंने देखे हैं पिछले 3 days में, ठीक है. वन पेशेंट अनफॉर्चुनेटली रूमेटॉइड आर्थराइटिस वाज बीइंग ट्रीटेड बाय ऑर्थोपेडिक सर्जन, और उसको ये टोफासेटिनिब दी हुई थी, और उसका जो लंग है टोटली इस वक्त बायलेटरल कैविटेटरी डिजीज़ के साथ है. उसकी वॉशिंग की है और उसका स्मीयर 3+ है, जीन डिटेक्ट हाईली डिटेक्टेड है. अब ये इसको स्टार्ट किए हुए ऑलमोस्ट 3 years हो चुके हैं, और इस वक्त वो इस कंडीशन में मेरे पास आई है, ठीक. और शायद रूमेटॉइड आर्थराइटिस उसका बर्न आउट नहीं है, लंग उसका बर्न आउट हो चुका है, और ये इन्फेक्शन आगे कितनी गई होगी इसको येट टू फाइंड. सो आई थिंक जैसे सर ने कहा कि वी आर श्योर दैट इग्रा इज़ डन टू रूल आउट लेटेंट टीबी. इस पर हम कंसेंसस कर चुके हैं. जो कन्फ्यूजन हमारी ये है कि किन को करवाना चाहिए. गाइडलाइन कहती हैं हाई रिस्क हम आइडेंटिफाई करने की कोशिश करते हैं, बट वी आर लिविंग इन एंडेमिक कंट्री, एवरीबॉडी इज हाई रिस्क कंट्री प्रूवन अदरवाइज. हम यहाँ पे थोड़ी कंफ्यूज हैं. लेकिन वंस इग्रा इज पॉजिटिव, देयर इज नो डाउट दैट यू शुड ट्रीट दिस पेशेंट irrespective of the whatever you want to give. This is what I say. You are talking about the biologics. I say whatever you want to give. So I will treat it if IGRA is positive, irrespective of the symptom of the patient. This is my take message.
Right. So we did so with
डॉक्टर इरफान, हाई रिस्क को उन्होंने फर्दर रीडिफाइन नहीं किया. व्हाट इज अ हाई रिस्क?
हाई रिस्क
लाइक प्रिजनर्स, इट्स नॉट जस्ट एंडेमिक.
हेल्थ केयर वर्कर, प्रिजनर्स, जो CLD केसेस, CKD केसेस, इम्यूनोसप्रेसिव, दे आर ऑल हाई रिस्क पेशेंट. Diabetes, that is what I am saying. Diabetes, we rank 2nd or 3rd in diabetes. Even don't underestimate obesity, please. मैडम ये उसमें भी दे रहे हैं, अब स्किन में भी दे रहे हैं, मैंने देखा. हाँ जी बिल्कुल मैंने देखा. यस सर.
Can I ask a question? Yeah. Can I ask a question? If a patient is treated for active pulmonary TB some years back, and now he is completely free of active TB, and we are now planning to start biologics, and we went for IGRA and it came out to be positive, should we again treat it as latent TB or not if the X-ray is normal?
Okay. That is a good question. If this patient was treated for TB and it was documented TB with a gene expert or whatnot, then and she finished her course of 6 to 9 months of treatment, or however long the treatment was, then she would be IGRA positive. I mean, so if this was recent, then she probably doesn't need to be treated for latent TB. But if she is on biologics now, and it's been a couple of years since she's been on biologics, she should be considered for treatment for, or at least evaluated for possibility of treatment again. Because, you know, in 1 or 2 years, she may well be exposed, and that's a time period that we should look for TB in these patients.
Thank you, sir.
So even though she was IGRA positive, there may not be a need to, you know, repeat the IGRA because it would be positive. And with immunosuppression, actually, the IGRA can be an invalid test in these patients. So I would suggest that clinical evaluation be done. If she's free of TB, if she hasn't been exposed, if her risk didn't increase again, which means if she wasn't exposed to somebody with TB again, then you know, we have to keep an eye on that and treat her accordingly. Yeah, because you know, she can become reinfected with TB, and then that TB will reactivate.
Okay.
Thank
you, sir. So I want to elaborate a little bit more. There are two phenomena in TB. One is reinfection, one is reactivation. So once we treat any patient of tuberculosis, statistics which I am giving you is of latent TB management. Once you treat the case of latent TB, we think that 10 years patient is safe for reactivation. Now you are living in a country which is endemic. The chance of exposure, reinfection, this data unfortunately is not available. So as sir said, in my point of view, too, that IGRA will be non-specific and sensitive in that patient. So clinical symptoms along with X-ray chest is a very valuable thing, which can help you to assess that patient is either reinfected or not.
But if the patient is not reinfected and we are again, the IGRA is only positive. So for how long is the period? Because this happens in the clinical practice that a patient is on biologics, we treat that patient, and before that IGRA was performed and that was negative. After some time, patient was in remission, we stopped the biologics or taper the biologics. And after some time, we are again in need of restarting the biologics. So should we again go for the IGRA testing?
After 1 year.
Okay. Yes. After 1 year.
1 year we should.
नहीं, अगर वो पहले टीबी की मरीज नहीं थी और उसका पहले इग्रा नेगेटिव था, then you will repeat in 1 year, or 2 years is also good. 1 to 2 years, yeah.
Thank you, sir. That's a very valid point, because a lot of time our patients are on therapies and then a year or two down the lane, they do become positive. Yes. So the next question, so do you think we need to do the IGRA while the patients are on biologics on yearly basis?
Yes.
So should the IGRA be repeated?
That was one of the questions that you sent us on WhatsApp, and I kept thinking about it. You know, I think it does make sense to retest them. You know, if the IGRA has been negative, and you suspect, I mean, in a highly endemic country like Pakistan,
absolutely.
And I was looking at estimates. If you compare estimates between the United States, where we look up to, you know, in terms of guidelines and whatnot, their incidence is two patients per 100,000 population. Right. And in Pakistan, it's 200 to 300 per 100,000 population. Absolutely. So there's your difference in incidence in Pakistan. So based on where we're living, which is Pakistan, we are in a high-risk country. And so these patients who go on biologics are much higher risk than the general population. Right. So if that answers the question.
So what you're saying is that patient's IGRA was negative and has been on biologics, so we need to retest them again. Yes. But doesn't biologic treatment suppress the response to IGRA? So why do we have to test again if they are not having any symptoms? And they have,
That is a good question. But, you know, the IGRA test is there to help us figure out if they've been infected with TB, right? That's right. So it's besides clinical aids, you know, clinical evaluation, absolutely, and considering the clinical risk of the patient and getting a chest X-ray done to rule out active TB, we have this test available. So why not utilize it? you know. So what I'm trying to say is that even if they are immunosuppressed with the biologics, there's a good chance that if they've been exposed, they will give you a positive IGRA test. You know, why miss that opportunity, right? There is a possibility that these people will give an invalid or indeterminate test, in which case the thing to do is, the guidance is to repeat the test if it comes back as indeterminate. The reason is that indeterminate tests point out that the patient is immunocompromised and they didn't give a good mitogen reaction. There's a nil and a mitogen and a TB, right? There's three things.
Yeah.
So the mitogen reaction is not good enough, and the lab will point that out on the test, that, you know, this patient didn't have a good mitogen reaction. So then you can individualize what you're going to do. You know, you can either think that, okay, this patient was exposed and, to a tuberculosis patient, or they're considered high risk for some other reason, then you go ahead and treat them.
For the indeterminate result as well.
And then you can, not take in consideration the indeterminate test and consider it invalid, right? And still treat the patient. So that'll actually increase your own clinical specificity as a clinician, you know, that, okay, the patient was immunocompromised, the test is indeterminate, but I still think she is high risk, so I'm going to treat her again with the 12-week course, whatever Dr. Saab ne jo bataya. Rifapentine and isoniazid.
I have a point, and please correct me if I am wrong. This IGRA has actually two types, quantiferon and T-spot test. So it is mentioned that if the patient is already on immunosuppressants, go for T-spot test, because that the quantiferon gold test may be, inconclusive. So is it okay?
I think they both have that same problem, you know, that they can be invalid because of immunosuppression. So the concept of the T-spot test is that it's based on the number of spots that are positive. So the number of spots that are considered IGRA positive is 8 spots. But if it's somewhere between 5 and 7, it's indeterminate or borderline. So that does get into the unclear test result. So I mean, if it's borderline, you know, because they can give you, in case of T-spot, they can give you 4 types of results: positive, negative, borderline, or indeterminate. So if they're borderline, they may well be latent TB positive.
Yeah.
So you have to repeat that. But the indeterminate is indeterminate. It's an invalid test, and you have to think of it as somebody who's giving a negative reaction because of immunosuppression.
So, right, I think a lot of things have been clarified on this. I think this is a very important topic that we talked about. So, yes, again, take-home messages, clinical history, but we're not doing the tuberculin skin test. I think everybody has been against, and we are doing IGRA here. And it is preferred in BCG vaccinated populations, and we need to be cautious of the false negatives in immunosuppressed patients, and then treat them. We think that they have TB on the basis of clinical history. And the important thing is to adapt the guidelines to local TB burden and the resources. And I think in the end, we need to have our own guidelines for treating our patients in our resource-limited country here in Pakistan for ourselves. Thank you so much, all the panelists, for your valuable opinion. And I think it's clarified quite a lot of things that we had in our mind today. Thank you. Thank you so much.
That was some fascinating and insightful panel discussion. Thank you to our esteemed speakers for their valuable contribution. I would like to call upon Professor Tafazlul Haq Mahmood along with Dr. Aflaq Rashid for a souvenir presentation to our panelists. Dr. Nigat Ahmed Mir, Doc Dr. Ashraf Ali Khan. Dr. Khalid Pervez Babar. Professor Dr. Irfan Malik. Dr. Babar Salim. And the moderator, Dr. Aisha Mahmood Malik. Ladies and gentlemen, as we near the end of this conference, we would like to honor our organizers who have made this conference possible. Please join us on stage to receive your well-deserved recognition. Professor Dr. Tafazle Haq Mahmood, the Chief Organizer. Dr. Flaq Rashid. Dr. Masuma Hashmat, Chairperson, Scientific Committee. Dr. Adnan Waji Akhtar. Dr. Myra Khalil, Conference Organizer. Dr. Wasif Aslam. Dr. Amara Tasadduq. Dr. Komal Khan. ये नहीं है. Dr. Atikur Rahman Bhatt. Dr. Sara Kazi. Dr. Aisha Khalid.
Dr. Zainab Malik. Dr. Maham Dilshad.
Dr. Noor Mariam. Amna Alam. Miss. Is she somebody? Mrs. Samreen Nadia. Mrs. Aisha Hussain. Mrs. Rebecca Salim. Mrs. Sonia Khurshid. Mrs. Hafsa Tahir. Mr. Hasib Khurram Akhtar. Mr. Rizwan Butt. Mr. Rizwan Butt. We are delighted to honor our pharmaceutical partners without whom this conference wouldn't have been possible. Mr. Mushtaq Ahmed from Hirani's Pharmaceuticals. Mr. Umar Ilyas from Hilton Pharma. Mr. Sakhawat Ali from Mactar Pharma. Mr. Zishan Aslam from Organ Care and Cure Pharma. Mr. Liaquat Riaz from High Noon Pharma. Mr. Faisal Hussain from Feroson's Laboratories Limited. Gentech Pharma. Gentech Pharma. Mr. Atif Latif from MedArt Pakistan. Mr. Mauz Arshad from Nabi Qasim Pharma. Mr. Imran Yusuf from Navu. Mr. Gul Abbas from Pfizer. Mr. Muhammad Usman from Farm Evo. Mr. Ikram Ishaq from Searle Pharma. Sulas Pharma. Tuzman. Getz Pharma. Thank you so much, everyone, for attending this conference and making it successful. We are grateful for your presence at our conference, and we appreciate the enthusiasm you have brought to our discussions. We look forward to reconnecting with you next year.